Now I call upon Dr. Shubha, Head of the Department, Pediatric Medicine, to deliver the welcome address. Over to you, ma'am.
Thank you, Dr. Sangeeta. On behalf of the Department of Pediatrics, so I wish to thank Tamil Nadu IAP chapter and also SRMC for permitting us to host this webinar. So I wish to thank Dr. Ramesh Babu, who is the President of the Tamil Nadu chapter, and also Dr. Rajendran, who is the Secretary of the Tamil Nadu chapter, for helping us to host this CME. And also I would like to welcome Dr. Jayakumar, who is the Head of Department of Nephrology in SRMC. And also I think the senior faculty as Dr. Chellam Kripakaran, who are there. I think their interest in the CME gives a great impetus for us to hold further CMEs because their encouragement is always welcome. So why is this? And I also have to thank Dr. Sangeeta for working tirelessly for putting all this together, because it is to getting so many speakers. And I think some ways as COVID has taught us this online platform, sometimes it's better that we are able to get people from different parts of the country to participate. So I wish to thank all the speakers who have readily agreed to participate in this CME from various cities. So nephrology is, a knowledge about nephrology is very important for any general pediatrician. So even though they may not be a specialized nephrologist. So I can tell this sort of personal experience that I briefly worked with Dr. Namalwar, who's a well-known pediatric nephrologist, senior most pediatric nephrologist in Tamil Nadu. So it kind of sensitized me to, made me aware of renal diseases which exist in children. I think till that time, as a part of the training or other, this one, usually we do not focus that much on nephrology in general pediatrics. So it sensitized me that, okay, these problems exist, and that picking up these problems are sometimes difficult because, most of them may be asymptomatic, mildly symptomatic. So a lot of these things get missed until they go into very advanced disease. And also picking up this early, and early referral and early treatment of some of these conditions, the outcome can be made better. So that is why as a general pediatrician, it is very important to be aware of all these diseases And with advancing technologies and advancing diagnosis, a lot of times, like now antenatally, they pick up renal problems. So most of the times you're not very sure what you're supposed to do, how you're supposed to counsel. So I think definitely this full day CME would definitely help all pediatricians in understanding a little bit of nephrology and also how to manage the manage cases, even though they are not the complicated cases, but at least the simple cases, what to do, how to follow them up. Definitely this CME is going to go a long way in improving the awareness of kidney diseases. So once again, I wish to welcome all the delegates, all the participants on behalf of SRMC and also the IAP Tamil Nadu chapter. Welcome once again to this CME. So I do not wish to take any more time. So you can go straight away to the program and we can definitely learn a lot from this program. Welcome once again.
Thank you very much, ma'am. I'm delighted to welcome our IAP President, Professor Dr. Ramesh Babu. Sir is currently working as head of the department and SNCU Nodal Officer, Department of Pediatrics, Government Dharmapuri Medical College and Hospital. He is the President IAP TNSE 2022. He was instrumental in establishing IAP Dharmapuri branch in 2012. He held various posts like President, Secretary and Treasurer posts in IAP Dharmapuri. He was the key person in getting many Central IAP Day celebration awards for IAP Dharmapuri branch. He was the recipient of Dr. V. Balagopal Raju Active Pediatrician Award. He was also awarded Best Doctor in 2018 on Doctor's Day by Tamil Nadu government for service to rural children in Dharmapuri districts. Interestingly, he was also the recipient of District Collector's Award for maximum number of blood donation. He has donated 47 times so far. Welcome to you, sir.
Thank you, madam. Thank you for the nice introduction. Respected organizing chairpersons, Professor Shubha madam, Professor PRC sir, Professor Ramesh Babu Srinivasan, and respected organizing secretaries, Dr. Sangeeta, Dr. Dinesh, and Dr. Subbarao, and respected dynamic secretary of IAP Tamil Nadu State Chapter, Dr. Rajendran sir, Treasurer Dr. Gopal Subramanian sir, and respected delegates who are attending today's virtual CME on kidney health for all, and respected postgraduate students who are all attending this CME. It is a pleasure for IAP TNSE to join with you all in this CME on pediatric nephrology organized by Srihar on behalf of the World Kidney Day celebrations. I know Dr. Sangeeta, who from the days when she was doing a CRRI, while at the time I was assistant professor, I know the hard work and the efforts she would have put for this CME. My appreciations to Dr. Sangeeta. The topics are well chosen, both for the postgraduates as well as for the practicing pediatricians. It will be very useful for all of them. I wish the CME to be a grand success. My one appeal to the faculty of Srihar, please enroll your postgraduates to become a member of Central IAP so that they can be aware of IAP as well as its activities, both academic as well as non-academic activities, and they get benefited by it. Thank you for giving me this opportunity. Once again, thank you all and wish the CME a great success. Thank you. Thank you.
Good evening, Sangeeta. I am actually unable to join with the video. You have to allow me.
Yes, sir. I'll.
Hello.
Good morning, sir.
Yeah.
Can you able to join now, sir?
I could not. Yeah, now. Yes. Yes.
Yes, sir.
Okay.
I'm very glad to welcome Dr. Rajendran, our Honorary Secretary IAP, to facilitate the gathering.
Yeah, thank you, Dr. Sangeeta, and because good morning to everybody. On behalf of IAP TNSC, I thank Dr. Sangeeta to invite this wonderful CME, and I thank Dr. P. Ramachandran sir and faculties, and I thank our President Dr. Ramesh Babu, who has given permission to make these arrangements. And once again, on behalf of IAP TNSC, I thank one and all for this wonderful opportunity. Thank you very much. Thank you.
Not more. Rajendran sir is always busy, and he is making us busy at the weekend with the regular IAP academic activities for the UG, PG students and the practitioners as well. He is always giving help hand for the CMEs to conduct the webinars and the links. He is always approachable. Thank you very much, sir. Without much delay, we will start the session. Now I call upon Dr. Ramachandran to moderate the session. Kindly bear for a few minutes. Dr. PRC sir is joining in few minutes.
Good morning. Am I audible?
Yes, sir. You're audible.
Yeah. Can we start, Dr. Sangeeta, or we already started?
Yes, we have started the program, sir.
Okay.
For the academic sessions, we can start, sir. I welcome Dr. Ramachandran, Professor Pediatrics, Associate Dean for the PG Studies, SRMC. Sir has been an editor-in-chief for IJPP from 2014 to 16. And sir's areas of interest is critical care, infectious diseases, and nutrition.
Good morning.
Dr. Namalva, sir, was joined earlier with his grandson's name, so we couldn't recognize. Welcome, sir. Welcome, Nedunjalian, sir, also.
Very good morning. Very good morning to Dr. Nedunjalian and all the people who have been joining this session. Now, these are two important topics we are going to have in this session. One is on nephrotic syndrome, which will be the talk will be delivered by Dr. Sangeeta, who is a pediatric nephrologist currently working in Sri Ramchandra Medical College and Research Institute, Srihar. And she takes care of a large number of children with renal problems. And I don't know whether after she has come here or I don't know, to be getting nephrotic syndrome. Not only that, I don't know whether because of a referral center it's like this. I am not seeing now children with nephrotic syndrome who respond that frequently. Probably they go to the general pediatrician, may not be coming to the institution. That may be a factor. But of late, we are seeing more number of dependent, steroid dependent and steroid resistant. I don't know whether it's my perception or it's a fact. Now to tell us about many aspects of childhood nephrotic syndrome, now we call upon Dr. Sangeeta, who will be talking to us on nephrotic syndrome in childhood. Dr. Sangeeta.
Thank you very much, sir. A very good morning again, one and all. Today's topic is nephrotic syndrome management guidelines in children, the updated guidelines 2021. Let's move on to the topic. This is a 4-year-old boy who presented with a periorbital puffiness, abdominal distension, and leg swelling and reduced urine output for a week duration. He did not have any hematuria, fever, rash, or arthralgia. On examination, his vitals are normal. He had periorbital puffiness, ascites, bilateral pitting pedal edema with a normal system examination. Urine routine showed nephrotic range proteinuria 4+, RBCs were negative, less than 5. Spot urine protein creatinine ratio was very high, 15.9. CBC, renal function test, and electrolytes were normal. Albumin was very low. Hypoalbuminemia was there, and hypercholesterolemia was documented. X-ray chest and MAN2 were normal. Ultrasound showed normal sized kidney sizes with the evidence of ascites and pleural effusion. So the diagnosis here is nephrotic syndrome, first episode. So how do we define this nephrotic syndrome? Children who are presenting with heavy proteinuria of 3+ or 4+ on urine protein, or more than 1 gram per meter square daily in 24 hours urine protein, or more than 40 milligram per meter square per hour, or in spot urine protein creatinine ratio of more than 2, we call them as nephrotic range proteinuria. It's very cumbersome to collect 24 hours urine protein in children, so we even diagnose nephrotic syndrome with spot urine sample. Along with that, hypoalbuminemia, serum albumin of less than 3 with the edema will be the manifestation. All of them will be having serum cholesterol of more than 200. Hypercholesterolemia is also one of the features of nephrotic syndrome. How do they present? The onset of edema will be gradual. They will have oliguria. If it worsens, they can present with breathlessness. Gross hematuria is not common. It can be there in less than 5% of children. Microscopic hematuria in up to 20%. Hypertension can be there in up to 5% of children. 2 to 10 years of age with a male predominance is usually there in childhood nephrotic syndrome. More than 90% will be idiopathic, and in only 5 to 10% of children can have systemic illness like SLE, HSP, and other vasculitis. 80% will be having minimal change nephrotic syndrome on renal biopsy. 8% can have FSGS and mesangial proliferative glomerulonephritis each. Coming to the pathophysiology of nephrotic syndrome, the glomerular filtration barrier is very important. It is inner side lined by fenestrated endothelium, followed by the glomerular basement membrane and the outer epithelium or the podocyte. Any disruption of these three layers, disruption of the glomerular filtration barrier, can cause nephrotic syndrome. Apart from that, T cell dysfunction, production of circulating factors, genetic mutation like nephrin podosin, also B cell involvement can cause nephrotic syndrome. What are the causes of edema in nephrotic syndrome? We have two theories. One is underfill theory. According to this theory, the hypoalbuminemia is decreasing the intravascular oncotic pressure, which will shift the fluid to the extravascular compartment and intravascular volume depletion. This may lead to activation of renin-angiotensin-aldosterone system, inhibits the atrial natriuretic peptide, and it activates the sympathetic nervous system, and release of ADH will happen. This finally lead to salt and water retention and edema. Whereas in overfill theory, this nephrotic syndrome is edema is believed to be due to enhanced distal tubular sodium and water reabsorption. They will also have renal resistance to atrial natriuretic peptide. This will lead to intravascular volume expansion and increased intravascular hydrostatic pressure and edema. So according to this overfill theory, the main mechanism is increase in sympathetic nervous system activity, ANP resistance, increase open channel probability of ENaC, increase number of activity of sodium potassium ATPase channels. Do we do second line investigations in all nephrotic syndrome patients? No. It will be mandatory only in some specific situations. Whenever you are suspecting some secondary causes, you will do complements C3C4, antinuclear antibody, anti-dsDNA, and ANCA. Hepatitis B, C, anti-HIV antibodies if you are suspecting some secondary causes. Genetic mutation analysis, especially when a child is presenting in less than 1 year and more than 10 years of age. Renal biopsy only in certain conditions like persistent microscopic or gross hematuria, acute kidney injury not attributed to hypovolemia, systemic features fever, rash, arthralgia, low complementemia, initial steroid resistant nephrotic syndrome, or children who are going for late steroid non-responder prior to starting calcineurin inhibitors or reduced kidney function during the CNI use. These are the indications for kidney biopsy. Coming to the general management guidelines of nephrotic syndrome, we always advise them normal salt with a balanced diet and adequate protein. Reduce the salt only when the child is having massive edema. The fluid restriction to insensible water loss in case of severe edema, and previous day's output plus insensible water loss in case of moderate edema. Diuretics will be indicated whenever the child is having moderate to severe edema, more than 7 to 10% of body weight. Albumin infusion can be used whenever the child is having resistant to the combination of diuretics. We use 20% of albumin, 0.5 to 1 gram per kg, maximum is 100 ml. That we have to give importance for treatment of the associated infections. Allow the children to have full activity unless they are sick. Coming to the specific management of first episode of nephrotic syndrome, as per Indian Society of Pediatric Nephrology guidelines, prednisolone is the drug of choice. The dose is 2 mg per kg per day, maximum of 60 mg. Will be followed by 1.5 mg per kg per day on alternate days for next 6 weeks. Then it will
10:30 10:30 to 11.
According to the KDIGO guidelines, this dosage at the end of 12 weeks will be tapered and stopped over the next 2 or more weeks. You have to check for remission at the end of 2 and 4 weeks. This boy, our case, attained remission after 2 weeks of initiating steroids and he completed the course of treatment. But after 2 months, he presented with the recurrence of edema, which was precipitated by LRI. He had a 4+ proteinuria, nephrotic range proteinuria again by UPCR. Serum albumin was low, cholesterol was high. So here the diagnosis is nephrotic syndrome, first relapse. Even after treating the infection with appropriate antibiotics, he had persistent proteinuria. So we started him again on steroids. This time for the relapse, we treated him with a daily dose of steroids till remission. Usually it will take 10 days to 14 days. It will be followed by 1.5 mg per kg per day on alternate days for 4 weeks and stopped. So the total duration for relapse treatment would be 5 to 6 weeks of steroids. Unfortunately, this boy developed 4 episodes of relapses in the next 1 year duration. So here our diagnosis will be changed to frequently relapsing nephrotic syndrome. What is the definition of FRNS? 2 or more relapses in the first 6 months after stopping the initial therapy, or more than 3 relapses in any 6 months, or more than 4 relapses in 1 year. We can term them as having FRNS scores. STNS, steroid-dependent nephrotic syndrome, is defined as 2 consecutive relapses when on alternate-day steroids or within 14 days of its discontinuation. Steroid-resistant nephrotic syndrome is defined as absence of remission despite therapy with a daily prednisolone 2 mg per kg per day for 6 weeks. How are we going to manage these children with the FRNS and STNS? The first choice would be slow tapering of steroids and maintain them on low-dose steroids. The 0.5 milligram to 0.7 milligram per kg on alternate days for 6 to 12 months. We have to maintain the threshold around 0.5 to 0.7. If the threshold exceeds more than 0.7 milligram per kg, you have to go for alternative therapy. At the same time, look for the steroid toxicity, like hyperglycemia. It will be defined as fasting blood glucose of more than 100 and random blood glucose of more than 140 with a HbA1c of more than 5.7. Also look for other features of toxicity like obesity, short stature, raised intraocular pressure, cataract, myopathy, osteonecrosis, or psychosis. Whenever you're keeping the child on steroids, always supplement oral calcium 500 to 800 milligram per day and vitamin D 400 to 1000 international units per day. What are the other alternative drugs we have? The first drug is levamisole. It is an immunomodulator which will be given on alternate days for 1 to 2 years. But whatever the alternative therapy we are starting, we have to start the child on steroids. Once the child attains remission only, we can start the child on alternative therapy. Along with that, usually steroids also will be continued for 9 to 12 months with the slow tapering of the dose. What are the adverse effects of levamisole? Leukopenia, flu-like symptoms, liver toxicity, convulsions, and skin rash. So we have to check total counts, liver enzymes every 12 to 16 weeks. The next drug is cyclophosphamide, which is a cytotoxic drug. It will be given for 12 weeks with the dose of 2 to 2.5 milligram per kg per day. It should not exceed 168 milligram per kg per cycle. Along with that, prednisolone also will be given in the tapering dose. The adverse effects of cyclophosphamide include leukopenia. So whenever the counts are less than 4,000, you have to stop the medication. Other adverse effects include hemorrhagic cystitis, alopecia, nausea, vomiting, and gonadal toxicity. Mycophenolate mofetil is the next drug we have. The dosage is 800 to 1000 milligram per meter square for 1 to 2 years, along with the tapering dose of steroids. The adverse effects of MMF include GA discomfort, diarrhea, and leukopenia. So in them also, we have to monitor the total counts every 4 to 8 weeks. And the treatment is withheld if the count falls below 4,000. What is the role of calcineurin inhibitors? We have cyclosporin and tacrolimus. This prevents the T cell activation and also stabilizes the podocyte actin cytoskeleton, thereby reduces the proteinuria. Indication being FRNS, STNS, and steroid-resistant nephrotic syndrome. Both the drugs can cause renal dysfunction, so we have to monitor the RFT, electrolytes, blood sugar, magnesium, and drug trough levels. The adverse effects include hyperglycemia, hypertension, hyperkalemia, neurotoxicity, hirsutism, and gum hypertrophy. Tacrolimus is preferred over cyclosporin in children because of lack of cosmetic side effects. The another last drug is rituximab. It is an anti-CD20 monoclonal antibody which selectively targets CD20 positive B cells. It restores the T regulatory cell population and upregulates their function, thereby prevents the production of cytokines and suppresses the circulatory permeability factors. The indications being difficult to treat steroid-dependent nephrotic syndrome and FRNS, SRNS children who are not responding to calcineurin inhibitors. The dosage is 375 milligram per meter square once a week for 2 or more doses to achieve the CD19 levels of less than 1% of leukocytes. They can have infusion reactions, flu-like symptoms, infections, restrictive lung disease, progressive multifocal leukoencephalopathy at a later date. So coming to the complications of nephrotic syndrome, we can divide this as disease-related and drug-induced complications. They can develop edema, and that ascites can present as a culture medium and can develop peritonitis. Other infections like pneumonia, thrombophlebitis, hypocalcemic tetany, deep vein thrombosis, cerebral venous thrombosis due to volume depletion are common in children with nephrotic syndrome. Whenever they present with these complications and nephrotic syndrome, we call them as complicated nephrotic syndrome relapse. Drug-induced complications we already discussed. What is the role of stress dose steroids in nephrotic syndrome? Children who are on more than 20 milligram or 2 milligram per kg of steroids in the last 1 year for more than 2 weeks are susceptible to adrenal crisis during stress like surgery or infection. So they need injection hydrocortisone 2 to 4 milligram per kg or oral prednisolone 0.5 to 1 milligram per kg should be given till the period of stress, and then we can taper it rapidly. Immunization is really important in children who are having nephrotic syndrome, but at the same time, we cannot give live vaccines during the child is on steroids. Oral polio vaccine should not be given even to the siblings of children with the active nephrotic syndrome, but killed and adjuvant vaccines when in remission or on alternate day steroids can be given. Whenever the child is off steroids, advise them varicella 2 doses at 2 months interval. Annual influenza vaccine also has an important role in these children. As they are at risk of spontaneous bacterial peritonitis with the pneumococcal bacteria, we advise them pneumococcal conjugate vaccine. Children who are less than 6 years and received 3 doses previously, administer single dose of PCV13. If they received less than 3 doses, then 2 doses of PCV13 should be given, followed by PCV23 1 dose. Children who are between 16 to 18 years, previously unvaccinated, give a single dose of PCV13 and PCV23 at 8 weeks apart. Coming to the long-term care and outcome in SSNS children who are 85 to 90% of nephrotic, the prognosis is good. They will have normal growth and development, schooling and social adjustment are ensured in them. But 50% may go for this FRNS and STNS course from this SSNS. The long-term course of the disease and response to specific drugs are variable in these groups and unpredictable, especially with a non-minimal change disease. SRNS and late steroid non-responder who are about 10% in this group, the management is really challenging in them and often frustrating for the family with a poor prognosis as they may go for chronic kidney disease. When will my child be cured? This is very difficult to answer question. When are you going to refer a child with a nephrotic syndrome to a pediatric nephrologist? As per the Nelson guidelines, as early as possible, but as per the ISPN guidelines, whenever the child is presenting with extremes of age, less than 1 year or more than 10 years, difficult to manage SDNS and FRNS course, familial or genetic nephrotic syndrome, steroid-resistant nephrotic syndrome, whether it is primary or late steroid non-responder, when I are suspecting secondary causes of nephrotic syndrome. Ultimately, the ongoing care is mainly by the pediatric nephrologist and the primary pediatrician. So whenever the child is presenting with the first episode of nephrotic syndrome, you treat them with the steroids daily 6 weeks and alternate day 6 weeks. If they are getting infrequent relapses, treat them with the steroid till they go in for remission and then start them on alternate day steroids for 4 weeks. But if they are going for this FRNS and STNS course, try to treat them with the low dose steroids with the required threshold of 0.5 to 0.7. If the threshold exceeds, then go for alternate therapy like levamisole, cyclophosphamide, MMF, or cyclosporin and tacrolimus. But whenever the child is not responding, even after 6 weeks of therapy, steroid-resistant nephrotic syndrome or late steroid non-responder, refer the child to the pediatric nephrologist for the renal biopsy and proceed further. Thank you very much. We will take up the questions at the end. Sir, can you introduce the second?
Sorry, am I audible now?
Yes, sir.
Yeah. So thank you, Dr. Sangeeta, for a very succinct and clear presentation on the management of childhood nephrotic syndrome. And as she has already said, we will take up the questions at the end of the
Sir, you're not audible, sir.
Sangeeta?
Yes, ma'am.
Can you stop sharing? I'll start sharing.
Yes, ma'am. PRC, sir. I request PRC, sir, to introduce the speaker. Okay. Dr. Sudha is the pediatric nephrologist, deputy director, Dr. Mehta Children's Hospital. Her area of expertise is nephrotic syndrome, CACUT, and CKD in children. She has 12 years of experience in pediatric nephrologist, and she has many publications in national and international journals, and written many chapters in the textbooks. Over to you, ma'am.
Thank you, Sangeeta. Thank you for the nice introduction, and congratulations on organizing this CME. So in the next 20 to 30 minutes, I would be covering about recurrent UTI. So UTI is the most common bacterial infection in children aged less than 2 years. It may be the first symptom of CACUT, with VUR being the most prevalent form. UTI affects 8.4% of girls and 1.7% of boys within their first 6 years of life, and the rate of recurrence is as high as 30%. Recurrent UTIs are a clinical challenge for all involved in care of the patient. So coming on to the definition of UTI, it is identified by growth of a significant number of a single species in a midstream clean catch urine along with symptoms. And it is considered significant if it demonstrates growth of a single bacterium with the following colony counts: any growth by a suprapubic aspirate, or more than 50,000 colony forming unit by urethral catheterization, or more than 1 lakh by midstream. By the EAU guidelines, it also states more than 10,000 with symptoms. And urine is contaminated when there is low colony counts, mixed growth, no pyuria, and no symptoms. So for recurrent UTI, different guidelines use different definitions. So in NICE guidelines, it is 2 or more episodes of pyelonephritis, 1 episode of pyelonephritis with an episode of cystitis, or 3 or more episodes of cystitis. By IAP guideline, a second episode of UTI is considered as a recurrent UTI. And these are the various factors causing recurrent UTI. It depends on the valence factors, any concurrent illness, any anatomical abnormality, and functional abnormalities, like the virulence factors being the resistance to uropathogens or inappropriate treatment, or any associated gastroenteritis or diarrheal illness, which increases the periuterus spread. And the most important being the anatomical causes like the vesico-ureteric reflux, the posterior urethral valves, and phimosis and other obstructive uropathy. And functional, which is very common nowadays, which is the bowel and bladder dysfunction. And the other important factor, which I have not put up here, is also the local hygiene. So these are the various factors which leads to recurrent UTI. And one of the commonest DDs for a recurrent UTI in our clinical practice is hypercalciuria, where they present with lower urinary tract symptoms like increased frequency and dysuria, and is often misdiagnosed for a recurrent UTI. Now, going on to the approach to recurrent UTI, I would be mainly concentrating on 3 things, which is the vesico-ureteric reflux, bowel bladder dysfunction, and urinary tract anomaly. And the other important thing is the urinary collection method and phimosis, whether we have to circumcise or not. So what is the ideal method of collecting urine in children? In toilet-trained children, yes, we can go for a midstream clean catch, but in a non-toilet trained child, it has to be a catheter or a suprapubic aspirate. And one thing which we need to remember about a back sample is this is not the ideal method for urine culture. A negative back sample rules out UTI, but a positive always does not confirm a UTI. So this is very, very important, and we need to keep this in mind. And is circumcision indicated in male children with UTI? There is evidence from observational studies that UTI incidence among boys under the age of 2 is reduced in circumcised infants, boys compared with the uncircumcised boys. And the degree of reduction is between 3 to 10-fold in all studies. And studies have shown that uropathogens in the periurethral area 3 weeks after circumcision is reduced compared with similar cultures taken at the time of circumcision. So circumcision is indicated in children with reflux and recurrent urinary tract infection. So the long-term effects of recurrent UTI is the renal scars, and this can lead on to 3 main complications: a long-term impaired kidney function, a high blood pressure, as well as complication during pregnancies. So during follow-up, what all do you have to look for? You have to monitor the growth of the child. You have to take a blood pressure at least 6 to 12 months. Get the urine analysis, a renal function, and an ultrasound done as and when required. And these are the various unproven interventions. The cranberry juice, which is not routinely suggested for the prevention of recurrent UTI in children. The meta-analysis limited to children with recurrent UTI, which found no benefit. Probiotics, which is not suggested for prevention of recurrent UTI. And in a meta-analysis comparing probiotics with placebo, probiotics did not prevent recurrent UTI. But the newer guidelines will have inclusions of all this, which is about to be published in a short time. So I'll be discussing a couple of cases which we have treated. So this is a 3.6 years old female child with grade 4 vesicoureteric reflux on the left side on regular follow-up and was on prophylaxis. She was brought with a breakthrough febrile urinary tract infection, and this is culture positive. She was admitted and started on IV antibiotics. What could be the reason for her breakthrough UTI? So as I said, now this 3 would be my main approach, whether she had a VUR, BBD, or a urinary tract anomaly. Now this child has a primary vesicoureteric reflux. So is surgery indicated in this child? Going on to the indications of surgery, which is quite controversial, but we do stick on to high-grade vesicoureteric reflux, recurrent UTI despite antibiotic prophylaxis. But this also, we need to consider the patient's age, the VUR grade severity, whether renal scars are there, whether child has a recurrent UTI, an underlying bowel bladder dysfunction. So you need to look into all this before deciding on the surgery. Just because the child has a high-grade reflux, it's not necessary that you need to go for a surgery, but you need to look into other factors and then finally come to a conclusion. Now, what is the indication for a uroprophylaxis in a vesicoureteric reflux? By ISPN guidelines 2011, grade 1 and 2, we have to give them antibiotic prophylaxis until the age of 1 and restart antibiotic prophylaxis if there is a breakthrough febrile urinary tract infection. And grade 3 to 5, the antibiotic prophylaxis is indicated up to the age of 5 and consider surgery if breakthrough febrile UTI, and beyond 5 years, prophylaxis continued if there is bowel bladder dysfunction. So coming on to the REWOOD trial, which was the largest prospective trial, the prophylaxis, they said the prophylaxis reduces the risk of recurrent UTI, but not that of the renal scarring in patients with VUR. And this difference was observed in patients with VUR grade 1 and 2, but not in the young, less than 2 with grade 3 and 4. But what we need to understand in this study is this study was not powered adequately for the renal scarring, and thus was only the secondary objective. And the primary objective of this study was to look into the recurrent UTI. And a high rate of uropathogen antibiotic resistance was observed in the prophylaxis group. So the REWOOD study supports the conclusion that routine urinary antibiotic prophylaxis is not necessary for patients with VUR. But as clinicians, what is our responsibility? It is good that we share the evidence-based results with the parents who have the right to make a choice about what is best for the children. But sometimes this is not always possible. So we also need to keep in mind the limitations of renal imaging, including renal ultrasound, VCUG, and DMSA renal scan. So in view of the REWOOD trial results, the debate on antibiotic prophylaxis should shift from no prophylaxis to selective prophylaxis in children with VUR. So this child actually defaulted the prophylaxis treatment, so was advised to restart the prophylaxis. Child is on regular follow-up with no breakthrough infections for the past 1.5 years. Now going on to the second patient, she's a 1.5 years old female child who presented with high-grade fever and was diagnosed to have urinary tract infection. The ultrasound was suggestive of a UTI, and she was started on neuroprophylaxis, but had recurrent breakthrough UTI even while on neuroprophylaxis. There was no history of constipation. So this child had two breakthrough UTIs. So this was the DMSA of the child. You could see that there is scarring in the right kidney upper pole, as well as there is bilateral grade 4 VUR. So now this child has bilateral grade 4 VUR, no history of constipation, and this child was having recurrent UTI. So surgery, we went ahead with the surgery. The bilateral coherence reimplantation was done, and the indication being the child was having recurrent UTI even while on prophylaxis, and there was no underlying bowel bladder dysfunction, and child is doing fine now. Going on to our third patient, she's a 10 months old female baby diagnosed with recurrent UTI and started on prophylaxis. The ultrasound abdomen showed features suggestive of pyelonephritis with bilateral ureterohydronephrosis. Had 3 hospitalizations for UTI in a span of 3 months. That is quite a big number for a small child, and we had a very tough time treating this child, because by the time I discharged her on oral antibiotics, that to a full dose oral antibiotics, before she could complete the oral antibiotic dosage, she will have the next episode of UTI. She will not give us any time in between, and she had 3 UTIs within 3 months, and she had no underlying constipation. This was her DMSA. The left kidney showed 43% and the right kidney showed 57%, resolving areas of pyelonephritic foci in both the kidneys. And this child had a bilateral grade 5 vesicoureteric reflux. So here is a child who has bilateral grade 5 VUR and a recurrent UTI, and she did not give us any time for reimplantation also. So we went ahead with surgery, and being a 1-year small child with having a breakthrough immediately while she's on antibiotic itself, we had to go ahead with a left ureterostomy. We gave a gap of nearly 6 months to 1 year, and then we followed it with ureterostomy closure and coherence reimplantation by the age of 2. And she is now 3.5 years and is doing well. There is no urinary tract infection after the surgical intervention. So we have seen 3 patients in this category, the VUR category. The first one who defaulted prophylaxis and is doing fine after the prophylaxis initiation. The second child with recurrent UTI with only a VUR and then underwent reimplantation. And third child who had a very, very complicated course requiring ureterostomy followed by a ureteric reimplantation. Coming on to my fourth patient, is a 3.8 years old female. This child was brought to the OPD with febrile urinary tract infection. After UTI treatment, was evaluated and found to have right grade 4 vesicoureteric reflux. The renal functions were normal, initiated on neuroprophylaxis. And after 6 months, she developed a breakthrough UTI. Now, how do we proceed? Now here, this child was constipated, does not void urine in school. She holds urine. And her ultrasound also showed bladder wall thickening, and her post-void residue was more than 20 ml. So all this suggests that this child is having a bowel bladder dysfunction. So this is here is a child with VUR with a bowel bladder dysfunction. So the bowel bladder dysfunction is the combination of both the bowel and the bladder symptoms, where the postponement of urination, it can be because of they can lead to urge incontinence, day and night time wetting, increased frequency, dysuria, hesitancy, and holding maneuvers, and avoiding the closet like standing to stool, hard stools, encoparesis, irregular timing to stool, fissure in ano, and they're poor picky eaters. So the main standard of therapy is, the most important is parent and patient education. That is one. We need to make them understand how important stooling and the bladder habits are. So we need to educate them first and make them understand that this could be the main reason for the breakthrough urinary infection. Unless until you don't educate them well, we are not going to get a good outcome. And then next is a good bladder training, a bowel training, and we need to definitely modify their diet. In this present world, more of junk food is what is preferred by children, but ensure that they get the adequate fiber, balanced diet along with a good amount of water intake, and also ask them to maintain a bowel bladder chart and regular follow-up and support. Coming on to the bladder training, the thing which we encourage in our OPD is timed voiding every 2 to 3 hours when they are awake, a double or a triple voiding, and to squat and pass urine, or at least face the closet position for obese children when they're using the Western closet, complete emptying of urine by the pelvic floor relaxation, cleanse the external genitals after micturition, and most important is to maintain a local hygiene. The bowel training is early morning stool is very, very important. An appropriate position in the closet, adequate water and fiber intake, and initiate on laxatives if required. And this is the correct position for opening your bowels. Here you could see the knee should be slightly higher than your hips. You need to lean forward and put your elbows on your knees, bulge out your abdomen, and keep your spine straight. You try to teach them this, but it's always very difficult in children. So we have treated the bowel bladder dysfunction with appropriate advice, and the child is on regular follow-up with no breakthrough infections. Now going on to my next patient, the 13-year-old female child who presented to OP with lower urinary tract symptoms and recurrent UTI. She has habitual constipation and has recurrent breakthrough urinary tract infection. How to proceed? So this is the DMSA of the child. It shows multiple foci or photopenic areas in both the poles. You could see here, and this child has no vesicular-ureteric reflux. We had done the NCU after treating her BBD. So this child has no VUR, but only a bowel bladder dysfunction and has had a recurrent UTI. So she was started on uroprophylaxis, initiated on laxatives, urotherapy, and we have trained her, and now there's no UTI for the past 1 year. So we have seen 2 patients with bowel bladder dysfunction. One was just the BBD leading on to recurrent UTI, which is very common nowadays, and BBD with VUR leading to recurrent UTI, and that is also very common nowadays in our clinical practice. Now here's patient 6. Who had an antenatal renal anomaly diagnosed at 28 weeks of gestation. The ultrasound showed bilateral enlarged kidneys with bilateral ureterohydronephrosis with bladder wall thickening. Postnatal ultrasound also showed bilateral ureterohydronephrosis with bladder wall thickening. The MCUG, which was done, showed a left grade 5 VUR, but there was no PUV. The child was started on uroprophylaxis, but child had a breakthrough UTI, underwent a diagnostic cystoscopy, and this child had a posterior urethral valve. So this is the DMSA of the child, where there's scars in both the poles of the left kidney with near normal function. Also, the child is having a left grade 5 VUR, and there was no PUV in this child by the MCU. So here's a child who has a reflux as well as a posterior urethral valve. So surgery was done, and he underwent a cystoscopic fulguration of the valves. Child is 2.5 years now, and there is no further urinary tract infection in this child. There's a 3-year-old female child who was brought to the OPD in May 2018 with history of recurrent UTI since 1 year of age, and she's 3 years now. And she was treated with 5 to 7 days of antibiotics with each episode. At presentation, she was asymptomatic. How do we proceed? On examination, the vitals were stable, systems within normal limits, and she had a palpable bladder up to the umbilicus. The ultrasound done in March 2018 showed a left kidney which is 10.8 centimeters with a bilateral ureterohydronephrosis and a bladder wall thickening with a post-void residue of 85 ml. I think by now you would have guessed what could be the diagnosis in this female child. It was a bilateral ureterohydronephrosis, bladder wall thickening, and a post-void residue of 85 and bladder palpable up to umbilicus. Yes, she had a neurogenic bladder. The MCU which was done showed a bilateral grade 5 VUR with a neurogenic bladder. DMSA shows left kidney 73% near normal function and 27% of the right kidney with reduced function with multiple sites of inflammation and scars in both the kidneys. So this is a child with a urinary tract anomaly, that's the neurogenic bladder with a secondary VUR. She was catheterized, initiated on clean intermittent catheterization and nighttime drainage, and also was started on soda bicarb supplements for low sodium. And here you could see how the creatinine has reduced, and her current creatinine is 0.54, and she is doing fine now. Now, this is my final patient. Here's a 3-year-old boy who was evaluated for short stature and bony deformity. He was evaluated by an orthopedician and found to have elevated serum creatinine and hence referred for further follow-up. Recurrent fever and receives IV or oral antibiotics for 5 days. There's a good urinary stream. Antenatal was normal. On examination, vitals were stable and child had bony deformity. Now, this child's ultrasound shows bilateral small kidneys with increased echogenicity. Both pelvic LC systems and the ureters are dilated, and there is bilateral grade 5 VUR. And here you can see the child is already into CKD with the high creatinine and the low bicarbs. And after supplementation, this was better. And this child is in CKD stage 4. This child was lost to follow-up. But is it possible that we could have managed him better? In a way, yes, because this is not the way we have to miss a UTI. But how much could we have prevented the CKD from happening? Because in utero itself, the damage could have happened. But definitely, we could have given him a better life than what he had. I think that is something which we should never miss. So, take-home message is UTI represents an important cause of febrile illness in young children. Recurrent UTI can lead to renal scarring and kidney failure. A paradigm shift has occurred from identifying children with vesicuretic reflux and prescribing prophylaxis to prompt management of urinary tract infections and identifying children at risk of developing renal scars. Children with VUR and BBD have the highest risk of recurrent UTIs, which needs appropriate management. Surgery is considered for children who develop frequent breakthrough infections despite antibiotic prophylaxis and appropriate BBD management. Circumcision is indicated in children with vesicuretic reflux and recurrent UTI. And finally, it is, and the most important is, it is the primary care pediatrician's share to appropriately diagnose and treat urinary tract infection. Thank you very much.
Am I audible?
Yes, sir.
Sorry. Thank you for joining late. There was some disruption. We listened to two wonderful talks which brought home the common problems which are encountered in pediatric practice. One is nephrotic syndrome. The second one is recurrent urinary tract infection. Both of these problems are seen by the pediatrician, but they have to know at what point of time they have to refer to the specialist and how they have to follow up these children with proper guidance and day-to-day care management, especially the problems like hygiene, bowel bladder dysfunction, how to go about. Now, there is, I saw only one question in the chat box by Dr. Nadjalian. This was on for Dr. Sangeeta on nephrotic syndrome. Can you get a child with a nephrotic syndrome without edema?
Generally, for the first episode of nephrotic syndrome, the parents would have not known much about the disease, so they present with the edema. The edema will be significant clinically, but for the relapses, whenever the child is presenting with a relapse, even for mild edema, they will be very cautious and do the urine routine, and they come to us. So during the relapse time, many children may be looking normal or will be having very mild edema. So without edema, also we can diagnose nephrotic syndrome with other biochemical features: proteinuria, hypoalbuminemia, and hypercholesterolemia. So they may not have this edema during the relapse time, sir. But for the first episode, they will usually present with the generalized edema.
Dr. Sangeeta, I have a question.
Yes, sir.
A child, the first episode of nephrotic syndrome, your treated child has gone into remission. How do you follow up? I mean, do you advise them to do the urine protein assessment of urine protein? And if so, how frequently? Before even the edema and symptoms appear, can they pick up? So what is the frequency and what is the advice given for monitoring these children?
After treating the nephrotic syndrome first episode or relapse, we always tell them to check urine routine whenever the child is getting edema or any infections. But if the child is not getting edema for the next few months, then we advise them to check every 3 months, sir. So I keep the children under follow-up every 3 months.
So we advise them only if the child becomes symptomatic, like develops an edema.
Yes.
Am I right?
Yes,
Okay.
sir.
Okay. So the other question I had for you, the observation, is it just because we are in the institution, we are seeing more of this steroid resistant and problems like this, or is it any literature which says that this problem is increasing?
Literature definitely says that the problem of steroid-resistant nephrotic syndrome and non-minimal change disease are increasing. The other point is, as you said, as it is our center is a tertiary care center, we are getting referral for the renal biopsy. So we tend to get more steroid-resistant nephrotic syndrome cases and non-minimal change disease, sir.
Okay. Other question is, do you expect by what age the remissions to occur in a steroid sensitive nephrotic syndrome, and what are the reasons for that?
We don't know the reasons, sir, but usually by puberty they attain remission. In that steroid sensitive nephrotic syndrome children, most of them will be attaining remission by 12 to 13 years of age. But more than around 10 to 12% can have recurrence of the relapse of the nephrotic syndrome even after puberty. But for the remission also, we do not know the cause. Generally, the relapse will be precipitated by any form of infections, like in the form of respiratory or GA infection or any form of stress can precipitate the illness. But after puberty, the relapse rates are really coming down, sir.
Dr. Sudha also can share her experience regarding nephrotic syndrome. Dr. Sudha, would you like to say anything specifically regarding nephrotic syndrome?
Sir, what
your experience or your perception in over the past few years?
Yes, sir.
Anything has changed or anything has for better or for worse or same?
So things that are changing, now the management wise, there are a few changes that we are looking into, sir. So before we did not have CNIs. It was, we started initiating only in the past few years, and the rituximab. So I think after CNIs and rituximab and even mycophenolate, what I have seen is children, they do well with mycophenolate also, the steroid-dependent nephrotic syndrome. And many a times we don't even go ahead with biopsy because they do respond with a higher dose of mycophenolate mofetil. But only thing is we need to monitor for the side effects very carefully. So this is one of the observations that I have made in the clinical practice. So a higher dose of mycophenolate mofetil helps them. And I think whatever Sangeeta said was all, I agree with her. And only one thing is, like, if children, they relapse after puberty also, then their outcome may not be a simple one. They are likely to, the nephrotic syndrome is likely to continue into the adulthood, and they might require further long-term care. So most of the children who go into remission, they go into remission by the pubertal age. Beyond that, then they're going to be having a difficult course. So even nowadays, it's just not the steroid-resistant nephrotic syndrome, the steroid-dependent and the frequently relapsing nephrotic syndrome. Some of them, we see them continuing towards the pubertal age group, and it continues even after that. Even if they're MCN also, it is continuing. So that is the other observation that I have seen.
Okay, thank you so much. Dr. Sangeeta, there was one more question for you. The child develops an intercurrent infection, and the child develops, shows albumin in the urine. And after treating the infection, it subsides. So do you have to start immediately if the child has an infection, or you can wait for some time?
If the child is going for spontaneous remission with the treatment of the underlying infection, we are not going to start the child on steroids. We'll just keep the child under follow. Whenever the child is getting relapse in the form of proteinuria, then we have to investigate the child again and start them on steroids. Again, ultimately, for the previous question, the proteinuria control is really important even it is non-minimal change, focal segmental glomerulosclerosis. If they attain remission with the calcineurin inhibitor, then it is good, and the prognosis also will be better in them, sir.
Okay, thank you. Now we have few questions for Dr. Sudha. Dr. Shahana Parveen has asked, what are the appropriate investigations, age-based, that have to be done for a child with urinary tract infection first episode and recurrent episodes? I think you have covered. Can you just repeat?
Yes. So for a recurrent episode, we do all the 3 investigations, the ultrasound, DMSA, as well as the MCU. As of now, I'm sticking to the ISPN guidelines only, which was published in 2011, but it is getting modified. But our earlier guideline, I'm sticking to it, is less than 1 year. We do all the 3 investigations, the ultrasound, DMSA, and the MCU. 1 to 5 years, we do the ultrasound, DMSA, and if that is showing any abnormality, we go ahead with the MCU, and more than 5 years we do the ultrasound, and then if that is showing any abnormalities, then we proceed with the other 2 investigations. But in practice, it definitely changes, and it is case based that we decide on the investigations.
Thank you. Other question by same doctor is, should DMSA be done in an active episode of recurrent UTI or after treating the urinary tract infection?
So for DMSA, when we do it during the active infection, we are going to see more of the pyelonephritic foci. And when we do it after 3 months, then scarring is what we are going to look into. But a child who is having a recurrent UTI, which means it is a missed UTI most probably, if they're coming to you for the first time, then we are at a position to make the patient understand that this child is having some difficult problem, why this child, they have missed the recurrent UTIs for such a long time, because I have seen many patients defaulting treatment. As soon as we advise them an MCU, most of them default the treatment. They are not interested in getting a catheter inserted, so they don't want to do an MCU. But as with the recurrent UTI, as a physician, I do not want to miss anything for this child. So I would prefer to still do a DMSA once I completely treat the infection, rather than waiting for the 3 months. But I think the guidelines do not support that, but this is my personal opinion. So.
Okay. Are there any guideline differences regarding the culture positivity? You have to take it more than 10 to the power 5, or between 10 to the power 3 to the 10 to the power 4 also sometimes are reported. Can you take it as a UTI if there are
yes,
other corroborative evidences?
Yes, if the child is symptomatic, sometimes we can't expect the 10 power 5 colony count. We know that this child, sometimes they would have received an antibiotic dose elsewhere. There are so many things to it. So the UTI is a clinical biological diagnosis. So it is just the urine culture is the gold standard, I do agree, but we have to go clinically also. So see if the child is having fever, child is having lower urinary tract symptoms, if the counts are high, polymorphonuclear predominance, your CRP is high, you look for the urine routine, check if it is if the child is having nitrites positive, your leukocyte trace or your pus cells, whether that is on the higher side, and also then you go for the urine culture. And with all this evidence, now you're going to have only a 10,000 colony count. Also, I would consider this child as having a UTI.
Okay, thank you. I don't see any other question in the chat box. I think you have covered most of the salient aspects for what the pediatricians have to know. And I thank once again for the opportunity given to me. And also, there was one more question. The first UTI order of priority, I think you have covered it. We will not go back into it. So thank both the speakers, Dr. Sangeeta and Dr. Sudha, for such a very clear exposition on the topic. And we thank the organizers once again. Thank you.
Thank you very much.
Thank you very much, sir.
Thank you.
Now I call upon Dr. Jayakumar. Sir is the Professor of Nephrology and Associate Dean Super Speciality PG Studies, Sri Ramachandra Institute of Higher Education and Research. Sir has achieved multiple awards and he received Best Teacher Award Tamil Nadu, Dr. MGR Medical University in 2011. He also received Dronacharya Award 2020 from the Association of Vascular Access and Intervention Renal Physician 2020. I request to moderate the session on AKA. Over to you, sir.
Thank you, Dr. Sangeeta. I am very happy to take part in this CME on behalf of the Department of Pediatrics and Division of Pediatric Nephrology and Pediatric Urology in association with Indian Academy of Pediatrics Tamil Nadu chapter. It's a very nice topic now, which is given to me. It is acute kidney injury in children and the renal replacement therapy thereof. The first of our speaker will be Dr. Amish Udani. Can I see his DNB in Pediatrics, postdoctoral fellowship in Pediatric Nephrology. Then he completed certificate course in Pediatric Nephrology from Indian Society of Pediatric Nephrology. He's working in BJ Bodia Hospital for Children, Mumbai. He has 12 years of experience. He has 14 publications to his credit. He's in charge of renal transplantation at BJ Bodia Hospital for Children and MUHS teacher for fellowship in Pediatric Nephrology. He'll be talking to us on AKI in children. We all know that the incidence of pediatric AKI is increasing globally, along with its associated morbidity and mortality. Of course, we have a standardized definition of AKI, which has allowed more accurate assessment of epidemiology of pediatric AKI. We also have several non-invasive diagnostic and predictive biomarkers. And there are several definitions, and including pediatric rifle, AKI and KDOGI. I request now Dr. Amish Udani to start the lecture.
Good morning, everyone. Am I audible?
Yeah, you're right.
And
yes.
My screen, is it visible?
Yes, visible.
Yeah, it is visible.
Yeah, so I would like to thank Dr. Sangeeta for inviting me for this CME. To start with acute renal failure, which was the definition or the terminology used in the past, was defined as rapid decline in the renal function, mainly in terms of elevation of serum creatinine, irrespective of the urine output. Many times due to nephrotoxic drugs or chemotherapy drugs, the urine output used to be normal or even more than normal. And so measurement of serum creatinine was taken into account while taking into consideration for defining acute renal failure. But most of the times, over 80 to 90% of patients which we see, usually the first clinical symptom what we see is the decreased urine output, which points the clinician towards investigating for the renal functions. And oliguria is defined as urine output of less than 1 ml per kg per hour, and anuria as complete cessation of urine output or even less than 0.3 ml per kg per hour. But over time, the researchers felt that this terminology needs to be replaced with acute kidney injury to include other functions of the kidney as well, and not only the accumulation of metabolic waste products. By the time we see a rise in serum creatinine or decrease in urine output, it might be already too late before we initiate treatment. So along with those criteria which were used earlier, they also included the renal function ability to regulate electrolyte and fluid homeostasis in this terminology as acute kidney injury, and more so even for the parents and the caretakers. Once failure terminology was used, they used to have misperception that it will not recover. But once the injury terminology is used, then they are more encouraging in providing treatment, since there are chances of recovery in such situations. So coming to the AKI diagnosis and staging of AKI, as we all know, the diagnosis of AKI is based on the urine output and the serum creatinine, and there were multiple papers in the past used to diagnose AKI based on serum creatinine clearance by Schwartz formula and the urine output. The earliest one which came was the pediatric rifle criteria, which was used in children, and it used the creatinine clearance and urine output. The criteria, which was acute kidney injury network, which was used more in adults, which defined based on the creatinine rise from the baseline and the urine output. And recently we have the KDIGO guidelines. It is more stringent in terms of the urine output, less than 0.5 ml per kg per hour for even 6 hours. They put it as a risk staging, and as the oliguria increases, then it progresses to injury, and last is the failure stage. And they also included the terminology called acute kidney disease, where if you have AKI or GFR, which is less than 60 ml per minute per 1.73 meter square for duration of less than 3 months, and after 3 months, it was labeled as chronic kidney disease. So based on this criteria, we stage the AKI, and it helps us to prognosticate and manage our treatment more aggressively. The pitfalls in this definition was it is an imprecise determination of the risk. It was mostly tested in the ICU or tertiary hospital settings. It has potential misclassification in children with AKI, especially they may come with fluid overload, or they may not have any baseline creatinine value which may be available to compare with, and the accuracy of the height measurement. It does not indicate the underlying pathophysiology or the cause of the AKI. It remains of moderate utility from the patient's point of view, as in terms of morbidity and mortality and the treatment options. It has limited use in neonates, as neonates, they have physiological oliguria even in the first week of life. These definitions are still rely on serum creatinine, which is widely available even in remote areas. But before we have other markers available which are cheap and accessible, we still rely on the serum creatinine. But the stress which I want to give here is the estimation of serum creatinine should be done by the enzymatic method in the laboratory rather than by the Jaffe's method. So based this criteria as the P-rifle criteria or KDIGO classification, they should be used in clinical judgment for AKI management. Coming to causes of AKI, we all know that it is divided into a pre-renal cause or intrinsic renal cause or a post-renal cause. The pre-renal causes which still are common in our country is because of decrease in the true intravascular volume due to severe diarrhea, vomiting, burns, or hemorrhage. Or it may be because of decrease in the effective intravascular volume due to septic shock, dengue fever, hemorrhagic fever, or cardiac failure. Or it can be due to because of increased intra-abdominal pressure and anaphylaxis. The intrinsic renal causes, most common group is the acute tubular necrosis. If the pre-renal failure is not managed appropriately with aggressive fluid resuscitation, they may progress to with hypoxic ischemic insult to acute tubular necrosis. We may have acute tubular necrosis because of endogenous toxins like intravascular hemolysis or rhabdomyolysis or tumor lysis syndrome. Even because of exogenous ingestion of toxins like ethylene glycol and methanol can cause acute tubular necrosis. Drugs like aminoglycosides, heavy metals, use of radio contrast and chemotherapies are also directly toxic to the tubular cells. The second group causing intrinsic renal failure is the acute glomerular or interstitial nephritis with or without multisystem involvement. vascular lesions like bilateral renal vein thrombosis or renal artery stenosis or vasculitis may also present with AKI. The post-renal causes are the unusual cause of AKI in a pediatric setup, but trauma because of clots or bilateral ureteric obstruction or bladder outlet obstruction because of calcular malignancy are usually the causes of post-renal AKI. The AKI usually occurs in at least 5 to 9% of all non-critically ill hospitalized children, and we should be aware or keep it in mind, this incidence, and these are the various studies from India which tells us the incidence of AKI, which range from almost 25 to 35% of cases who were hospitalized had developed AKI, and most of them had infections as the cause of sepsis as the cause of AKI. The mortality ranged from around almost in half of patients, they had a mortality, and renal replacement therapy was needed in around 15 to 30% of patients, which increases the cost of treatment. And studies in Chikmar and St. John's Hospital, who had a follow-up of these patients, showed that 20 to 30% of them developed chronic kidney disease. So, as we said, the creatinine or the urine output are the factors which is going to decide our diagnosis of AKI. But what I feel is now more and more centers are looking into the fluid balance sheet, which can be calculated even in the wards and more so in the ICU setup. And it is not only the urine output, but you should also stress upon the amount of fluid which is going in, and the fluid which is going in minus the fluid out, which is the urine output, or any extrarenal losses also should be included in it, and you divide it by weight and you calculate the fluid overload percentage. And if it is more than 5%, this should raise alarm for the clinician, and you can chart this every 6 hourly, or you can ask the parents to make a record, or your sisters to calculate. This may be a little problematic in younger children, but diaper weight can be used to measure the urine output in such situation. And you need to clinically also make a mention whether the child is edematous, whether the child is signs of dehydration, or whether the child is euvolemic. So once you have maintained this chart, it will be easier to predict the risk of AKI, which many of the centers don't have advanced monitoring like variability in aortic peak blood flow velocity or IVC diameter, which are based on the 2D echo parameters, which will predict the fluid responsiveness state. So once you have IVC which is collapsed or underfilled, then fluid challenge or increasing the fluid intake may help, but many of the centers may not have this availability of the test. So as we said, there are many urinary biomarkers are also available, but as we said, the cost of this biomarkers and the availability still remains a major hindrance for our country. So there are many parameters which are used, like in cardiac patients, they have troponin T, which will tell us a bedside marker that whether this patient needs cardiac investigations or not. Similarly, a renal angina index was developed to predict the risk of developing AKI, where there were variables which were put in the risk category, and you multiply with signs of injury, and you get a score. And if it is more than 8, that says that this child has a renal angina, and probably the child may have a risk of developing AKI. And here in this criteria, instead of the urine output, they had used fluid overload criteria, and if it was more than 5%, the score was given as 2, and if it is more than 15%, the score was 8. So this was developed for pediatric ICU patients. So similarly, recently in 2021, the neonatal acute kidney injury risk stratification score was published by Wazir et al. In this STARS study. And even in this, as you can see, there are multiple variables which were put as the age of entry in the NICU, use of bag and mask ventilation in the delivery room, the gestational age less than 28 weeks or more than 28 weeks, whether the child had sepsis or significant cardiac disease, any use of nephrotoxic drugs or furosemide, or the child needed inotropes were the variables used, and the clinical markers were used as urine output. And here in neonates, they had defined as less than 1.3 ml per kg per hour or more than 1.3 ml per kg per hour, and serum creatinine cutoff was 1. So this is available on the Google. If you can just put the variables in this chart, you get a total score and the probability of developing AKI, and it has a sensitivity of 92% with a specificity of 87%. Positive predictive value was 80% and negative predictive value of 95%. So if you have a risk of developing AKI, what you can do is assess the fluid status, and accordingly, if you have fluid overload, then cut down on the fluids. And if you are using nephrotoxic drugs, then you can either change the drug or you can use a renal adjusted dose for these nephrotoxic drugs. So coming to treatment part, once you are diagnosing AKI or you have suspected that the child is having a risk of developing AKI, the most important thing is the fluid modulation in these critical patients. And it all depends on the urine output, whether there is presence of edema or no edema, and what amount of fluid which is going in, and the net balance or the fluid overload should be calculated, and whether there is evidence of renal failure as estimated by serum creatinine, and calculating the creatinine clearance by Short's formula will decide upon the total volume which can be given. So we have a clinical scenario. If it is an edematous child with good urine output but no renal failure, this may happen in terms whether you are recovering ATN. In that case, the quantity of fluid which we can calculate is based on the urine output plus the insensible water losses. But if the child is edematous but has good urine output and renal failure, then the quantity of fluid should be calculated as insensible water losses over the next 24 hours. If the child is edematous, has reduced urine output and renal failure, obviously this goes without saying that the fluid restriction should be to bare minimum insensible water losses. But if the child is edematous with reduced urine output and no renal failure, as you may see in a child with nephrotic syndrome, still the fluid restriction should be initiated till the edema resolves. If otherwise, the child may develop fluid overload and complications of fluid overload. The second scenario is a non-edematous child with a good urine output with no renal failure. In this kind of patients, we can use a maintenance fluid. And if you have a non-edematous child with good urine output, but there is evidence of raised serum creatinine, many times the patient will like post-urethral valve and all may come with acute and chronic kidney disease. And in such situation, the safe calculation to give fluids would be to replace the urine output, the previous day's urine output. In a non-edematous child with reduced urine output and renal failure, again, even though there is no edema, you should start restricting the fluids to insensible water losses. And if you have a non-edematous child with reduced urine output but no renal failure, these are the patients who may have come with pre-renal failure, and you need to give despite maintenance fluid, you may even have to give correct underlying dehydration depending on the grade of dehydration which is present. Once you have decided amount of fluid which you want to give, the second thing would be to give the sodium, and depending on presence of hyponatremia or hypernatremia, correct potassium if there is hypokalemia, and if you have hyperkalemia, then you have to give potassium free fluids. and based on the presence of metabolic acidosis or alkalosis, we have to decide about the bicarbonate which needs to be given or not. This is a broader fluid management which I am trying to highlight here, and not going into all the complications or management of hyperkalemia, hypertension, metabolic acidosis individually. And one slide on renal replacement therapy, which is going to be covered later, is most of the times now the indication for dialysis is fluid overload, more than 15%, before we develop AKI stage 1 or oliguria, because as we know, the kidney has a very important interaction with all the systems like the immunology, the brain, the lungs, the hematological parameters, the liver, and even the cardiac. Sequential organ system failure would complicate the fluid status dynamically, and early renal supportive therapy may help in further fluid titration. So take-home message would be to monitor the urine output very closely in any admitted patient. Not only calculate the urine output, but also see for how much amount of fluid is going in and calculate it on as fluid overload percentage. Serum creatinine estimation should be done by enzymatic method. To early referral and early diagnosing AKI, so that aim of having 0 deaths due to AKI by 2025 can be achieved. Thank you.
Thank you very much, Dr. Ramesh Sudani, for that nice lecture in a short span of time. You started off with definition, and you talked about pitfalls of definition and classical classification of acute kidney injury in the form of pre-renal, renal, and post-renal, and you given various causes for all these conditions, and then touched upon the epidemiology. You said about the mortality of acute kidney injury in pediatric patients very, very high compared to even adults. And then you talked about renal angina index, how it is important in identifying the acute kidney injury patient which requires dialysis. Then you talked about neonatal acute kidney injury stratification score STARS study, and then fluid modulation in critical care patients and various clinical scenarios, and what are the types of fluids you should use. An excellent lecture. We will have a discussion at the end. We'll call for the second speaker now. Very popular speaker, Dr. Sukanya Govindan. She's MD Pediatrics from JIPMA Pondicherry and Nephrology DM from PJ Chandigarh. She had ISN Fellowship from Great Ormond Street Hospital for Children, London. She is a consultant pediatric nephrologist, Mehta Multispecialty Hospital and Global Campus, Chennai. Her areas of interest are early recognition of AKI, AKI therapeutics, low-cost RRT, nutritional rehabilitation. She has several awards and honors to her credit. Nematullah Award of Southern Chapter of Indian Society of Nephrology 2012, International Society of Nephrology Fellowship Grant in 2017, Best ISN Fellow Poster Award, World Congress of Nephrology, Melbourne 2018, Best Clinical Research Paper Award, ISN Southern Chapter 2022, and she's a member of ISBN Pediatric AKI Guidelines Committee, and she's a liaison officer of ISN Sister Renal Center, Great Ormond Street Hospital, London. She'll be talking to us on renal replacement therapy in pediatric AKI, and she will be answering when to start or initiate renal replacement therapy in pediatric AKI, what is the best access that is possible, what are the modalities which will suit individual patients, and how much ultrafiltration and clearance should be modulated. All these questions will be answered by Dr. Sukanya. Welcome, Dr. Sukanya.
Thank you very much, Dr. Jaikumar, for that wonderful introduction. And it's an honor to be speaking in the same session as you, sir. And thank you, Sangeeta, for extending this invitation. And also congrats to the departments of pediatrics, pediatric nephrology, and pediatric urology to have come together and so wonderfully put this session for today. So moving on to my talk, in the next few minutes, I'll be taking you through the indications of dialysis, especially for AKI, the timing, modality, and the complications that one would see with this AKI. The indications of RRT have traditionally been extrapolated over the years from the management of chronic kidney disease. So not surprisingly, a few years back, the only indications for starting renal replacement therapy, and especially in children where renal replacement therapy is very challenging when compared to adults, seem to be limited to only these indications, wherein you have symptomatic uremia resulting in encephalopathy, uremic bleeding, or a child with pericarditis, or the consequences of severe fluid overload like hypertension, heart failure, or respiratory failure, or refractory metabolic disturbances like hyperkalemia or metabolic acidosis, which does not respond to treatment. And what we were effectively doing is actually treating these children when already the damage has set in and they are just nearing the failure stage or at the failure stage, where often dialysis remains the only option to prevent complications rather than being anything other than supportive or even curative. But slowly over the years, things are starting to change. We do realize that not only AKI, but also, as Amish said so wonderfully in his presentation, that fluid overload and various other factors have also, we have realized that they start influencing mortality and survival in these patients. The PPCRRT trial very elegantly showed that with fluid overload, when it crosses 10% and goes to 20 or 30%, the mortality sort of jumps from 20 to 43% and more. And it's also a 3% increase in mortality for every 1% of increase in fluid overload. And so much so, the American Critical Care Society also suggested initiating RRT as early after giving the initial goal-directed fluid therapy to counteract fluid overload. We calculate fluid overload like by the difference between the fluid that is coming out by the fluid input per the ICU admission weight into 100. And also now its fluid overload has been incorporated in this very useful risk score of renal angina, which has the capacity to identify patients who are at risk of AKI, at risk of fluid overload and hence mortality much before the failure stage that we all know and initiate RRT before. So it was also the indications for RRT has evolved over the times because the patients that we deal with have also evolved over the times. We have multi-organ dysfunction. We now deal with more patients who have multi-organ dysfunction, either acute or chronic. We deal with very low birth weight infants, children on multi-organ supports and ECMO. We deal with many transplant recipients, not only renal, but other bone marrow transplants and other solid organ transplants. And often, and unfortunately, we still deal with children with overwhelming sepsis complicated by multi-drug resistance. We do now, our triggers for RRT also have rightfully changed. We do consider RRT quite early in children who have limited physiological reserve to tolerate AKI, non-renal organ dysfunction, which is complicated by fluid overload, anticipated solute burden. In some hypercatabolic patients, we do anticipate increased solute burden and probably institute early AKI. The need for large volume administration, including blood products and total parenteral nutrition. The severity of the underlying disease. The more severe the child, the more early or more frequently do we discuss the need for RRT. And of course, overwhelming sepsis. And the more we realize that kidney interacts with several other organ systems and could be helpful in aggravating or accelerating organ injury, non-renal organ injury, we are now thinking of RRT as one of the supportive measures to come in all these situations. And of course, we should be deciding based on what evidence we have, versus the complications that these modalities can bring about in children, and versus the most important factor, cost. So now our indications, moving away from the complications of renal failure, we also now institute RRT for many as a supportive therapy in many of these situations. When fluid balance is difficult to achieve only by fluid therapy and diuretics, when we need extra organ support, non-renal organ support like hepatic, lung, or cardiac support, when we need nutritional delivery, and also in certain situations like poisoning. But can we use dialysis as a curative therapy? Yes, and recently we are going probably towards that direction. In sepsis and multi-organ failure is perhaps the best condition that more and more details and more experience is evolving about using dialysis as one of the curative therapy. The role of RRT here is not yet clearly defined, but definitely more and more data is being produced. And this is one area of RRT where practice precedes evidence. Even before evidence or significant evidence has been generated, many of us do practice CRRT as one of the modalities in septic children. The availability of newer machines and filters have also enhanced our ability to support such delicate requirements for these children. Immune dysfunction in sepsis, going on some more into how dialysis could be curated. Immune dysfunction in sepsis could be two different ways, where you have a hyperactive immune system, where you have a really hyperactive immune system with plenty of pro-inflammatory cytokine mediators, to the other end of immune suppression and vulnerability to infection because of something called immune paresis, which also could be because of an increase in anti-inflammatory mediators. So this cartoon shows that clearly. From the immune hyperreactivity side, where we have the increase in pro-inflammatory markers, where you have the other side where we deal with children with immune paresis, where nothing works in them, there is probably a theory that there is increase of anti-inflammatory cytokines. And that is what is being promoted as the reason for using RRT in these septic children. These interleukins and pro-inflammatory mediators are all in this side of the molecular weight table, where they are all grouped together called middle molecules. And we need special filters and special modalities of clearances to remove these mediators. So with this knowledge, moving on to how do we prescribe RRT in our children? I'm going to discuss about the timing of RRT, the modality to choose, which access type to choose, the dose that is required, and anticoagulation, not particularly in the same order. So the timing of RRT, probably this is the most challenging part of RRT. So when to initiate and who to initiate. This particular chart clearly shows when grouped into four, patients can be grouped into four groups, where towards the lower end, there is a group of patients who would survive without ever needing RRT. And doing RRT in them is going to be probably unfavorable, putting them at needless risk of complications of RRT. And there is another group which would need RRT, but not necessarily early RRT. So they would survive just with RRT, even if it is started late. And there also starting early accelerated RRT might not be very favorable. And this particular group is what is going to be beneficial from starting an accelerated or an early RRT, where you can have improved survival and also improved secondary outcomes. But there is one group which will, regardless of the timing of RRT, are too sick to have RRT made a difference at all. So as a clinician, it is the nephrologist's imperative and the intensivist imperative to actually find out which of this group our patients fall and then take a wise choice. Do trials help us in telling which group would benefit from RRT, or either early RRT as of now is even beneficial at all? We do have some guidance from many major trials, and all of them have sort of somewhat ditched the idea of early RRT. They do not find any difference in the 90-day mortality. They do not have any, or the 60-day mortality. They also do not show any difference in terms of the recovery from RRT, but the complication rate seems to be higher in children children and adults who receive early RRT. So what do the guidelines say? The guidelines say, especially KDIGO says, of course, you should start RRT when there are life-threatening changes, but consider RRT in the broader clinical context, putting together all the conditions that could be modified with RRT, along with certain clinical biochemical parameters that should be or could be available to you in your particular center. And creatinine and urea thresholds alone should not be used for making the decision for RRT. The NICE guidelines also says that clinicians need better tools in like the clinical risk prediction scores and also use of biomarkers, which probably in the future we'll all be using biomarkers to determine the need for RRT or the stopping of RRT. So choosing the best modality, we do have plenty of modalities available. The choice for the modality would be based on the age and size of the kid, the hemodynamic status of the patient, the vascular axis or the peritoneal membrane status of the child, the local expertise that is available at your particular center, the indication of dialysis, mainly for certain conditions like hypometabolic states or inborn errors of metabolism, where continuous removal of metabolites are needed, you might want to choose one particular modality over the other. And of course, in our center or in our region, cost of therapy is going to probably be the biggest deciding factor on what modality you're going to choose. And also theoretically, and also from the nephrologist point of view, when somebody is calling me for dialysis, I would also like to determine whether what is it that I need to remove in this child, what is it that needs clearance in this child, whether it's a small molecule or it's a middle molecule, and what sort of dialysis or clearance, diffusive clearance or convective transport would benefit, would this child benefit from. So how do we choose? It is also a balance between the clearance, the rapidity of clearance that you require, and also the complications that one could expect in these children. So when you need higher clearance and quicker clearance or faster clearance, but you are willing to take a risk on the complication side, or you are better suited to manage those complications, you would go in terms to a rapid clearance modality like HD or SLED. But when you're thinking of, when you have a child with significant hemodynamic compromise and clearances can wait, or clearances can be done very gently over a longer period of time, then you are going to choose either CRRT or peritoneal dialysis. And there are obviously certain difficulties and certain parameters that differ across these centers. I'm going to only concentrate on the cost. Cost-wise, PD and intermittent hemodialysis of SLED are going to be the most cost-effective procedures. Although HD and PD are not that great in volumetric control, do not be disheartened if those are the only two modalities that is available in your center. Still, by tweaking the prescription, you can still achieve near normal or good clearances and good volumetric control, even with PD and HD. And of course, vascular access would also determine which modality you're going to choose, with vascular access being the Achilles heel of all blood-based therapies, especially in small neonates and infants. And vascular access you would definitely need for HD and your CRRT. So when to choose PD? So I'm going to start off with peritoneal dialysis and quickly go through the other modalities. This is the cheapest and continuous form of RRT that is available.
Not audible.
Yes, sir, not audible. Sukanya.
Yeah, thank you.
Yeah.
Sorry for that interruption. So PD is the most cost effective, and it's also the most, and also it achieves continuous RRT, and it's the most physiological form of RRT that one could achieve. And it also achieves the similar results as any other continuous therapy, especially your CRRT, at only the half the cost of hemofiltration. And it also is the only available therapy which aids renal recovery in some form. If you see, all the blood-based therapies are require the interaction of blood with an artificial membrane, which itself can produce certain inflammation. But PD avoids that, and hence it can aid renal recovery. And it also offers some form of middle molecule clearance, so could be useful in sepsis, which could also, one should also consider. It does not require any vascular access. Electrolyte abnormalities, and more importantly, even sodium you can achieve correction of extreme when you have extremes of sodium values. That is something that you cannot do with HD or CRRT. Coagulopathy is not a deterrent to start somebody on PD, and this modality offers the lowest risk of disequilibrium, better hemodynamic stability, and also the preferred modality in children with raised ICP. But why don't we do enough PD? The unpredictable fluid removal, the unpredictable solute clearance also is thought to be one of the main reasons why clinicians or nephrologists are moving away from PD, and also the fear of peritonitis, and the physician comfort, the need for 24/7 nursing care. But often it's the wrong patient that is selected would often result in poor clearances. Hypercatabolic patients would need more clearances, and often a blood-based therapy would be better in them. Poor lung status would hamper enough volume PD, and also very late initiation, especially when the patient's systolic BP, sometimes it's not even recordable, and that's when some of us are called in for PD. And that's not the right choice of patient to put on PD. And also, we do not know yet about how much of drugs are cleared through PD modalities. So PD, for starting PD, you would need a viable peritoneum, and you have the options of multiple catheters, which are soft or the rigid catheters. And you can also use multiple improvised catheters ranging from central lines to ET tubes and chest tubes and whatnot. So PD is very, very easy to set up on the bedside, and even when you do not have the standard equipments that are required to start it. The type of fluid would also, you could use the standard PD solutions with varying dextrose compositions available, or you can also use locally prepared fluids. The PD guidelines recently released by the ISPD are a good resource material for whoever wants to use locally prepared fluids. The dwell volume would mean anywhere from 20 to 40 ml per kg per cycle, and you can change it according to the clearances that are required. And the dwell time per cycle would maximally, you can use longer dwells also, but we would like to start at 20 to 30 minutes and see how it goes. There is also the option of using a cycler to do these PDs. As I said, nursing care and the burden on caretaker is going to be very high when you use an acute PD. So more and more use of cycler PDs would do away with that discomfort. You can use additives to the fluid when required. And also PD would require monitoring of electrolytes and blood sugars, especially because we use dextrose containing fluids, a proper fluid balance chart, and also doing periodic cell counts to rule out peritonitis. So moving on to blood-based therapies. The blood-based therapies are different from PD in that you would definitely need a vascular access. And in this group of neonates and small infants, that is probably going to determine whether you're going to do PD or a blood-based therapy. The size of the catheter, which will depend on the vessel lumen and the type of the vessel that you're choosing. The catheter length also matters, because often we see that the catheters that we use, the length might be a problem in a pediatric age group. And also the effect of vascular access on the circuit life, especially when we use expensive filters like CRRT, needs to be considered. Anticoagulation could be really a big thorn in your armamentarium, because critically ill patients have either side of they are either procoagulant, or some of them have DIC, and also you're struggling to achieve some form of circuit life with heparin when you have a child who's bleeding. And also, even with newer modalities like citrate for anticoagulation, still the complexity deters most of us from using this. Between the blood-based therapies of SLED and CRRT, again, choosing the modality would also depend on the clearance and the hemodynamic stability, and also versus what you want to clear, whether it's a small molecule or a middle molecule that you're interested in clearing. Again, what is the adequate dose in dialysis? A higher dose does not necessarily mean better patient survival. That has been demonstrated by various studies here. There is no difference between a 35 and a 45 ml per kg per hour of CRRT dose, or even when you are contemplating hemodialysis in your child. An alternate day or a 3 per week schedule does not is as good as your daily hemodialysis or an intensive hemodialysis schedule. And the resolution from acute renal failure is much quicker when you use a 3 per week schedule for AKI compared to a daily dialysis. And also here, this is a very well-designed study where the ATN study, where intensive versus conventional therapies, both across hemodialysis and CRRT modality was tried. And of course, there was no difference in the mortality or any cause mortality between the intensive and the conventional arm. So we know that higher dose is not better, and even a lower dose can achieve good survival benefit. Again, coming to the vascular access, these are the options that are available for pediatric vascular access. You can choose to put the catheters in the internal jugular, sometimes in the external jugular, or the subclavian, or the femoral. And I've just briefly given here the priming volumes of each of these filters. Earlier, 5 or 10 years back, the availability of all these filters were very, very difficult. But now we have the luxury of using the smallest of filters for these modalities, and also with the smallest of tubings also being prevalently available. In some regions, we still struggle to get these filters, but definitely the service is improved. As I said, the Achilles heel remains vascular access in all these blood-based therapies. This chart here shows that when you're placing a catheter using in the internal jugular, placing a catheter in the internal jugular gets the best survival for the catheter or the circuit survival at 60 hours of dialysis initiation. And this chart here shows, but lower down, when you use a smaller catheter French, as you go down, the circuit survival drops down significantly to less than 50% of catheters surviving, or the circuit surviving, at 24 hours time. So your catheter selection and the vessel that you put should be very, very carefully chosen. The prescription for your hemodialysis or SLED would require you deciding on the duration. The duration can be from anywhere between 1 hour to 6 to 8 hours. And also you should choose between the intensivity of the dialysis that you want to deliver. We've already spoken about the dose. Ultrafiltration would depend on how your patient's volume status is and what your targets for fluid removal per day is. The blood flow rates are given here. For the prescription of CRRT, you would have to determine the total dose that you're going to give. And this total dose is split between the replacement therapy and the dialysate fluids that you're giving. I will not go into detail of this prescription in the interest of time. You can also choose between the pre or post dilution when you're using a replacement fluid. And there are plenty of modes to choose based on only ultrafiltration, only hemofiltration, or a combination of only hemodialysis, or a combination of all these modalities. The anticoagulation, we have the choice between now heparin and regional citrate in patients who are able to tolerate anticoagulation. And in a patient who is obviously has bleeding complications, but you are interested in preserving the circuit life as they are very expensive and cumbersome to maintain, you can use the heparin-free saline flush methods or the regional citrate methods. Regional citrate methods are becoming more and more easier to use with change in the solutions that are available. And if you're using a blood-based therapy, you should probably choose to use an anticoagulation in the interest of better circuit life. The challenges in blood-based therapies are numerous, as I said. It would also depend on multiple patient factors, their hemodynamic status, their procoagulant status, the viable vascular access sites, complicated by the patient's poor HB and albumin. The pathology of which we are choosing, whether it's sepsis or there is fluid overload, the available anticoagulation that is in your center, the available circuit and the filter size and the tubings, and also the technique that you want to use. Lastly, I want to discuss about complications, and briefly I would discuss this. Comparatively, peritoneal dialysis and hemodialysis, the complications that we encounter are much, much different. Peritoneal dialysis, you're more aware of or more likely to encounter a mechanical problem because of the type of catheter that you're using or the internal environment in the peritoneum that you're facing. You could either face a catheter obstruction or a leak, and sometimes which could complicate a poor ultrafiltration. Metabolic complications like hyperglycemia because of dextrose fluids and hypokalemia because of accelerated potassium removal can be anticipated, and infections in the PD circuit and inadequate clearance can complicate your peritoneal dialysis. But hemodialysis, the more or the blood-based therapies, the more complications shift towards hypotension, hemodynamics because of the extra blood in the circuit, the disequilibrium syndromes because of the rapid shifts in solutes, and also coagulation, because the circuit is a foreign material and a foreign membrane, which would very quickly clot if you're not using coagulation. And of course, as I discussed, vascular access failures and coagulation issues cause a significant downtime in the CRRT dose or the hemodialysis dose delivered. So in summary, offering renal replacement therapy for AKI in children is becoming more and more prevalent for many, because we are now using it for many indications. But challenges do exist in identifying the correct group that would benefit from renal replacement therapy. The modality also depends on the cost, the expertise, and the needs of the patient. But RRT has many challenges, including vascular access and the complications that I just now enumerated. More vigilance is needed in prescribing RRT and monitoring, and especially in children. Thank you.
That's an excellent presentation, Dr. Sukanya. You have touched upon all the questions that is required to be touched. We talked about the timing. You showed us the AKI trial, ideal ICU trial, and then various guidelines like KDIGO guidelines and NICE guidelines. You talked about the options of access that is available, then the modalities. You particularly highlighted initially on pros and cons of peritoneal dialysis, then what is adequacy in dialysis in acute kidney injury, then how to do heparin-free dialysis, and then what are the complications of challenges that we place in blood-based therapy, and finally the complications. This is an excellent lecture. Thank you very much for your very lucid presentation.
Thank you, sir.
I'm not able to see questions in the. I just want to know, one of you can answer. You talked about on the renal angina index, and then you said risk and injury. In that, how do you really calculate the fluid overload in children?
Amish, do you want to take, or can I?
You can take, yeah, no problem.
Thank you. So practically in the ICU, we do have a fluid balance chart and the admission ICU weight. Although that is not the ideal, we do not know the ideal body weight of the child. Many of these children do turn up critically ill, and we have no ways of measuring their weight. We do take the first ICU weight, and then progressively the fluid in and out is calculated on a daily basis to them. And when they cross, and we think it's significant when they cross the 10% threshold. So if a child from the ICU weight over the next 24-48 hours has gained more than 20% or 10% of their body weight in excess, and that's the time then we are a little bit worried. And by then, when we are called for, the intensivist has already tried some fluid restriction, and diuretics are most probably going on infusion. And beyond that, when the fluid overload still is persistent or increasing, and that's when we would think that we'll have to step in.
Yeah, some things. Thank you for that answer. I'm not able to see any. There is one question in the chat.
There is no questions.
Okay. No.
Yes. Thank you very much, Dr. Sukanya and Dr. Amish, for the wonderful session. Thank you, Jayakumar sir, for the moderation.
I thank you, Dr. Sangeeta, and also I thank both the speakers who had a very lucid presentation on a very important topic of acute kidney injury. Thank you very much.
Thank you, sir.
Thanks a lot. Now I call upon Dr. Kumaravel.
Hello, am I audible? Hello.
Sir, it's echoing, sir.
One second, I'll just disconnect. Am I audible now? Is it clear?
Lot of background noise is there, sir.
Okay. Just give me a second.
Dr. Kumaravel, sir is a professor of pediatric surgery, deputy medical superintendent, JIPMER, Puducherry. Sir has many career highlights. He has won BIST Endowment Prize winner, Innovation Award winner for consecutive 2 years. And he has given so many talks, invited faculty for the many conferences, trained in advanced pediatric robotic urological surgery at University Chicago, USA. He has the postdoctoral teacher guided more than 20 theses. He is interested in innovative surgeries. His special interests are neonatal surgery, pediatric laparoscopic, and robotic minimally invasive surgeries. I welcome Sir to moderate the session on hydronephrosis. Over to you, sir.
Hello.
Good morning, everyone. It is indeed a great pleasure to take part in this pediatric nephrology CME at Sri Ramchandra Higher Institute of Education and Research. And I wholeheartedly thank the organizers for inviting me here. Antenatally diagnosed hydronephrosis is one of the most common antenatally diagnosed anomalies, and hence a clear understanding of this topic for pediatricians, pediatric nephrology, as well as for pediatric surgeons is essential if we are to provide accurate management and avoid either unnecessary delay in surgery or intervention or over investigation. Who better to enlighten us on these topics other than Professor Ramesh Babu, who has an PhD in this very subject, that is uretropelvic junction obstruction and non-obstructive dilatation of the kidney. Dr. Ramesh Babu, in addition to all the things that you are seeing on the screen, I hope you are seeing this on the screen. Yeah, he is an excellent clinician. He is an academician par excellence. If you see his reviewerships, the number of presentations and publications that he has, and the editorial memberships of premier article, like PSI, Pediatric Surgery International, etc., you will know what an excellent academician he is. He is not only that, he is a multifaceted personality, excellent writer, not outside the field of medicine also, an excellent cartoonist, a skillful surgeon, a fantastic teacher, and above all, a great human being and a dear friend. Without further ado, I request Dr. Ramesh Babu to take over. Thank you.
Thank you, Dr. Kumaravel. Can you hear me?
Yes, sir. Please
thank you, Dr. Kumaravel, for your kind words. I thank Dr. Sangeeta for putting up this comprehensive program, and it is indeed a great pleasure to be amongst the elite speakers. Are you able to see my screen, full screen now?
Yes, sir. Yes, sir. Please proceed.
Okay, yeah. So this is an important topic, uretropelvic junction obstruction. When you look at the etiology of fetal urinary tract dilatation, transient hydronephrosis is the commonest cause, also known as non-obstructive dilatation. It amounts to more than 50% of the causes of fetal urinary tract dilatation. This is closely followed by uretropelvic junction obstruction, which accounts for around 30% of the cases. Now, there are multiple hydronephrosis grading systems. The Grignon staging system was in 1986, and then SFU, Society of Fetal Urology, then antropelvic diameter, then urinary tract dilatation. Then we proposed this hydronephrosis severity score, and then there is this Onan grading, which keeps on coming up every other year with a new modification. The original grade, the report of appeared in the radiology by Mr. Grignon, included anteroposterior pelvic diameter as well as a calyceal dilatation, and they had this cutoff of 1.5 centimeter, above which they called it grade 4 with the moderate caliectasis. Society of Fetal Urology grading has been there in WO since 1993, and you all know the details. Grade 0 is normal, grade 1 is mild dilatation of the pelvic calyceal system, grade 2 slightly more dilatation with the major calyces, then minor calyces and cortical thinning. Now, the anteroposterior diameter of the renal pelvis, that classification has been prevalent since 2001, and it measures the anteroposterior diameter at the level of the isthmus, the transverse plane, and if there are cutoff values established, in the second trimester, something less than 4 is considered normal. In third trimester, less than 7 is normal, and after birth, less than 10 is normal. Now, we also know that we can use the same thing in the grading of the severity. In the second trimester, anything more than 10 is abnormal. In third trimester, something more than 15 is abnormal, and after birth, something more than 20 is abnormal. Now, the disadvantage of anteroposterior diameter are the operator difference is very high. The AP diameter is very low in dehydrated infants, so that can be one of the factors influencing how you measure the diameter. It can be low in an empty bladder. And the intrarenal pelvis, I mean, this is one condition where even with the lesser AP diameter, it can be more severe, causing pressure effect. So the predictive value of decrease in renal pelvis anteroposterior diameter, this is an interesting article. One Gyanendra Sharma said that it is more useful in prone position. If the AP diameter decreases in prone position, then that is probably not an obstructive hydronephrosis. Now, UTD classification has been in WO in 2014. We all know it is made up of 6 factors. In the antenatal period, the anteroposterior diameter, calyceal dilatation, parenchymal abnormalities, ureter, bladder, and Leica status. The same is applied in the postnatal period as well, where you do not have the oligo, but you have all other features like the AP diameter 10 to 15, more than 15. Then peripheral calyceal dilatation. Here, the parenchymal abnormalities are also there, but they also club the ureter and bladder and other things to P3. So they divide it into just P1, P2, and P3. Now, the pros and cons of urinary tract dilatation classifications are like it is simple to the radiologist. So it is easy to reassure the parents in milder varieties where you can say that this is going to resolve. So this will get better. Extent of evaluation and the need for follow-up is also predicted upfront for the pediatrician. So it's easy for them to refer, particularly in the Western world, when to refer, when not to refer, and give the patient to yourself. That can be decided in the Western world. But it includes a wide differential diagnosis of congenital anomalies of kidneys. It fails to demonstrate accurately the severity of hydronephrosis, and it does not suggest who needs a surgical treatment and who can be safely followed up, which is what I am interested as a surgeon. So this is a publication which came in the year 2017. They compared the usefulness of SFU grading and UTD grading. So SFU grading in the worst SFU 4, 57% of them had a 3-year resolution rate, and then in UTD, slightly better correlation, 71% of them had a UTD resolution rate. So they felt that UTD is slightly better, but I do not know what way. It still doesn't tell. The Onan publication in the year 2020, again, it looked at the value of UTD, SFU, and then they said that the wide definition of SFU4, for example, here itself, the amount of cortical, the amount of cortical parenchymal thinning can be different between different types, and also the UTD P3 failed to indicate accurately the severity of the hydronephrosis. So Onan went on further and said that in whatever grade, the AP diameter is not important. And then he said that in calyceal dilatation is grade 2, but in grade 3 the medulla alone is thinned. Here the cortex is also thinned. So he kind of differentiated between the thinning of the cortex based on the sonological appearance. But I think this needs quite a bit of an extensive experience in the radiologist to pick up this particular difference in medulla and cortex to tell what exactly is is significant obstruction. We looked at this uretropelvic junction obstruction based on anteroposterior diameter. We looked at the 32-week fetal scans and then reported in the year 2010 in Indian Journal of Urology that anybody more than 30 millimeter, they always needed surgery, and anybody less than 15 millimeter, they did not need surgery, and the in-between group was variable. So the predictors for the need for surgery in an antenatally diagnosed hydronephrosis, this was looked up by the group in SGPJ Chandigarh, not Chandigarh, SGPJ Lucknow, and they showed that APD of more than 24 could predict the need for surgery with a sensitivity of 73% and a specificity of 88%. Still, they did not recommend that 24 millimeter as a cutoff for surgery, but what they said was in those less than 24 millimeter, the burden of investigations can be minimized. We published this in the Indian Pediatrics in the year 2018, where we looked at the role of VCUG and role of renogram in antenatally detected hydronephrosis. The current guidelines of Indian Society of Pediatric Nephrology says that anybody more than 10 millimeter in diameter should get both the MCU and renogram. But we found that when we follow that guideline, 89% of the patients had no abnormality if there was no hydroureter, and 98% of them did not have an obstruction on the renogram if the diameter was less than 20. So our current protocol is slightly different. We have gone like this: when the AP diameter is more than 10 millimeter at a 48-hour ultrasound after birth, what we do is, if it is a boy with the bilateral hydroureteronephrosis, we obviously go for an early VCUG to look for posterior urethral valve. However, in the remaining, the girls or the ones with the unilateral hydronephrosis, we decide based on the hydroureter. If the hydroureter is present, we ask for a late VCUG to look for VUR. In those without hydroureter, if the AP diameter is less than 20, we simply follow them with the ultrasound. And if the AP diameter is more than 20 millimeter, we obviously go for a diuretic renogram. But there is also this group where there is a 15 to 20 millimeter AP diameter, but there is a calyceal dilatation or cortical thinning. I mean, those are the ones who also get a diuretic renogram. Okay, obviously, when there is a UTI, you get a VCUG, which is a late UCG, not necessarily a late UCG. So this is a typical patient with the uretropelvic junction obstruction. You can look at the ultrasound and says that there is a cortical thinning here. This is grade 4, and then the AP diameter during follow-up has gone from 25 to 30. The grade has gone from 3 to 4. There is a drop in SRF. There is an obstructed curve. That means that there is not draining. This is a normal draining curve. T half is more than 20. I'll come to that. I mean, this T half is again, I mean, T half is not available in some of these patients, so you can't really tell, but more than 20 also sometimes can be a little equivocal. Then prolonged transit time, hold up in delayed films, all these things. This is a typical case where there is a probably, no doubt, that child will need surgery later. This is a case which is a typically non-obstructive dilatation where there is hydronephrosis, but the size is probably 18 millimeter or 16 millimeter. There is no calyceal dilatation, and there is a drainage on both sides. There is a holdup there in the late film on the left side, but still the left kidney is functioning 44%. So although they have reported that this is a kidney with reduced parenchymal function and obstruction on the GTPA, we tend to wait, because when we see this kind of curve after surgery, we feel that patient has succeeded from the surgery. So why not give them the benefit of success beforehand? Surgical indications for unilateral neonatal hydronephrosis. This is a paper which was published some time ago, and they looked at they summarized multiple factors which has been used in diagnosing the indication for surgery. Most of them, the cough criteria is like 10% reduction in the differential renal function. Some said 5%, some said initial function is less than 40, then you are worried. So different people have got this. The safest indication is neither early surgery nor aggressive observation, but severe hydronephrosis associated with less than 40% function and a decrease of 5 to 10% of relative renal function on follow-up. However, The optimal time interval for follow-up is essential to avoid irreversible renal function loss. This is a particular problem in India where people tend to drop out of the follow-up. They don't stick to their program of following up. We published this paper in year 2015, where we looked at the functional outcomes of early versus delayed pyeloplasty in prenatally diagnosed pelvic junction obstruction. We found that early pyeloplasty in prenatally diagnosed SFU grade 4 hydronephrosis tends to significant improvement in SRF, whereas delayed pyeloplasty leads to marginal but significant loss. What we meant was, like, for this cough postulation is there should be a 10% reduction as an indication for surgery. But when we looked at it, if there is a reduction, then after surgery, it doesn't reach the preoperative level. Whereas if you have done an infant pyeloplasty, whatever function, which was 30-35%, goes up to 40-42%. So this is particularly infants have this potential to recovery. If you know that they have the significant hydronephrosis, then you probably can go ahead. So can you predict which case will lose function during follow-up and preempt pyeloplasty to prevent a permanent loss of function? So this is another parameter we looked at, and then pelvis cortex ratio, where we just didn't use the AP diameter. We also combined with the cortical thinning. And then we found that pyeloplasty was indicated in all patients where the ratio is less than 8. Okay. Now, this is another parameter which we introduced, hydronephrosis severity score, where we used a combination of a Society of Fetal Urology and APD grading, drainage pattern, and the differential renal function. So the maximum score is 12 for the worst hydronephrosis. 0 is normal. So we look, we know this already. 0 already we have the SFU grading from 0 to 4. We added the APD criteria. Anything more than 30 is considered 4. Then drainage pattern we categorized as something which drains even before the furosemide is given is 0, whereas something which starts draining after furosemide is 1, sluggish after furosemide is 2, then flat 1, then upgoing curve with the stasis at 2 over delayed film is grade 4. Then differential renal function that goes like that, less than 30% gets 4. So when you have a severe hydronephrosis severity score like 9 to 12, then we found that almost all of them, 31 out of 31, underwent surgery. Okay, so the hydronephrosis severity score we felt should be a useful parameter. Now, other ultrasound markers, resistive index, we all know anything more than 0.7 is considered a useful marker, but this is not widely done. Shear wave velocity on ultrasonography, we have looked at it, and the shear wave velocity on elastography is more in uretropelvic junction obstruction. This is again not routinely used. Now, other renogram markers, T-half more than 20. Some people say it is suggestive of obstruction, but not always. If something starts draining at 22 or 23, we will still say that this is working. Intrarenal transit time, that is the time for the tracer to leave the cortex and appear in the pelvis, more than 3 minutes is suggestive of obstruction. Then hold up in 2-hour film is suggestive of obstruction. So this is a 3-month-old baby with the uretropelvic junction. The query is whether it is a UPJO or non-obstructive dilatation. So the initial ultrasound showed a 15 millimeter AP diameter, then it later became 18 millimeter, and the calyces are dilated, but cortex is not really thinned out. Now we did a renogram. They've given the report as normally functioning right kidney with obstruction at PUJ level. This is the report they give, but we should be able to interpret some of these. And then right kidney function here is 45%. Now, when you look at the curve, I bet this is beyond 20, but it kind of starts coming down at the 22, 23, 24. Slowly, it starts coming down. And then intrarenal transit time, if you look at it, that is also like, it's getting better. For example, here it is starting to appear in the pelvis by around 4 minutes. And then when you look at the curve, there is a late dip here. There is some hold up in the 2-hour film. But this is a case where this is a typical case where we cannot decide whether this child is going to lose function by waiting. I mean, these parents can be worried, and then we need to know what is the best way to treat them at the right time. So, role of urinary biomarkers. We have heard several people talk about urinary biomarkers. These children undergo repeated invasive imaging, renogram, ultrasound to differentiate NOD from uretropelvic junction obstruction. So, can they differentiate this uretropelvic junction obstruction? So, we published, Dr. Sangeeta and myself, that we have started this project on urinary biomarkers to compare whether they can predict accuracy of urinary biomarkers. This is a meta-analysis. Obviously, we are going to start a proper original research here. So when we looked at this particular biomarkers, this is a summary table of ours. This is the 6 biomarker candidates which are promising, out of which CA19-9, then NGAL, and then KIM. So these are the ones having the highest accuracy of predicting. So we probably can have a panel of biomarker combining 3 or 4 either CA19, NGAL, and kidney injury molecule, and then we can say that these 3 biomarkers are elevated. So these are the kidney patients who are going to get worse. The previous speakers expressed a concern about the cost of the biomarkers. I'm sure in the years to come, biomarkers are more going to become popular, and as they become popular, there will be centers who will be pulling and doing these samples, so the cost will come down. So I bet in another 5-10 years, biomarkers have a great future. Now, this is a paper which appeared in year 2019, surgical decision making in infants with a suspected uretropelvic junction obstruction, the stakeholders' perspectives. So most of the patients relied on the surgeon's recommendation, and the surgeon's recommendation essentially based on the personal experience, then perceived family circumstances, published literature. So the load of the thing is on the surgeon, and when we have so much reliance on us, our decisions, then we need to be aware of the current evidence and what are the indications of surgery in these patients. So to conclude, I want to say that take-home points: Kelly cell dilatation and cortical thinning are more important than the absolute APD values. Initial split renal function less than 40%, it's risky to wait. Diuretic renogram curves can be unpredictable. In severe hydronephrosis grade 3 and 4, early intervention in infancy definitely recovers the renal function, and the biomarkers may aid in the future. A combination of factors and clinical decision is the key to decide intervention, and at the moment, this is what we do. We combine multiple factors and then make an informed decision. Thank you for listening to this talk.
Thank you, Dr. Ramesh Babu, for that excellent exposition of how the decision making is being done by the experts. So I think we are very close to closing. I'll just check the chat box. As of now, I don't see anything specific for you. Just one question from my side. Can you highlight the necessity or the lack thereof for MCU in early investigation? As you rightly said, and it is our experience also, that you need to do 90 more MCUs to get 10 positives out of 100. If there is a unilateral hydronephrosis without a ureteric dilatation.
Yes. After we have done our study and then published in the journal Indian Pediatrics, we have found that even in those with the bilateral UTD, for example, we see a lot of UTD, PA1, A2 to 3, but no hydroureter. That hydroureter component is not there, and bladder is normal, liquor is normal. So even in these patients, we are simply following up. Just because bilateral hydronephrosis is there, we don't do voiding cystourethropy anymore. We do only when there is a bilateral hydroureteronephrosis with the bladder wall thickening, keyhole sign, or or there is a lot of bladder wall thickening. Now, in those with the unilateral hydronephrosis and hydroureter, the indication to do a VCUG to rule out VUR, it is often done late. Like, for example, persistent hydroureter nephrosis, which continues when you do an ultrasound at 2 months or 3 months. That is when we go for a VCUG, because we need to know a baseline what is going on. But there is no rush to do that VCUG.
Thank you, sir. Thank you. I now hand over to Dr. Sangeeta for the next session.
One more question.
If there are any questions, please go ahead.
What is the earliest age you have operated?
For PUG obstruction?
Yes, sir.
Generally 6 weeks, because by the time we get the first ultrasound and then repeat ultrasound and a renogram, it's usually 4 weeks. We don't do the renogram before 4 weeks. So usually it is 6 weeks, and then from 6 weeks onwards, we are now doing laparoscopic pyeloplasty. So it's not an open pyeloplasty anymore. It's very successful in our hands nowadays. Now, have I done a neonatal pyeloplasty? Yes. I mean, that is very rare. In the last 25 years, probably 2 or 3 times. That is because these children presented with a huge mass palpable, or they've already ruptured during delivery. So those are rare indications where we get a DMSA scan just to look at the function. DMSA scan can be done slightly earlier than the diuretic renogram. That is basically to make sure that we are not dealing with the absolutely non-functioning kidney. And then we have done nephrostomies or pyeloplasty and nephrostomy, or pyeloplasty and stenting, which is very rare, as I said, probably only 2 or 3 cases in the last 25 years.
What is the role of...
One more question. Yeah, please go ahead, Dr. Sangeeta.
The role of antibiotic prophylaxis only in case of VUR. This is a question from Dr. Nisha.
Yeah, even in VUR, the role of antibiotic prophylaxis is going out. I'm sure the previous speakers have been are there. They can add on this. Nowadays, we don't do uroprophylaxis in grade 1 to 3 VUR. And so if there is a hydroureteronephrosis and grade 5 or 4 reflux, then probably we can start a uroprophylaxis. But it's generally not needed in any hydronephrosis. I mean, those days are gone where we all UTD get an uroprophylaxis, which we are not doing that anymore.
Thank you very much, sir, for the enlightening session. And thank you, Kumaravel, sir, for moderating the session.
Thank you.
Now, I call upon Dr. Ram Prasad, sir, for the next session. Ram Prasad, sir, is working as a professor and head of the Department of Nephrology, Ramchandra Institute of Ramchandra Institute. He has experience of 14 years in the field of nephrology. His areas of expertise are transplant, AKI, ADPKD, genetics, and kidney disease. He has publications of around 32 in indexed in international and national journal. I welcome you, sir. I request you to...
Thank you, Dr. Sangeeta. Can you hear me?
Yes, sir.
Okay. So thanks organizers for giving me this opportunity. And we will move on to our next topic, which is investigation in child with renal disease, basic to advanced. We all know renal disease is one of the major cause of morbidity and mortality in pediatrics, especially the young ones with renal disease may present with non-specific signs and symptoms. So it is very important we should have an high index of suspicion of renal disease whenever the patient presents with these symptoms. So early diagnosis and treatment is very important to prevent the progression. So talk upon this topic of investigation in child, I call upon Dr. Susan Uthup, who is currently the professor and head of Department of Pediatric Nephrology at SAT Hospital, Government Medical College, Thiruvananthapuram, and who is also currently the National President of Indian Society of Pediatric Nephrology She is also an honorary consultant pediatric nephrologist at Secretaries Institute of Science and Technology. Her area of special interest includes CKD and peritoneal dialysis and nephrotic syndrome and acute kidney injury. We welcome you, madam. Please.
Thank you, Dr. Ramprasad, for that nice introduction. And can you hear me?
Yes, ma'am.
Yeah. Shall I share my screen?
Yes, ma'am. Sure.
You can see my screen, no?
Yes, ma'am. Be good.
Thank you, Sangeeta, for this wonderful opportunity to be with you all on this 1st of April, talking about a child with kidney disease, how we have to go about the investigation. We all know that the renal disease is having a very subtle manifestation, or most often it is silent, and we pick up the disease most often very late. And so investigating, actually choosing the correct investigation after a proper clinical evaluation is important in ultimately detecting the disease. And we all know that early diagnosis and treatment will improve the outcome in all people with renal disease, especially so in children, because childhood, we know that the kidney is growing and the child is growing, and the renal function assessment is very important for a child who may be having a very silent or subtle presentation. We have to remember that nephrology is actually physiological chemistry, and so we all rely on a very good lab, and at the same time, a sensible interpretation by the doctor is important. There are no routine tests, and all tests should be specific to the clinical situation. And there is no single test for accurate assessment in a wholesome manner. And we all know that the kidney disease approach is actually a compartmentalized disease approach, because the clinical manifestations are quite stereotyped when it is affecting each and every compartment. We know that there are glomerular diseases, the tubular and interstitial diseases, the diseases affecting the vascular system, as well as the drainage system. And in the pediatric age group, congenital anomaly of kidneys and urinary tract is topping the list of chronic kidney disease in children. And picking up acute kidney injury in time is important, as well as chronic kidney disease, picking up the disease and proper management, culminating finally into a transplant in time is important for the proper, the longevity as well as a quality life for the child. So let us look at the renal response to injury. So glomerular diseases may be affecting the glomerular base membrane, mesangium, endothelium, or epithelium. There could be inflammation or no inflammation. There could be inflammation plus proliferation. We will be dealing with that shortly. The tubular injury will present with concentration or dilution defect, metabolic acidosis, or alkalosis, that is electrolyte imbalance may be the presentation. The child may be the anemia may be the presenting symptom sometimes. And in vascular diseases, blood pressure changes are usual. And we all know that checking the BP is quite often not happening in the pediatric age group. And the obstruction, if it is there, if it is partial, it could be polyuria. And if it is total only, there may be anuric renal failure. So the glomerular disease, that stereotyped clinical manifestation will be oliguria, hematuria, edema, hypertension, and a reduction in glomerular filtration. Whereas tubulointerstitial disease will be presenting as with a child who is very dry, with polyuria, nocturia, anemia, acidosis, and bony deformities. And we all know that the triad of manifestation of CKD in children is growth failure, anemia, and bony deformity. And most often, almost all the carpet will be affecting the tubulointerstitial compartment. And vascular diseases usually will be manifesting with hypertension and urinary tract obstruction, obstructive voiding symptoms may or may not be there, especially so if it is the upper tract that is obstructed, there may be fever, and the pyelonephritis may be the presenting symptom in such children. Children can present with voiding dysfunction, and so we know that we have to really decide on the what investigation is to be planned depending on the clinical presentation. But we all know that renal injury will lead to an abnormality in the urine, both in the quantity and quality, and urine being the liquid biopsy of the kidney. Looking at the urine is going to give you a lot of clues regarding the disease. So let us have a look at the urine first. When kidney is injured, Urinalysis will give clues as to the type of injury, whether it is acute or chronic, the site of injury, the severity of injury, what is the evolution of the disease. You can assess by looking at the urine, and you can even prognosticate depending on the urine analysis, which is to be done properly. A fresh sample is the best sample, and the sediment examination is a gold mine of clues for the clinician. And how we examine the urine for microscopy, we do it on a centrifuged specimen, and the button that is at the bottom will be suspended, and then you will be looking under the microscope to see for RBCs, WBCs, casts, crystals, bacteria, yeast, parasites and artifacts and all. And a more closer look at the microscopy is important, and we have to have a fresh urine that is examined because the cast and cells will disintegrate within 1 to 3 hours at room temperature, and refrigeration can be done to preserve these cells up to 48 hours. And centrifugation, why do we do? Because there will be a concentration of all the pathology that is there in the urine by doing this. And we can have the bright field microscopy, phase contrast microscopy, polarized microscopy to look at the urine. And RBCs in urine is actually a great support for the clinician for making a proper diagnosis. We know that this dysmorphic RBCs are giving a clue to the glomerular bleeding. The cast in urine, if you look at it, is actually can be considered as poor man's renal biopsy. And the hyaline cast, few of them are normal, they are colorless, they are cylindrical, and they are taking the shape of the tubule. And RBC cast studded with RBCs is the telltale evidence of acute glomerulonephritis. And so this remnant of cells and protein that fill the tubules during the pathogenesis or pathology of the disease will be shown in the urine when you look at the urine for cast. And we have to look at the edge of the cover slip to see the cast. And hyaline and granular cast may be normal, but if they are present in large numbers, you have to give some concentration on that point. And the waxy or broad cast is present in usually in advanced renal failure, because as it is shown that it is actually taking the cast is actually the tubule is the mold, and the cast is getting molded. And so whatever is happening in the tubules, we are able to identify by looking at the cast. There are different casts. There are this WBC, RBC cast, granular cast, broad cast, fatty cast, and so many casts are there which are actually telling you, yeah, this is what is happening inside this renal factory. And the crystals also are giving us a clue, especially in crystalluria and renal stone disease. We may think that renal stone disease is not very common in the pediatric age group, but as of now, we are detecting the renal stone disease in very small kids, and any person who is prone to develop crystalluria and stone disease will show these things in the urine by the age of, and even stone in the kidney from the toddler age group. That is what our clinical experience over the years is teaching us. And yeast actually may be seen in a urine as a contaminant, but if it is budding hyphae there, it may be significant. So now let us look at the response to glomerular injury. The injury to the glomerular capillary wall, and there is no active inflammation. The sediment will be bland and leukocytes may be there, and the proteinuria will be heavy. That is nephrotic proteinuria, which is 40 milligram per meter square per hour, and you call it as there is nephrotic syndrome. Injury to the glomerular mesangium will lead to dysmorphic RBCs and RBC casts. There may not be significant proteinuria, and this is what is manifesting as a glomerular hematuria, and the telltale is IgA nephropathy, where recurrent hematuria may be seen. If there is injury to the glomerular capillary wall and mesangium, there is active inflammation and or proliferation. The sediment will be nephritic, RBC cast, plenty of RBCs which are dysmorphic, and presence of WBCs. Proteinuria is usually subnephrotic, and you call the syndrome as acute nephritic syndrome. If the injury is severe, there is inflammation plus proliferation. There will be nephritic sediment plus nephrotic proteinuria, and you call the syndrome as nephrotic syndrome. So let us have a look at few case scenarios now. A 10-year-old female child presented with gross hematuria and edema. Physical examination revealed a blood pressure of 124/70. She was having purpura and her extremities were edematous. Her urinalysis showed 3+ protein with numerous RBCs and RBC cast. Urine protein to creatinine ratio was high, 8.3, suggesting that there is nephrotic proteinuria. Hemogram was suggestive of anemia. Leukopenia means borderline total count of 4,000 and a high ESR. Serum albumin was quite low, 1.6 gram. Creatinine was elevated, 2.5 milligram. And the complement C3 was 48 milligram per liter. So we are dealing with a child who is having a nephrotic syndrome with anemia, high ESR, low C3 complement, and she is a 10-year-old female. And so we are making a diagnosis of when we say that there is acute nephritic syndrome, dysmorphic RBCs more than 20% with RBC cast, acanthocytes or G1 cells which are more than 5%, proteinuria which is usually more than 500 milligram, and leukocyturia. This defines acute nephritic syndrome. But our index child here is having nephrotic proteinuria also, and so we have to make a diagnosis of nephrotic syndrome, girl child with high ESR. I know that everybody in the audience is now having the diagnosis with them. So let us see what happened to this child on further evaluation. And the renal biopsy was done, and the lupus workup was done, which was showing a crescentic glomerulonephritis, and it was a class 4 lupus nephritis. So this is how the urinalysis itself and the investigations which we are planning are giving you a clue as to the diagnosis even before you become too invasive. Let us look at the second child, a 3-year-old boy who presented with puffiness of face and feet. Mother noticed that he was not active. He had actually gained almost 2.5 kg in 1 week time. There was no hematuria, and his urine stream was good. There was no family history of renal disease. He was growing normally, and his blood pressure was normal. But his urine was quite frothy with 3+ proteinuria. There was lipiduria, and PC ratio was 5. And so the diagnosis in this child is very obvious, that is, this child is having nephrotic syndrome. And a very special cell in this disease is this. This is for the interest of postgraduate students. That is the oval fat body, which is actually the renal tubular cell that is loaded with fat globules. And it is also this oval fat body or Maltese cross is what you see under polarized light. And so this child was having nephrotic syndrome. Then let us look at another 2-year-old boy who came with anuric renal failure, which was preceded by respiratory infection, which was treated with amoxicillin for 7 days. No past or family history of renal failure. He was having 1+ protein, plenty of WBCs, WBC cast, and eosinophils in urine. He was anuric, and so we had to start him on dialysis. So this is acute kidney injury with failure, and whether it is because of the infection that he had or the drug which was causing the problem. His liquid biopsy showed leukocyturia with cellular cast, and the Hansel strain is showing eosinophil cast in urine, and the interstitial infiltrate and leukocyte cast, some of the leukocytes being eosinophils, is what is seen on renal biopsy. So this child was having acute interstitial nephritis as the cause of renal failure. And it is to be underscored that the poor man's biopsy was giving us a clue that this is acute interstitial nephritis. And so this urine is actually the real liquid biopsy, the final product from the renal factory, a telescopic view of renal secrets we are getting. That is a non-invasive biopsy specimen, and the kidney is biopsying itself so many times a day. And this simple diagnostic tool we are actually missing in our office practice, and we have to look at the urine. Renal injury is leading to abnormality in the urine, both in quantity and quality, and the whole lot of cells which are seen, or the cast and the crystals that you are seeing under the microscope, is giving a clue to us. We have to do it correctly performed on fresh urine by an experienced person, experienced clinician. Definitely urinalysis is going to help us in making wonderful diagnosis. As I have already told you, our renal medicine is physiological chemistry. Physiological chemistry was the earlier name that was given before nephrology was given to this specialty. There is no single test to interpret all functions. Functional assessment should be done as indication demands, and interpretation should be based on specific condition of the patient. Overall assessment is important rather than isolated values. The number matters for this decrement of GFR. GFR as a number is important for us because the decrement of GFR by more than 50% has to happen before biochemical abnormalities actually set in. So this also we have to remember. So let us have a look at the chemistry of urine. Normal urine pH is between 4.5 to 8. The kidney is having such a wide scope of acidification and alkalinization possible to maintain the internal homeostasis. We will be looking at the various chemical substances in urine, and the urine dipstick is actually very good test to assess for all these pH, specific gravity, protein, blood, glucose, ketones, all that is going to give us a lot of information. And so assessment of kidney function, if you look at it more closely, it is an assessment of glomerular function and tubular function. And glomerular function will be we will be actually looking at the markers like creatinine or cystatin C, and the number calculation of GFR is very important. And the proteinuria assessment also is going to help us in assessing the glomerular function. And the tubular function is assessed by concentration and dilution test and assessment of acid-base handling. I will not be going in depth into the tubular functions because the other speakers will be dealing with that. When will we need to assess the glomerular filtration rate? That is to diagnose acute kidney injury or CKD. In AKI, actually, the GFR assessment may not hold very promising because it is actually fluctuating and changing. And at the same time, the creatinine, the marker which we are using, is getting diluted because of the fluid overload. That is a common accompaniment of AKI. And in CKD, actually, we can start the early intervention to prevent the progression of CKD by having the number from the beginning. And also based on the number, we make the modifications of drugs and monitor the side effects of drugs. So is it the time to leave creatinine behind? Is a question that is being heard in all these forums for the last so many years. But we do have only this creatinine at our fingertip all the time, available in almost all the labs. The cystatin C, we know that it is a logical marker that is not affected by muscle mass and not secreted by the renal tubule as is the creatinine. But the problem is it is not available in all over the place, and India being the country we know where this access to the medical care itself is limited. So such investigative, this newer investigative modalities will become universal only after maybe some time. So how to assess GFR in children? GFR is assessed by modified Schwartz formula. We all know that. Then there is the CKD equation which has come, which is actually utilizing both creatinine and cystatin C. The newer methods to estimate GFR is actually using a beta trace protein or this fluorescein-based assays which are coming up. But these are all molecules which are at the research level and not to the bedside. Then acute kidney injury criteria, the PROC criteria is now coming up after the P-rifle and KDIGO, that is an advance that is coming, and the Ninja that is actually making us quite aware of the AKI, the drugs, and in the means what harm we are doing to our patients by not identifying the nephrotoxic medication exposure in time. So Ninja is actually an eye-opener that had happened, and I am sure the AKI discussion, they might have already discussed these points. And this point of care testing in AKI is coming up as part of the 0/25, the venture by ISN, and this is actually to identify the AKI very early, and even saliva-based biomarkers can be used. And for this POCT devices can be this Abbott and Nova devices. I'm not sure how much these devices are helpful for us in the field testing of AKI in our this peripheries, but these are certain things that are there, and maybe we can actually start using these POCT devices if it is available to us. Biomarkers in AKI is actually becoming a crucial tool for early diagnosis, but the earliest and most commonly used one till now is the serum creatinine and urine output. The limitations of serum creatinine we all know, and the urine output can be affected by the hydration status and the use of diuretics. So the focus is now shifting in the pursuit of a better biomarker, that is novel biomarkers of AKI that we want to look at. And the AKI biomarkers, there are functional biomarkers, there are damage biomarkers are there, but how many of them I have translated from bench to bedside is a big question. So the excellent performance is there in studies, but we have to have still there is a long way to go. And so the biomarkers, possibly the functional as well as damage biomarkers may help us. And in the future, we would be able to use some of them at least. And the only one that is relatively into practice is the NGAL in AKI, and the cutoff is also there, and some of the centers, they are having access to NGAL. And so NGAL as a marker, especially so in the pre-injury, during this point, pre-injury setting, that is prior to cardiac surgery, you do the baseline, and then after the cardiac surgery, you do it again, and you're able to diagnose who is going to go for severe AKI and kidney requiring renal support therapy. So let us analyze the renal chemistry of this child. A 10-year-old female child presented with generalized edema. Physical examination revealed a blood pressure of 104/70, and she was edematous. 2+ protein with numerous hyaline and waxy cast. Protein creatinine ratio was 3. Hemoglobin was 16 gram, and albumin was 1.6. Urea was 62. Calcium is 6.8. Sodium is 126. So we can see that this child is having severe hypoalbuminemia. The urea is elevated, but the creat is normal. Calcium is low and sodium is low. And so the corrected serum calcium, the formula is to be applied because it is dependent on serum albumin. And after applying this, it is coming as 8.72, which is reasonable. And the child is having a lot of edema, and sodium low may be dilutional hyponatremia. And there is hemo concentration also. There is pre-renal azotemia, nephrotic range proteinuria. So the lab is actually giving us a definite clue regarding what exactly is happening inside. We have to look at the lights and diseases. A 10-year-old child with diabetes mellitus presents with ketoacidosis. Sodium is 125, her potassium is 3.2, chloride is 104, glucose is 800, blood urea is 56. Do we have to correct her sodium? That is the question. So the corrected sodium here is actually, you know that this is because of the shift of water from one compartment to another because of the hyperglycemia that is there, and the shift has to be corrected. And after application of the correction factors, it is 136.2. And so this is actually not a true hyponatremia. And sodium is actually measured by flame photometry in the usual labs where pseudo hyponatremia becomes a problem. And sodium sensitive electrodes are to be used, and that method will help us to circumvent the problem of pseudo hyponatremia. Then dilutional hyponatremia, one child we have already seen. Translocational hyponatremia is what we are seeing here. So this Dr. Sangeeta was asking me to look at the advances, and the system biology and omics technique in kidney disease is what is evolving these days. And so let us have a quick look at that. There is something called Kidney Disc Precision, this project that is coming up, which is actually to redefine and reclassify the diagnosis and understanding of chronic kidney disease and AKI. This is a new, innovative initiative that is combining this. You are looking at the clinical presentation, and then you will be having a kidney biopsy, a deep molecular phenotyping typing will be done, and digital pathology and relevant clinical outcomes are assessed. And the kidney biopsy tissues will be interrogated with the use of multiple levels of omics technology. And what is this omics? We will be talking shortly. So this this advancement has helped us to identify this critical cells and pathways and targets, which can be the point of novel therapy application. So we are having such advances that are happening, which may be translated in future, so that we will be able to identify the disease at a very early phase and have technologies to detect the disease and intervene and apply medication so that we will be having a better renal disease outcome. So this omics is actually the proteomics, peptidomics, this metabolomics, all this omics. That is the fashion for today in research. And so we hope that this will help us to actually get on better with our disease management and halting the progression. So what is this urine peptidomics? So proteomics we were hearing a lot, and the peptidomics is actually indicating that initially whenever there is a damage to the glomerulus, we know that there can be a damage to the glycocalyx, there can be a glomerular base membrane thickening, there can be podocyte effacement, then matrix accumulation that is happening in the extracellular compartment. And so all this, when it is advanced, that is what we are picking up now. So, but if we are able to pick it up at an early phase, when you will be seeing some protein molecules which are actually broken down, and the peptides which are there in the urine, we are able to have them identified by the gel electrophoresis analysis. And the peptides, once it is analyzed, the pattern of peptides will give us an idea regarding what exactly is happening, if it is normal, abnormal, And the abnormality is indicating that actually the protein is that the disease is in its early phase. The peptides are actually more stable compared to proteins. And so the detection of the peptidomics detection is better in assessing the disease once it is starting at that starting point itself. So comparing it with the renal biopsy, the histological, so we are able to identify this urine peptidome analysis that will be actually picking up the disease much early than the renal biopsy. Biopsy is invasive, this is non-invasive. So a histological assessment versus the peptidomics assessment and comparison is telling you that we are able to pick up the disease at the signaling molecular level or the signaling pathway level before the real clinical presentation and advancement when there is a point of no return. That is the problem with most of the CKD. We are actually detecting them at a point, the point of no return is already reached. Then this congenital anomaly of kidneys and urinary tract, already the anomaly is there. And in PUJ obstruction, that was the first peptidome study in urine was done in neonates with PU junction obstruction. And actually an invasive surveillance mechanisms. We are doing so many investigations, so many times the renogram, nuclear scan. So this urine peptidomics will tell us which patient is in need of surgery. And so we can decide based on the urine peptidome analysis in the newborn period itself. So, and then PUV. So we know that 30% of children with PUV are going to progress and they are going to require a kidney transplant in future. So who is this? The 3 children undergoing this fulguration today, one of them is going to progress to ESRD and will require a renal transplant. But which one? This also can be assessed by the fetal urinary peptidome analysis or the baby's urine peptidome analysis. And 26 peptides have been found out, which are actually associated with PUV and ESKD. So this genomics, epigenomics, transcriptomics, this regulomics, proteomics, metabolomics, these are all the omics that is there for us, and all these researches that are happening at these levels that may be actually revolutionizing the nephrology as well as other fields. And so then another thing is this genetic analysis which has come up. So we know that previously we used to do renal biopsy in all congenital nephrotic syndromes, but now no, we will be doing a genetic study. So many small babies who actually had to undergo a renal biopsy, invasive, has been escaping because of the genetic study which is being done and the next generation sequencing, the exome analysis. So we are actually walking into an era where personalized medicine is coming up, and genomics and all the other omics technologies will be actually replacing what we are doing now. We are very crude in this analysis of kidney disease at present if you look at the future. And so the kidney disease are silent or subtle with clinical symptoms and signs which are so subtle. Compartmentalized approach is good as signs and symptoms are stereotyped, and early diagnosis optimizes the outcome. Clinical evaluation coupled with precise diagnostic and intelligent interpretation by a good clinician is the prerequisite for good patient outcome. Targeted testing, absolutely essential for the future of personalized medicine. And we all remember, pursuit of excellence is a continuous process that never ends. Thank you.
Thank you very much, madam. It was an excellent presentation. So we'll be having a discussion later. So we'll be moving on to our next topic, which is an approach to rickets. We all know rickets is a disease which has been described in mid-17th century. Despite the fact that several preventive measures are available, it's still one of the common diseases. So to talk about approach to rickets, I call upon Dr. George Matthew, who is an assistant professor in nephrology, pediatric nephrology in CMC Vellore. His area of expertise is nephrotic syndrome. And he's also having over 11 indexed publications. We welcome you, Dr. George Matthew.
Good morning, everybody. Thank you for the opportunity for me to present a complicated topic at this scenario. So Just hold on a second before when I set up my presentation. And I hope I'm audible and my slides are visible. Am I audible?
Yes, Georgie, you are.
Sure. So without further ado, I know that I have about 20 minutes. So I will start on this topic of refractory rickets approach and management. As we know, rickets is actually a very common scenario that we see in regular clinical practice, whether in pediatrics or pediatric nephrology. So I would like to take you through step-by-step approach and tell you about my understanding of refractory rickets and how to manage the condition. So this will be the overview of the presentation. So as we know, and as we all have read in our undergraduate, postgraduate, and the super specialty studies, we know that vitamin D is one of the cornerstones in the metabolism of calcium and phosphate. So first I will go through vitamin D homeostasis. Vitamin D homeostasis, as we all know, the sunlight converts the 7-dehydrocholesterol into vitamin D3, and it is hydroxylated in the liver at the first step, and then it undergoes hydroxylation at the kidney. And then once it gets hydroxylated into the calcitriol form, it activates the vitamin D receptor, and along with the other factors of activation of vitamin D receptor, it finally culminates in increased calcium reabsorption into the blood, whether it's from the renal tubule or it's from the intestine or from the bone. It acts to increase calcium levels in the blood. And then once its levels are adequate, it undergoes metabolism by two metabolic pathways into multiple inactive forms, either by the CYP3A4, as you can see on the top, or the CYP24A1, which is the 24-hydroxylase enzyme. Okay, so this is about vitamin D homeostasis. And the next would be the calcium, which is one of the key players in this one. In the pathophysiology of rickets, calcium is absorbed from the gut by the TRPV6 receptor, and then once in the blood, the PTH is the key hormone which regulates the calcium metabolism. The calcium levels in the blood, that is particularly the ionized calcium levels in the blood, are sensed by the C cells of parathyroid levels and the calcium sensing receptor, and it stimulates hypercalcemia as a potent stimulus for PTH release. So what does PTH do? PTH activates the vitamin D as well as FGF23. It helps in increasing calcium reabsorption from the intestine by indirect action via vitamin D, and it also increases calcium reabsorption from the kidney and causes phosphate excretion. Then the next key player in the metabolism is phosphate. Phosphate. So phosphate is absorbed by the NaPi2b receptors from the gut, and then in the blood it undergoes circulation, and it exists in equilibrium by the action of three different target organs, which is the bone, which excrete FGF23, secrete the osteoclast, secrete FGF23, which causes renal excretion. The PTH also causes renal excretion, and the kidney also. Kidney is the final organ by which the phosphate is excreted. Around 1 gram of phosphate ingested during the day, about 800 grams, 700 to 800 grams excreted by the kidney, and about maybe 150 to 200 milligrams are excreted by the from the gut. So this is what our current understanding of this homeostasis. In case of any doubts in between, please feel free to add in the chat. I will try to take the questions at the end. So I'm going on to the next slide. So we all are familiar with the clinical features of rickets. I don't need to tell you all pediatricians, my colleagues, seniors, everybody is very familiar with these. So I'm not delving into the clinical features of rickets. Coming to the pathology of rickets, this is a cross-section of growing bone or a long bone in the child. So from the metaphysis, we have the between the metaphysis and diaphysis, we have the epiphysis or the growing area of the bone. We have the growth plate from distally from the resting zone, proliferating zone, and the hypertrophic zone. We will see in detail what is happening histologically. So the left panel shows the normal. The B panel shows the normal histology of a growing bone. So in the epiphysis, you can see the growth plate. So in growth plate, actually, you can see 2 to 3 different areas. So you can see the proximal, the area which is most closest to the epiphysis. It's a little, smudgy, and you cannot see the cells separately. And then while you're traveling towards more proximally, you can see the chondrocytes actually maturing and arranged in a columnar form. This is actually the most important part in understanding what is happening pathologically in rickets. So you have the area of maturing of chondrocytes from the resting plate towards the metaphysis, where they undergo hypertrophy and are presented in columnar arrangement. They also undergo vascularization, and then slowly they undergo mineralization after the chondrocytes are, undergo apoptosis. This forms an orderly pattern of growth of bone. This is how bone grows, and this is how children and all of us increase in height. But in rickets, what happens is that the chondrocyte apoptosis, chondrocyte vascularization, and mineralization all are in disarray because of multiple factors, which we will come to later. And this shows an irregular or disorderly form of growth plate increase in size. I see a raised hand. Is there any doubt?
Actually, you can proceed, sir. We can have a discussion at the end.
All right, sure. Thank you. So there will be a disorderly or a disorderly proliferation of the chondrocytes, as you can see in the right-sided panel, where the columnar arrangement is lost, and also the hypertrophy is irregular when compared to the other one. Okay, so this leads to all the manifestations of rickets as we know of. What as I understood during my MBBS and MD times, we knew that rickets is typically classified as calcipenic rickets and phosphopenic rickets. But recently, through by reading, and through recent research, it is being clear that hypophosphatemia is actually the common denominator of both the forms of rickets, whether it's calcipenic or phosphopenic. Ultimately, renal phosphate wasting and hypophosphatemia cause the impaired apoptosis of chondrocytes in the growth plate, and that is what leads to all the bony manifestation of rickets. So when coming to the pathophysiology, we know that there is low 25-hydroxy vitamin D, either by poor nutritional intake or by poor sunlight exposure. This leads to low calcitriol, which impairs the calcium absorption. And finally, this leads to drop in calcium below the individual set point. And this calcium, as I told before, it is immediately sensed by the PTH parathormone, and that leads to secondary hyperparathyroidism. This has 3 major implications. So what are those? Number 1 would be renal, that would be reduced calcium and calcium excretion and increased phosphate excretion, leading to phosphaturia. Increase intestinal calcium absorption by increasing 1-alpha hydroxylase activity, and also the osteoclasts are stimulated by bony reabsorption, and all try to increase the calcium above the individual set point. The unnecessary or unwanted side effect or the casualty in this battlefield is phosphate, and this hyperparathyroidism leads to phosphaturia. And in case these 3 metabolic compensatory mechanisms are fail, they lead to hypocalcemia as well, leading to persistent hyperparathyroidism. Now, how does this translate into rickets? As I mentioned, all these bony changes are because of the hypophosphatemic complication, that is the rickets, rickety procedure, growth plate widening, osteomalacia, etc., etc. And hypercalcemic complications are irritability, neuromuscular irritation, then cardiomyopathy, and even tetany and seizures. So how do we approach rickets? So whenever we have a patient with rickets, clinical signs of rickets, with definitely there will be increased alkaline phosphatase. The only disease with low or normal alkaline phosphate and bony changes is usually hypophosphatasia, which is extremely rare disease. So suppose we have a child with these clinical signs and increased alkaline phosphatase and X-ray changes, first and foremost, we have to make sure that chronic kidney disease or renal tubular acidosis is excluded, because the management is entirely different. So as I mentioned, the common denominator phosphate is almost always low or normal in any patient with rickets. The only patient with high phosphate and rachitic changes is usually chronic kidney disease, that we have already excluded in the first step. So Once we see that the phosphate levels are low or normal, we look at the PTH activity. If there is hyperparathyroidism, we know that pathophysiologically it can only be because of hypocalcemia or drop in calcium below the set point. In case the calcium levels or PTH levels are low or normal, we know that the predominant pathophysiological mechanism in this situation is the phosphopenia. So once phosphate is low, we have to find out why the phosphate is low. Is it because of dietary deficiency or because of renal losses? If because of dietary deficiency, there is a separate algorithm. If it's because of renal deficiency, there are renal losses. There are two ways. The FGF23 causes renal loss, and also isolated proximal renal tubular diseases also can cause renal loss of phosphate. So when there is low urine levels of phosphate, that means it's not because of kidney wasting, and it's predominantly because of insufficient intake or malabsorption. These are the causes. And when there is renal losses, you see whether it's FGF mediated or primary tubular mediated, which is in Fanconi anemia or hereditary hypophosphatemia rickets with hypercalciuria, where the NaPi2c receptor itself is mutated. Suppose there is high levels of PTH, we know the stimulus of PTH is low calcium. So with the levels of calcidiol and calcitriol, we can make the differentiation between the different types of VDDR, vitamin D dependent rickets, or nutritional vitamin D deficiency. But for lack of time, I will not be going into detail of these. If someone has a doubt, can ask at the end. And then some of the diseases are genetically mediated, like hypophosphatemia rickets, HHRH, Fanconi anemia, and many hypophosphatemia rickets are genetically mediated. And so these genetic tests will also be helpful in this situation. Okay, so now that we know that phosphate is the main culprit, so which all problems of phosphate can cause refractory rickets? So first and foremost, there is impaired dietary availability or NaPi2b, which is extremely quite rare actually. And then we come to the predominant metabolizer of phosphate, that is a kidney. So we lose either by primary Fanconi syndrome or HHRH or IAH, idiopathic infantile hypercalcemia. Then the other causes are FGF mediated, which is autosomal dominant or X-linked or autosomal recessive, and also fibrovascular dysplasia, McDonald-White syndrome also play a role in FGF mediated phosphate homeostasis. Okay, all these lead to hypophosphatemia and rachitic features. Then the other disorders are vitamin D homeostasis. So if there is dietary deficiency or poor sunlight exposure, it comes in the very first, the rightmost part of this pathophysiology diagram itself. Then we have VDDR1B, which is because of impairment in liver hydroxylation, VDDR1A because of impairment in kidney hydroxylation, VDDR2A if the vitamin D receptor is abnormal, and VDR2B, the cofactors for the receptors are abnormal. Then we also have, suppose when there is increased metabolism of the vitamin D calcidiol or calcitriol, we have vitamin D DR type 3. So the disorders of calcium homeostasis, there can be abnormalities in the calcium absorption or dietary calcium deficiency, and then renal losses, which are predominantly mediated by vitamin D deficiency or vitamin D dependent rickets. We also have very low vitamin D levels when the calcium reabsorption from the gut is poor in VDDR2. So it affects the calcium reabsorption by TRPV5, also TRPV6, and also calcium reabsorption from the bone. So all these lead to hypocalcemia and hypocalcemic manifestations. So putting just one slide to all of you, just to tell you that calcium levels are usually slightly lower in case of infants and less than 6-month-old children, and then they climb up to around 9 for all the other ages. Phosphate is actually very important for infants and neonates, especially higher levels of phosphate is actually normal. Suppose you see a 3.2 or 3.5 levels of phosphate in a 3-month-old, 4-month-old, we actually have to pay close attention to that because that is actually in the hypophosphatemia range. So also you can see that because of immature tubular function, the TMP GFRs are also higher in the infantile age group, and it slowly matures into lower values as the child grows. So coming to case scenarios, so you have so now that we have understood, all the participants are free to put put the answers in the chat box. I will wait for a few moments to respond. So we have a 2-year-old male child with excessive bowing of lower legs, was exclusively breastfed till 1 year, poor socioeconomic status, no recurrent diarrhea. Child has all features of rickets, and there is a liver 1 cm below the costal margin. So these are the investigations. So what all are the predominant findings that you see, and what is your possible diagnosis? I'll wait for a 10-20 seconds for any responses from the audience if there are. Okay. So currently audience does not seem to be in the appropriate state of mind to respond. All right, I will proceed with the interpretation. So you can see there is hypochromic microcytic anemia. There is slightly low calcium. There is definitely low phosphorus. Okay, somebody has responded vitamin D deficiency. Very good. Okay, there is high alkaline phosphatase, vitamin D deficiency, and parathormone is appropriately elevated for hypocalcemia and vitamin D deficiency. So yes, this will be definitely nutritional rickets, as other features are there. So low phosphate, low normal calcium, normal renal function. So the from the various hospital-based surveys, we have these numbers about 40 to 90%. These are because of hospital-based surveys, because there are a referral population. A recent comprehensive national nutrition survey has pegged the rate of vitamin D deficiency as between 14 to 24% in Indian children. Okay, so how do we manage vitamin D deficiency? So we have initial therapy, we have to give daily dose for 3 months, and then followed by a maintenance therapy. And along with that, do not forget to add calcium daily requirement. Okay, so whenever we are looking at patients with vitamin D deficiency, always make sure that non-nutritional origin rickets are not there, because there are some cases in the family, underlying CKD, CLD, malabsorption, alopecia, cataract, polyuria, etc. for this one. And also make sure that these patients are not resistant to a prior vitamin D therapy. How do you monitor these patients? We monitor them by X-rays at 4 to 12 weeks, and also vitamin metabolites at 12 weeks, and continue therapy if there is no radiological clearing or metabolic normalization. So there is a recent guidelines which are come from the Indian Pediatrics. So come to the next case, again similar 2-year-old, but has a familial history and also dental abscess. So what is the possible case scenario in this one? First, possible diagnosis in this one. Okay, you can see this is normal renal function. There is very low phosphate, and vitamin D levels are normal. So this we are dealing with some form of hypophosphatemic rickets, because there's a family history. There's a possibility that X-linked disease is there. So hypophosphatemia, family history. So we may be dealing with the X-linked hypophosphatemic rickets. So this is the pathophysiology of X-linked hypophosphatemic rickets. I'm not going into details of this one. In X-linked hypophosphatemic rickets, you may see dental abscess. This pathophysiology, you can see craniosynostosis in some situations where FGF2 mediated abnormalities. You can see nephrocalcinosis in some scenarios like clotho deficiency, as sensitive for A1, so multiple mutations. You can also have hearing loss in this. Okay, so conventional management of hypophosphatic rickets, which either by phosphate. So make sure whenever you are looking at phosphate, you give 4 to 6 times in a day. Try to normalize alkaline phosphatase. There's a recent guidelines for management of hypophosphatemia rickets. You also need to add on calcitriol for the appropriate management. Also, calcium needs to be given in these situations as well. So the current guide standard of therapy is burosumab, which causes significant increase in height and reduction in the ricket severity scores. I'm not going into detail. You can look at these wonderful references. And with burosumab, you will be able to target normal alkaline phosphate for age. And thing is that it is extremely costly and not available currently. So we may have to wait for till this becomes appropriately available. Okay, so we have a next case. A 2-year-old child and a younger sibling with hypophosphatemic rickets. So any other comments here? Okay, we have further clues of alopecia and dental caries. Yes, so VDDR type 2A is the diagnosis in this case, where you have, these scenarios, this will be the calcitriol levels will be low in VDR1. That's how we make the differentiation. It is a very difficult disease to manage, require very high dose of calcitriol and also other minerals. I mean, also we have to supplement calcitriol and calcidiol, calcium and phosphate. Some children with severe hypercalcemia may even require calcium infusion. Okay, so we have another child for polyuria, polydipsia. So here the catch is the low bicarb. Okay, the vital functions are low, but the bicarb is low. That means metabolic acidosis. And if I throw a liver 5 centimeter into this patient, so it may be a Fanconi syndrome. Okay, so maybe proximal and distal renal tubular acidosis. I'm not going into any detail of these things. You are all efficient and proficient in the management of renal tubular acidosis. So long-term follow-up, distal renal tubular acidosis do have some amount of chronic kidney damage as well. Okay, so coming to the next case scenario, a 2-year-old male child with again rachitic features. So here the catch is normocytic normochromic anemia with a deranged renal function. A 0.9 creat is abnormal in a patient who is 2 years old. So in renal tubular acidosis, you have hyperphosphatemia, low calcium, and acidosis leading to bone resorption. All these changes typically affect that at low GFR. I'm not going into management of CKD MBD. So overall important clinical features you have to look at is symptomatic hypercalcemia, tetany, alopecia, phenygomyelia, symptoms, cafe macules, facial dysmorphism, clinician anomalies, hypercalciuria, polyuria, polydipsia, etc. So the biochemical workup of a nutritional rickets, this also I'm not going into the detail. You have to look at all the metabolites, make sure creatinine and bicarbonate are normal. That is in the first line investigation itself, and the next line investigations are as mentioned here. Okay, so I'm not going into details of this again because of lack of time. So this is the approach to rickets. I just wanted to reiterate this scenario. And some rickets mimics, that is metaphyseal dysplasia, Blount's disease, achondroplasia. They are also mimics of rickets with normal, all metabolic parameters will be normal. Okay, so take home points are: take a good history to rule out non-nutritional rickets, approximate systemic examination, judicious use of laboratory investigations. You pay close attention to renal function and bicarb levels, and meticulous and age-appropriate interpretation will give you results in most of the refractory rickets. Thank you.
Thank you, Dr. Georgie, for a wonderful presentation. There is a question: is there any difference in the speed of action of vitamin D versus calcitriol?
Okay, calcitriol is the active form, so it is supposed to act slightly earlier. I'm not sure exactly about the half-life and time of action, but in a child with hypercalcemic seizures and severe vitamin D deficiency, yes, we can use calcitriol initially in case there are, unless there are any other contraindications. But ideally, hypercalcemic seizures, the best currently you start with calcium supplementation, and then start on management with vitamin D and calcidiol or calcitriol. As you know, all these drugs require action at the genetic level to improve the calcium reabsorption and this set point. All of them take their own time. They are not magic drugs to reduce the hypercalcemia in 1 day or 2 days. Initially, you may have to supplement IV, and even there are even recommendations of reports of patients requiring calcium infusions for long time in case of very severe VDDR to prevent seizures, tetany, and all this management.
Thank you, Doctor. So as we are running short of time, we will move on to next thing. Thank you very much, Dr. Susan Uthup and Dr. George Matthew, for your excellent presentation. Thank you.
Thank you, all of you. I'll be briefly standing in as host in place of Sangeeta. She has some important work. So I'll also be moderating the next session. For the next session, we have 3 very important topics. And the first topic is on renal pathology, interesting case series. And for this, it's my great pleasure to be introducing Dr. Anila Abraham. She needs no introduction. She is the director at Renopath, Center for Renal and Neurological Pathology at Chennai. She's widely regarded as one of the best nephropathologists in the country, and many of us do turn to her when we are in doubts. And thank you, ma'am, for joining us. And I'll now give the stage to you. Thank you.
Can I share my screen?
Yeah.
I think you need to come out of it.
Yeah, I've stopped sharing. You can share your screen now.
Yeah, is it visible?
Yeah, it's visible.
Okay. So, and is it moving? It is not moving here. Uh-oh. Now is the screen moving?
No, ma'am.
I'll come again. Yeah, I'll do it again because now has it moved to the first case? All right. I'm not making it a full screen because probably there's some problem. Anyway, the next 15 minutes or so, keeping up with the time, I would like to discuss just 3 cases on tubular interstitial diseases of the kidney. We invariably end up giving a lot of importance to glomerular pathology, but there are equally, or in fact, I would say more fascinating pathologies in the tubular interstitium, and that too in children too. So the first case is an 8-year-old boy who presented with vomiting and decreased urine output for past 5 days. He had a low hemoglobin and his biochemistry for urea and creatinine were markedly elevated. An ultrasound showed that both kidneys were of normal size, but it had multiple small calculi in the left lower calyx. There was no hydronephrosis and KUB was normal. So it's radiolucent stones that he had. Now with this history, we went back to the mother and they found out that yes, he did give a history of colicky abdominal pain off and on, and which she just ignored as part of growing up or worms or whatever, and it was never investigated. And they do not know of any renal disease in the family. The nephrologist had a clue based on the radiolucency and decided to biopsy the kidney. And this is the biopsy findings. I have just focused on the tubular interstitium. The glomeruli were absolutely normal. And what is staring at you on the screen are these beautiful flower-shaped muddy brown crystals, which are arranged like a radial spokes of the wheel. This is actually in the interstitium, and it is eliciting a giant cell reaction. Basically, the macrophages are trying to engulf it because this is a foreign body to the interstitium. And you can also see similar crystals in the tubular epithelial cells if you look carefully. Now, this is the same view that I have just put on the polarizer. Under the polarized light, there are many more crystals, tiny crystals studding the tubular interstitial compartment. And this characteristic brown color is very suggestive of a disease, and that is DHA crystalline nephropathy. Now, DHA crystalline nephropathy is an autosomal recessive disease where there is a deficiency of the enzyme, the APRT enzyme, which is a main part, which plays a main part in the metabolism of adenine. So in the absence of this enzyme, adenine gets metabolized to 2,8-dihydroxyadenine, 2,8-DHA, and this abnormal protein or abnormal constituent is under physiological conditions, it's insoluble. So it will crystallize and form calculi within the kidney. So what about the presentation? As so rightly that Dr. Susan had mentioned in her talk, when she spoke about the crystals in the kidney and in the urine, she was saying that we normally consider that a renal stone disease is of the adults, not so. We do see this in children. We have a couple of cases of DHA among children too. So it is important to look, and we all know about oxalosis. That doesn't need any discussion further. So what are the clinical issues of DHA crystalline nephropathy? It's a wide range of presentation as far as age is concerned. Typical history of recurrent nephrolithiasis as they grow older. And if it's undetected or not treated, they go into progressive kidney injury. And most important for us to know is they recur in the allograft. We have 2 kidney graft nephrectomy, graft biopsies in which we diagnosed DHA crystalline nephropathy. The native kidney disease was never known because the patient was never picked up on time. And by the time he presented with CKD, the kidneys were far too small and shrunken for the nephrologist to biopsy him. And never had it occurred that it could be DHA. And promptly, just like oxalosis, it recurs and causes renal allograft failure. Now, how do you diagnose this? Either way, you can find out about the activity of the enzyme in the RBC lysates, or a definitive test would be a genetic study. And what is a good part of this disease is they respond to allopurinol. You wouldn't call it treatment because it doesn't cure the patient, but allopurinol will block the metabolic pathway and prevent the formation of DHA formation. I'm not going into the details for lack of time. And they usually have an excellent prognosis if the treatment is started before renal failure develops. That is invariably in childhood where the stones start forming. Once they reach adulthood and there is tubular injury and tubular irreversible fibrosis, then there is no point in giving allopurinol. This boy, the tubular interstitium, except for the crystals, did not show much of interstitial fibrosis and tubular atrophy. So he's doing extremely well. Now, the other type of crystal that you see commonly in children, which is polarizable, is oxalosis, but they are radio opaque. You can immediately diagnose them in imaging studies. What are the other crystals that we see in the kidney? This is DHA on the left, like in our case, calcium phosphate crystals, and they have a typical purplish pink color. You cannot miss those crystals. They do not polarize. And the third type, the common type, is the oxalate crystals, which oxalate crystals are so bland and they do not have any color. In fact, if you don't look carefully, you can miss them, whereas they polarize. So DHA and oxalate are polarizable. We all tend to imagine or tend to believe that any crystal that is polarizable is oxalate. Not so. DHA is beautifully polarizable, as I showed. The difference on light microscopy you can pick up with the color, the muddy brown color of DHA. Now, this child, we confirm the diagnosis of DHA crystalline nephropathy both by enzyme study and genetic studies. He is now doing well on allopurinol. Now, moving on to the second case. It's a 13-year-old girl who complained of loss of appetite and weakness and swelling on either side of the neck, which turned out to be cervical lymphadenopathy. And her pediatrician, on investigation, found out a creatinine of 2.6 and was immediately referred to the nephrologist. And these were the other findings: anemic, total count normal, ANADS DNA negative, and ultrasound showed bilateral bulky kidneys. The pediatrician's clinical suspicion was tuberculosis. But the nephrologist biopsied the kidney, and the 4 stains, which are our bread and butter and which we routinely do on all biopsies, is H&E, PAS, silver, and trichrome. I focused on the same area. The diagnosis is clinched on the silver stain, where you have this typical pattern, what we call as a storiform pattern of fibrosis, where actually this is a type of fibrosis which just disappears, unlike the interstitial fibrosis that we see of any other cause as part of scarring, where scarring, the collagen is almost, it'll never come back to its normal form, and the tubules are atrophied. Here, the tubules are actually separated out, widened out, and that's why the kidneys look bulky. And the other clue is the dense inflammatory infiltrate in the area of fibrosis, and the inflammatory infiltrate consists of lymphocytes, plasma cells, and eosinophils. Another characteristic feature is the IF finding on IgG. Normally, where you see the immunoglobulins, it's on a glomeruli, right? Like it's IgG, it's in a membranous, it's on the capillary loop, it's IgA, it's in the mesangium. But this is a condition where you have intense and extensive immunoglobulin depositions in the tubular interstitial compartment. So all these are taken at the lowest power. This is a globally sclerotic glomerulus, but all the tubular basal membrane, the small rings, and the interstitium are beautifully highlighted by IgG. So this is very diagnostic, and the disease is confirmed by doing an IgG4 immunohistochemical stain, and the cutoff is 10 IgG4 cells per high power field. This had more than 50 to 60 IgG4 cells per high power field. So the diagnosis is IgG4 related tubular interstitial nephritis. And the hallmarks is the inflammatory infiltrate, the fibrosis, and the tubular basement membrane immune deficits that we saw on IF for the diagnosis. Now, what is IgG4 related disease? This is a disease usually that is described in middle-aged men, though you can get it in women, and 50 to 60 is the usual age. It's unusual, uncommon to see it in children. In fact, this was the only case I've seen it in a child, though in adults we see it often. It is a chronic immune-mediated fibroinflammatory disorder. The pathogenesis is still not known. They don't know if it's allergic or autoimmune, or the debates is still going on. It often manifests with tumor-like masses or as a painless enlargement of multiple organs. Simultaneously, you can have multiple organ involvement, and the symptoms obviously depends on what organs are involved. And the diagnosis typically requires a biopsy. So the importance of a biopsy cannot be underscored here. The treatment is, that's another beautiful thing, with corticosteroids. Nearly 90% of the patients beautifully respond to corticosteroids, and the disease completely disappears. In fact, just a few days back, we had one of an adult patient who had extensive inflammation and fibrosis, but 6 months later, after treatment, there is, except that I know that I have reported the previous biopsy 6 months, nobody would ever say he has not a single inflammatory cell in the interstitium. So that's how beautifully they respond to corticosteroids. And what about IgG4 related disease in the kidney? It could be a tubular interstitial disease, or it could rarely involve the glomerulus where it presents a membranous nephropathy, or it could be in the ureter. And in the kidney, it appears commonly as a mass. So it may be mistaken, especially in the adult, for a renal tumor. And sometimes you may have multiple lesions, in which case, again, it could be a tumor or a tuberculous lesion, because usually their general symptoms also are very suggestive of tuberculosis. And in this particular case, like how we saw, it could be a diffuse renal enlargement, sometimes bilateral, where it could mimic a lymphomatous infiltrate. In fact, if the pathologist is not primed for IgG4 related disease, at the first look with that extensive blue cells in the interstitium, it may be mistaken, and the history of bilateral bulky kidneys and all the other corresponding history, you may wrongly call it as a lymphoma. Whereas, and sometimes the mass may not just be limited to the kidney, it can go through the renal capsule, and the lesion can extend into the perinephric tissue, again, where it can be misdiagnosed as a T3 stage a renal tumor. And the ureter, it can be stricture or a pseudotumor. Now, this is the pathophysiology. Every organ from the meninges all the way, you can have the disease, most commonly being in the lacrimal glands, the salivary glands, the pancreas, and the retroperitoneum. This is the largest case series or the review that I saw among the pediatric population. They had 25 cases of IgG4 related disease in children, mean age 13 years. And unlike in adults, here the predominant was in girls. Nearly half of them had an orbital mass where the eyes bulge out because of the proliferation of the tissue there. And what about our Indian study? This is the only study I got that was from PGI. They had 6 cases of IgG4 related disease in children, of which one was of a tubular interstitial nephritis. Now moving on to the last case. This is a 17-year-old female with a family history of renal failure. Her elder brother died of renal failure at the age of 23, 3 months back. And the family was evaluated, and she was found to be hypertensive with a creatinine of 1.9, trace proteinuria 1.7 UPCR. She she wanted a renal biopsy done because she was very concerned about her health. And here on the left, you can see the glomerulus, which is again unremarkable. The pathology lies in the tubular interstitium. There are no tubules here. Again, here there's complete lack of tubules, small atrophic tubules, what we call as thyroidization, the small with cars are seen. And whatever tubules are there appear abnormal in shape. See, normally tubules are round to oval, right? Here you can see very branching out irregular tubules, like in this particular one, where you have budding, what we call it as budding or outpouching. And this is very characteristic of this disease. And the other characteristic feature is normally the tubules are lined by cuboidal epithelial cells with brush borders, and this is how it looks normally. The nuclei are widely spaced, whereas the upper half, you can easily make out that you can fit in 4 nuclei between these 2 nuclei here. They're very closely packed, and this is typically seen in the macula densa. That is, in the juxtaglomerular apparatus, the macula densa cells look just like this. So we call it as a macula densa-like change of the tubular epithelium. You may have splitting of the tubular basal membrane, which this biopsy did not show. So all these are very characteristic of nephronophthisis, though renal biopsy alone cannot establish the diagnosis. We went ahead and did the genetic study, and we found that definitely this family and the rest of the family too had nephronophthisis. Now, what is nephronophthisis? It's a tubular interstitial autosomal recessive kidney disease. The name is very unique and striking, and it means vanishing of the kidney, because over a period of time, the kidneys shrink and eventually vanish. From 1997 up till now, more than 20 different genes have been identified. So doing a genetic study is not very easy, because you have to specifically look for certain mutations, or if you do all 4, the cost is going to be exorbitant. But a renal biopsy, we have around 10 to 15 cases where the renal biopsy really clinched the diagnosis. So if the lesions are well established, we could make a diagnosis on renal biopsy too. Now, what are the subtypes? Infantile, juvenile, and adolescent. And these are the most common genetic defects. So initially, at least in the first line, we could get them tested. And in the infantile form, it is the cortex that's involved. The glomeruli become cystically enlarged. You don't see much of tubular interstitial changes. Whereas our patient fell into this juvenile category, where the disease is mostly in the tubular damage without any glomerular pathology. Now, imaging studies, though they say cysts in the initial stage, this particular patient did not have any cysts on ultrasound. In fact, after the renal biopsy, I again asked a nephrologist who went back, and she called me back saying, "Ma'am, there are no cysts." But we couldn't do any further dye studies because the creatinine was elevated. But otherwise, ultrasound may not pick up these cysts in the early stages. As the disease advances, the kidney size shrinks. It becomes hyperechoic with corticomedullary cysts, and there is loss of corticomedullary differentiation. Now, nephronophthisis, it's a primary cilia dysfunction. Our primary cilia are the non-motile or sensory cilia that are seen at the surface of all cell types. And in the kidney, they are specifically seen in the apical surface of tubular cells, and they are thought to play a very important role in orienting the cells during cell division and proliferation. So here there is complete disorientation. That is why the tubule sort of forms bulgings and outpouchings, and you have different type of looking cells too. And about 15% of these cases, because it's a primary ciliary disease, you have other organs, especially retinitis pigmentosa is the most common other involvement. And you may also have a part of a lot of syndromes, and I'm very scared of syndromes. I leave it to that. I have a lot of respect for the pediatricians who remember all these names. I cannot even pronounce them, but they are associated with a number of syndromes. Now, treatment, there is no treatment. Renal transplant is the only way out. And this is a large study from Canada, basically a North American pediatric group. And they have compared specifically children of nephronophthisis with the children of other diseases who underwent a transplant. And they have found that there is no difference in the glomerular or the graft pathology is between these two groups. And their conclusion was these patients have excellent outcomes following a renal transplantation. Yeah, with that, I end. Thank you.
Thank you, Anila, for that wonderful talk. We'll now move on to the next talk. And the speaker, the topic is hemolytic uremic syndrome. And we have an excellent speaker, Dr. Shweta Priyadarshini. She's done her MBBS and MD from AFMC Pune, and she's done her fellowship in pediatric nephrology. She's also done pediatric nephrology and transplant immunology research from Boston. She's currently consultant pediatric nephrology at Apollo Health City, Hyderabad, Butterflies Pediatric Specialty Clinic. And also she's the adjunct associate professor of pediatric nephrology for Apollo Health Education and Research Foundation. She has multiple areas of interest, specifically in voiding dysfunction, glomerular diseases, and renal transplant, and has over 13 years of experience in the field. She has multiple international and national publications and book chapters to her credit. Over to Dr. Shweta.
Thank you, Dr. Suganya. Thank you for the kind introduction. I'll have to share my screen, right? Is it visible?
Not yet.
Is it?
You can see your slides.
Now?
Yeah.
Yeah, great. Thank you. So at the outset, I would like to thank the organizers to give me this opportunity to present my talk over here. So today I'm going to talk on hemolytic uremic syndrome. So basically this hemolytic uremic syndrome is a spectrum of disease, and it's pathologically characterized by thrombotic microangiopathy and has a clinical presentation of thrombocytopenia, microangiopathic hemolytic anemia, and end organ injury. So it's classified into four types: the primary or the acquired thrombotic microangiopathy, and a typical HU. One second, I am somehow like once. I'm sorry. Yeah. So one of the groups is primary or the primary acquired thrombotic microangiopathy, of which atypical HUS with FH autoantibody is one of the parts of that. Then the second group is primary thrombotic microangiopathy, which is hereditary in origin, and atypical HUS with complement gene mutation, cobalamin deficiency can be seen in this. And secondary TMA, we see with severe hypertension or drug-induced bone marrow malignancy-induced things. And also this infection-associated HUS associated with pneumococcal HUS or STEC HUS. Now this, coming to the diagnostic criteria for HUS, HUS is comprised of macroangiopathic hemolytic anemia with hemoglobin less than 10 gram per deciliter, fragmented red cells on peripheral blood smears, cystocytes more than 2%, either high LDH or 450 IU per liter, or undetectable haptoglobin. It also has AKI, which is characterized by rise in serum creatinine by over 50% over the baseline, and thrombocytopenia with platelet counts of less than 1.5 lakhs per microliter. Now, what is thrombotic microangiopathy? So when there's a trigger of vascular injury in a host which is genetically predisposed to developing this thrombotic microangiopathy condition, there is injury of the vascular endothelial cells, characterized by the swelling of the endothelial cells, the detachment of the endothelial cells, which collection of the debris underneath in the subendothelial space. There is sequestration of the platelets. Then that leads to consumption of the platelets, and that leads to thrombocytopenia. The RBCs are sequestered there, leading to anemia and increase in cystocytes. The vessel wall thickness increases, and there's partial or complete occlusion of the vessel, and this entire phenomena leads to end organ injury. Coming to the investigations that we do for HUS, for diagnosis purposes, we do CBC, peripheral blood smear for schistocytes, reticulocyte count, LDH, haptoglobin, DCT. In blood, we do serum creatinine, serum electrolytes, transaminases, bilirubin, and complement C3. Urine analysis to look for proteinuria and RBCs. Rapid tests for malaria, dengue, IgM antibodies for dengue, leptospirosis if the situation is suspected, coagulations profile in suspected systemic sepsis, and DIC, ultrasound abdomen, and if clinical features are present and so warrant, we should do echocardiogram, neuroimaging, amylase, and troponin T. Coming for determining the cause of HUS, we should investigate for infection-associated or secondary HUS if clinically suspected, anti-factor H antibodies, anti-nuclear antibodies, CD46 expression on neutrophils by flow cytometry where required, wherever the diagnosis of HUS is not clear, we should store blood for Adams 13 activity. Total homocysteine levels can be done for, an evaluation for Shiga toxin associated HUS. I'll be coming in bit in details about these as we progress into the talk, and pneumococcal infection, and then sequencing of certain genes implicated in HUS. Renal biopsy, it's not really essential and rarely performed. However, the Indian Society of Pediatric Nephrology recommends renal biopsy in patients with unclear diagnosis of HUS, unsatisfactory clinical response to determine the extent of clinical damage, renal damage, and help in prognosis, and to distinguish between the causes of allograft dysfunction, including recurrent HUS. In fact, there was a study done in 1991 by Dr. R.N. Srivastava et al., and they biopsied about 50 kidneys, and various histological features were present, including cortical necrosis, glomerular changes, glomerular and arteriolar changes, and acute tubular necrosis. However, none of these were pathognomonic, were like typical findings for like confirmatory diagnostic finding for hemolytic uremic syndrome. I'll speak about Shiga toxin associated HUS, which is an infection associated thrombotic microangiopathy. The implicated organisms are Shiga toxin E. coli, the type O157H7 and non-157, and Shigella dysentery type 1. A very low infecting dose is required to get infection with these organisms. The confirmatory lab should be done when suspecting these, this pathology. The detection of virulent genes on fecal extracts or cultures by Shiga toxin 1, STX2, EAE by PCR. Free fecal Shiga toxin detected on tissue culture or immunoassay. Then serum IgM antibodies to serogroup specific lipopolysaccharides by ELISA hemagglutinin assay. Suggests screening for STEC infection in all suspected cases of STEC HUS on stool samples collected at admission. Coming to the pathogenesis of STEC HUS, now this Shiga toxin is carried in neutrophils, monocytes, and platelets, and it has got a special affinity to GB3 plasma membrane receptor, which is in plenitude on the renal endothelium. So it goes and localizes on the endothelium and is internalized by receptor-mediated endocytosis. And once internalized into the endothelium, it causes TMA. Shiga toxin can also directly cause complement activation and TMA. Coming to the epidemiology of this problem, HUS develops in 5 to 10% of sporadic infection with STEC and 20% of the patients during the outbreak. About 30 to 40% cases of STEC HUS may not have dysentery, and the condition is also reported in patients without diarrhea and infants below 6 months of age. So the index of suspicion has to be really high in these situations. The risk factor for development of HUS in more when child is less of a young age, less than 5 years old, has more than 3 days of diarrhea, has blood in stools, and the leukocyte count is high to the tune of more than 15,000 per microliter. Coming to the clinical features, the child can contract the infection through fecal-oral route, contaminated food or water, or through farm animals, and within 2 to 5 days of contact, develops symptoms of profuse diarrhea with or without blood, abdominal pain, and vomiting. About 3 to 14 days after this diarrheal illness, about 10 to 15% of them go on to develop HUS with symptoms of pallor, fatigue, oliguria, edema, and easy bruisability. The child runs a clinical course for over 2 weeks, and then ultimately either there's a resolution in 70% of the cases, and in 30% of the cases, there is long-term renal sequelae. The non-O157H7 E. coli related cases, the bloody diarrhea is less common and duration of dialysis required is lesser. In shigellosis related HUS, it's mostly associated with malnutrition, associated with other infections. There's increased mortality. There's cortical necrosis documented on biopsy. There are more extrarenal complications, especially gastrointestinal. DIC is common, and there's increased mortality. And hence we see that shigellosis is more severe than this non-O157H7 E. coli related illness. Treatment usually is general supportive measures. We have to tightly regulate the fluid and electrolyte balance. as far as renal replacement therapy is concerned, there's no proven benefit of early initiation. PD is safe even with thrombocytopenia. However, anticoagulation needs tight control. Plasma exchange is not recommended, however, can be considered for patients with severe neurological or cardiac involvement. Antihypertensives should be given if the child is hypertensive, and appropriate antibiotics for bloody diarrhea should be instituted. Use of transfusion of platelets is usually discouraged. However, the child can be given PRBC for anemia. Now, use of eculizumab, it's a novel drug which is being used mostly in atypical HUS. It's for terminal complement blockade. However, the use of eculizumab in this condition, STSC HUS, is mostly anecdotal. In German epidemic, there were 3 patients who were given eculizumab and they attained hematological remission, neurological improvement, they were off dialysis, but had residual hypertension and proteinuria. And 2014, 2 Turkish patients had similar outcomes. So eculizumab is not really recommended. Its use is just anecdotal. The toxin blockade, Synsorb and all, that's also not shown to have any major benefit in according to various randomized controlled trial. So there's no demonstrable benefit and hence not really recommended. Coming to Streptococcus pneumoniae related HUS, this is again another infection associated HUS. It is very, very rare, less than 1:1.2 lakh per children. And usually age of these children is less than 2 years. It's associated with pneumococcal pneumonia. Now coming to a bit about the pathogenesis of this disease. Now T cells, T antigen, Thomson-Friedrich antigen is present in RBCs, platelets and endothelium. And about 3 to 5% of the individuals have antibodies to this T antigen. However, this is covered by uramic acid, the antigen. Now, when the streptococcus, this infection with pneumococcal bacteria takes place, then this neuraminidase that is present, and that cleaves this uramic acid and exposes this antigen. And in 3 to 5% of the individuals who have these antibodies to T antigen, it reacts and it causes thrombotic microangiopathy. Investigations to be done for diagnosis are blood culture, bacterial culture, PCR for ELISA, positive peanut lectin agglutination assay is seen with streptococcus related infections. Treatment is with parenteral cephalosporin or vancomycin. Avoid plasma infusion or exchange, and watch platelets can be given. HUS with cobalamin deficiency, it is a hereditary primary TMA and accounts for about 6 to 8% of the patients with HUS. Homozygous mutation in MMA CHC gene is seen. Impaired cobalamin C metabolism is documented. Onset is seen in early infancy with failure to thrive, poor feeding, vomiting, neurological manifestations, metabolic acidosis, hemolytic anemia, respiratory and liver failure. Homocysteine levels are found to be elevated, and the child responds well to therapy with hydroxycobalamin and betaine therapy. Now I'll be coming to complement mediated HUS or the atypical HUS. The diagnosis of atypical HUS. And so this HUS is basically a primary TMA. It can be acquired or hereditary, as I had already discussed. The diagnosis of atypical HUS is considered where suspected STEC and pneumococcal HUS, TTP, and secondary HUS are excluded based on clinical and laboratory features. Diagnosis of atypical HUS is considered in patients with negative results for infection by Shiga toxin producing organism, positive non-synchronous family history, or recurrent disease. So in our body, there's a tight, there's a very tight control, there's a regulation of complement, and there's a balance of regulation and activation of complement, with regulation always being more than the activation. And when the regulation is more than activation of the complement, there is no pathology. However, in certain situations, when the regulation is less than the activation of the complement, atypical HUS or secondary HUS can result. Regulation of the complement is maintained by plasma factor H and I, and there are various membrane regulators. And activation of the complement can happen occasionally, and usually by the activation of the complement path, alternative complement pathway. And there are various factors which cause activation and regulation of the complement system. Coming to the epidemiology, It can occur at any age, but 70% of the cases occur below 18 years. And up to 80% episodes are triggered by an infectious agent, respiratory infection, or diarrhea. So when do we suspect atypical HUS? When the child has had history of diarrhea in the last 15 days. Age is less than 6 months, child has recurrent HUS, suspicious previous HUS, family history of HUS, recurrent HUS after transplantation, and complement C3 level is low. Now, a little bit about the alternate complement pathway, because that's a pathway that is affected in the HUS, atypical HUS. So the alternative complement pathway is triggered by the covalent bonding of the C3b to the pathogen on the cell surface. And next, this factor B is there that binds to the surface bond C3b. And it's susceptible to cleavage by plasma factor D. The result is production of BA and BB, and active protease BB, which remains bound to the C3b. And this creates the C3BB, which is the C3 convertase, this one, the C3 convertase. And this leads to amplification, the auto amplification of the C3b again. Now, this amplification loop, when it gets saturated, there will be C3b saturation on the cell surface with release of C3a, a small inflammatory mediator. Eventually, some of the C3b will bind to the pre-existing C3 convertase, producing C3b2bb, which is the alternative pathway C5 convertase. And this C5 cleaves into C5b, which then generates the membrane attack complex and the C5a, which is a potent pro-inflammatory mediator. Now, these are the various regulators of the complement at various places. This is shown in the circle in red. These include factor H and factor I, and each acts to promote the inactivation of C3b and prevent the complement cascade. So whenever there are mutations affecting the complement regulatory factors like the CFH, CFI, MCP, and others, there's activation of the complement system with the generation of membrane attack complex. The endothelial cells are injured, platelet activation takes place, and then platelet aggregation takes place, and HUS can result, end organ injury, and HUS can result. Now, terminal complement blockade, that the new eculizumab is a drug that is used for complement blockade. It blocks this C5 and it blocks the C5 and leads to decrease in leads to inhibition in production of C5a and C5b, and hence inhibition of attack complex, and hence according to the coming to the guidelines regarding management of atypical HUS without anti-FH antibodies. It's the guideline of the Indian Society of Pediatric Nephrology. And these guidelines have been framed because eculizumab is an expensive drug and it cannot be given in the resource-constrained setting of our country. In the absence of eculizumab, the guideline recommends prompt initiation of plasma exchange in patients with atypical HUS. For initial therapy, plasma exchange is preferred to plasma infusions. Plasma exchange should be administered daily until hematological remission is achieved and then tapered over 4 to 6 weeks. Patients on plasma therapy should be monitored for plasma or filter reactions, complications of catheter insertion, infection or thrombosis, and blood-borne infections. Efforts to enable therapy with eculizumab should be done in following situations: lack of remission despite 7 to 10 days of plasma exchange, life-threatening features like seizures and cardiac dysfunction, complications due to plasma exchange or vascular access, and inherited defect in complement regulation. Coming to anti-factor H antibody HUS, this is very common in India. It accounts for approximately 50% of the Indian cases. It is associated with deletion in CFHR13 gene in approximately 80% of the cases. Typical age of onset is 7 to 12 years, and there's slight male preponderance, and infectious trigger is commonly seen. The management of the anti-FH antibody-associated HUS, according to the Indian Society of Pediatric Nephrology guidelines, is a prompt plasma exchange and immunosuppressive therapy combination for patients with anti-FH antibodies. However, the use of immunosuppressive medications without confirming the presence of anti-FH antibodies is not recommended. Daily plasma exchange until hematological remission is given and then tapered over 3 to 5 weeks. Plasma infusion is not recommended as a substitute for plasma exchange in these situations. Since high anti-FH antibody levels might predict a relapse, the society recommends monitoring antibody titers frequently during the first 12 to 24 months. And therapy with eculizumab is recommended in the following situations: lack of remission despite 7 to 10 days of plasma exchange, life-threatening features like seizures and cardiac dysfunction, complications due to plasma exchange of vascular access, and inherited defect in complement regulation. Coming to the plasma exchange protocol, plasma exchange should be done daily with 1.5 times plasma volume, that is 60 to 75 ml per kg per session for 5 days, or until hematological remission is achieved, whichever is later. Then alternate day at 40 ml per kg for 2 weeks, twice a week for 2 to 3 weeks. Anti-FH positive HUS plasma exchange can be discontinued after 4 to 6 weeks. However, for negative anti-FH negative HUS, FFP infusions 10 to 20 ml per kg should be done every 7 to 10 days. And how do we define hematological remission? Platelets should increase to more than 1 lakh per microliter. Citrocytes should decrease to less than 2%, and LDH should be less than upper limit of normal for the 2 consecutive days. Then there are other forms of HUS like associated with hypertension, bone marrow transplant, autoimmune conditions, malignancies, and underlying conditions should be treated in these situations. Coming to renal transplant. Now, renal transplant should be done and counseled for after proper counseling with extreme caution. There's a variable risk of disease recurrence. Risk of recurrence is high in patients with dysregulation of complement pathway. There's low risk in SDEC-HUS, abnormalities in membrane-anchored CD46 and intracellular DGKE protein. Counseling regarding risk of recurrence should definitely be done properly. Live-related donation should be avoided in patients at high risk of disease recurrence for obvious reasons. Monitor for recurrence post-renal transplant. And if recurrence of HUS is confirmed, all efforts should be made to procure and institute the therapy with eculizumab. Thank you.
Thank you, Shweta, for that excellent and elaborate talk on HUS. Can you stop screen sharing? Yeah. For the next speaker is Dr. Mehul Shah, who's going to be speaking to us about another excellent topic, which is renal tubular acidosis in children. It's a very confusing topic, and I'm sure Dr. Mehul Shah will throw light on it. Dr. Mehul Shah works as a senior consultant pediatric nephrologist at Uplow Health City and Little Stars Children's Hospital, Hyderabad. His areas of expertise are in renal tubulopathies and antenatal renal anomalies. And Sir has over 22 years of papers and experience and publications. Over to Dr. Mehul Shah.
Thank you, Dr. Sukanya, and thank you for the team for the opportunity to participate in this important webinar. I'm sorry. I think the topic for discussion is renal tubular acidosis, and I know I have about 20 minutes to cover this vast topic. I will have to go a little fast because it itself is a day-long discussions on this topic. As we all know that metabolism of macromolecules, mainly carbohydrates and fats, produces volatile acid in the form of carbon dioxide, whereas metabolism of protein results in production of non-volatile acids, mainly sulfuric acid and phosphoric acid. Carbon dioxide is ultimately excreted through the lungs, whereas the hydrogen, which is generated by metabolism of proteins, is initially buffered by bicarbonate in the plasma and subsequently and more importantly by the intracellular proteins as well as the phosphates. The reclaimed bicarbonate by buffering hydrogen is then reclaimed by the kidneys in the proximal tubule, and the bicarbonate which has been utilized to buffer hydrogen is then excreted through the distal nephron and new bicarbonate is regenerated. In children, about 1 milliequivalent of hydrogen per kg per day is generated due to protein metabolism. And in addition, about 1 to 2 milliequivalents of hydrogen per kg per day is generated due to growing bones. So hence, about 2 to 3 milliequivalents of hydrogen per kg per day is generated in a child as against 1 to 1.5 milliequivalents per kilogram in an adult. Now, the kidneys take part in acid-base homeostasis through two processes at two different sites. The first is the reclamation of the filtered bicarbonate, which occurs predominantly in the proximal convoluted tubule. About 80% of the filtered bicarbonate is reabsorbed in the proximal convoluted tubule. And the second is the secretion of the hydrogen generated by metabolism of protein is then excreted in the distal nephron with regeneration of new bicarbonate. Albert Einstein once stated, the most beautiful thing we can experience is the mysterious, and it is the source of all true art and science. Who else but the kidney that can be related to this particular statement? The specific part of the kidney we are talking about is the renal tubule. It was, and it indeed is mysterious. It's a blend of true art. There is a complex yet harmonious interplay of various processes which are responsible for reabsorption and secretion of solutes and water. Now, renal tubular acidosis is a diverse group of renal tubular disorders that involve defects in the proximal bicarbonate reabsorption or distal hydrogen secretion or both, while the GFR remains near normal. So we cannot define RTA in a child who has got either AKI or chronic kidney disease. It is characterized by hyperchloremic, normal anion gap, metabolic acidemia, and hypokalemia in most types of renal tubular acidosis. It was first described in 1935 by Lightwood and was designated as RTA in 1951 by Pines et al. There are three main types of RTA. Type 1 or distal RTA, because it was the first type of renal tubular acidosis to be described. This is due to a defect in the distal nephron hydrogen secretion. Type 2 or the proximal renal tubular acidosis, which is usually part of renal Fanconi syndrome, and rarely it could be an isolated proximal RTA, and it is mainly due to defect in the proximal bicarbonate reabsorption. Type 4 is the aldosterone hyporesponsiveness, either due to aldosterone deficiency or because of aldosterone resistance. We used to talk about type 3 or mixed renal tubular acidosis earlier. However, the terminology is not used anymore. In this situation, there is a defect in both the proximal and distal nephron due to carbonic anhydrase 2 defect. What are the clinical features of a child with renal tubular acidosis? Most often, they would present with failure to thrive, which results due to delay in physical milestones, polyuria due to salt wasting and hypokalemia, polydipsia mainly because of polyuria and secondary volume depletion and dehydration. They often have constipation, vomiting, and weakness. Occasionally, they may present with vitamin D resistant. Children with PUB would have type 4 renal tubular acidosis, and they may present with recurrent urinary tract infections or poor urinary stream. Please remember, all these features can be seen in any child who has got chronic kidney disease, especially due to hypodysplasia or due to PUV. So these features are not pathognomonic of renal tubular disorder, but they can also be seen in a young child who has chronic kidney disease because of hypodysplastic kidneys. There are different tests which can be used to assess the urinary acidification. I'm not going to go into the detail of all of them, but just to enumerate them: urine pH, urine anion gap, ammonium chloride loading test, urinary to blood PCO2 difference, as well as the furosemide challenge test. I think of this, we should focus on the first two. Now, urine examination often gives us a clue to the presence of underlying renal pathology, and that is same for assessment of a child with renal tubular acidosis. Urine pH varies depending upon our diet as well as the physical and pathological state. But usually if the urine pH is more than 6.0, it can be seen with any causes of diarrhea, distal renal tubular acidosis, any causes of hypokalemia, or in children who have got proteus infections. So there are different reasons why we may have an alkaline urine pH. Specific gravity in children with renal tubular disorder, due to any reason, they will have a low urine specific gravity or a hypoosmotic urine, and the specific gravity is less than 1010. Certainly, presence of even trace proteinuria or 1+ proteinuria and glucosuria would be important, because that would make us think in terms of renal Fanconi syndrome. One of the important messages I would like to share with the students over here is that a urine specific gravity of 1025 or 1030 would indicate a good concentrating ability, and it essentially rules out renal tubulopathy. So many times when a child or a mother comes with the child having frequent urinations, not gaining weight, there could be other reasons besides renal tubulopathy. A simple complete urine examination, especially obtained after overnight 6 hours of fasting in an older child, would give us an important clue whether there is a renal disease or there is no renal disease. The second investigation of use, which can be easily performed in most centers, is urinary anion gap. Certainly, it has its own limitations. We use this particular diagnostic test to differentiate between hyperchloremic metabolic acidosis because of diarrhea and because of distal nephron hydrogen ion secretion defect. It is an indirect index of urinary ammonium concentration. All we need to do is measure sodium, potassium, and chloride, and the sum of urinary cations minus the urinary anion, the predominant being the chloride, would give us the urinary anion gap. It is physiologically 0 to ±5. A positive urinary anion gap more than 5 would indicate there is a deficiency of urinary ammonium, and that would indirectly tell us that the child may be having distal RTA. Conversely, negative urinary anion gap would indicate that there is enough urinary ammonium, and this is usually seen with diarrhea or children with proximal renal tubular acidosis. So a simple diagnostic test. Certainly, we need to be aware about its limitation, about presence of AKI, presence of other causes of metabolic acidosis, which can affect the urinary anion gap. But in a child who does not have other confounding variables, this would help us differentiate between a proximal renal tubular acidosis and a distal renal tubular acidosis. So to summarize, the baseline tests which would be required are complete urine examination. We often ignore individual points which are mentioned on complete urine examination. Please pay attention to specific gravity, pH, presence of protein and glucose. Venous blood gas, we do not need an arterial blood gas. We are not looking at the oxygenation aspect of the blood gas analysis. Renal function test to rule out CKD, serum electrolytes, calcium phosphorus alkaline phosphatase, and certainly a baseline ultrasound mainly to look for size, hypodysplastic kidney, hydroureteronephrosis as an indirect indicator of PUV, and more specifically nephrocalcinosis to differentiate between distal and proximal RTA. So is it distal or is it proximal RTA? A simple urine anion gap would help us. A positive urinary anion gap would indicate there is a defect in distal nephron hydrogen secretion and would point towards distal RTA. A urine calcium creatinine ratio normal will not rule out distal RTA, but if it is high, would point towards distal RTA. Look for proteinuria. In case if there are features of renal Fanconi syndrome, look at fractional excretion of phosphorus and urinary acidification test. Fortunately, we do not need this in most children. In my own experience over the last 22 years, we required to do the ammonium chloride loading test or the furosemide challenge test in only 2 children to differentiate between the 2 types of distal RTA. Specific investigations in case if there are features of renal Fanconi syndrome to look for eye examination, aminoacidogram, and now since mutation analysis is easily available, we can directly jump to mutation analysis. And for type 4 RTA, we need to look at the plasma aldosterone assay, cortisol and 17-hydroxy progesterone assay, and an MCUG if we are suspecting PUV. For practical purpose, these are the tests which are sufficient, easily available, and can guide us as to the differential diagnosis of a child with distal RTA. So let's move on to specific subtypes of renal tubular acidosis, starting with proximal RTA or type 2 RTA. This is because of a defect in the reabsorption of proximal renal tubular bicarbonate reabsorption. It could be an isolated defect, which is very rare. Most commonly, it is part of generalized defect in reabsorption of various solutes, characterizing renal Fanconi syndrome. As we know, 60% of bicarb is reabsorbed in the proximal convoluted tubule, another about 10% in the proximal straight tubule. So almost 75% is reabsorbed in the proximal tubule, 15% is reabsorbed in the distal nephron. Now, when bicarbonate is lost in the urine, increased delivery of sodium bicarbonate in the distal nephron in presence of hypovolemia will stimulate aldosterone system. Aldosterone will reabsorb sodium and excrete potassium and resulting in hypokalemia. So the hypokalemia in children with renal tubular acidosis of the proximal type is because of increased delivery of sodium bicarbonate in the distal nephron in presence of aldosterone, resulting in increased sodium reabsorption and potassium secretion causing hypokalemia. A transient or sporadic type of renal tubular acidosis, primary, is because of a defect in the sodium hydrogen antiporter or the exchanger NHE3. It is a very rare condition. Fortunately, it is self-limiting and most children resolve this by 2 years of age. However, autosomal recessive isolated proximal renal tubular acidosis, which is due to a defect in the basolateral sodium bicarbonate co-transporter, results in severe manifestation, often has ocular features, CNS features, and dental features. It's one of the severe forms of proximal renal tubular acidosis due to defect in the basolateral sodium bicarbonate co-transporter, which is the electrogenic type of the transporter responsible for moving sodium and bicarbonate from the lumen into the interstitial compartment. As we discussed, proximal RTA is rarely isolated. It is often a part of renal Fanconi syndrome, where there is a defect not only in reabsorption of bicarbonate, but a defect in the reabsorption of sodium, phosphate, glucose, amino acids, and uric acid, resulting in loss of multiple solutes in the urine. The presenting features of renal Fanconi syndrome depends upon the type of the etiology or the cause of the renal Fanconi syndrome. Children with cystinosis, most common cause of renal Fanconi syndrome is cystinosis, galactosemia, hereditary fructose intolerance, Fanconi-Bickel syndrome, Lovis oculocerebrorenal syndrome, mitochondrial myopathies, and tyrosinemia. They would present in the first 2 years of life, whereas children with juvenile cystinosis, Wilson's disease, and Dent's disease would present in the later part of first decade or second decade with features of renal Fanconi syndrome, because it takes time for the accumulation of the solutes in the renal tubular cells, causing progressive loss of function. Acquired causes of renal Fanconi syndrome can happen at any age, depending upon the exposure to the toxin or the drug. Certain common agents which are known to cause renal Fanconi syndrome include sodium valproate, ifosfamide, cisplatin, the oral iron chelating agent, defiracirox, which can contribute to proximal renal tubular dysfunction in up to 25% children over a period of 5 to 10 years of use of this agent, and heavy metal poisonings. And lastly, children who are recovering from a severe ATN can have transient features of renal Fanconi syndrome because of tubular damage. And children with tubular interstitial nephritis can also present with renal Fanconi syndrome. But again, the most common are the inherited forms of renal Fanconi syndrome. How do they present? Like we discussed in the previous slide, they were present with growth failure, polyuria, which results in polydipsia, weakness, constipation, and rickets because of chronic hypophosphatemia. Specific to the etiology, we may have vomiting or flatulence beginning at 6 to 8 months after introduction of fructose-containing items in the weaning foods, seizures due to hypoglycemia in children with hereditary fructose intolerance and glycogen storage diseases, mental milestone delay when there's storage disorders, eye changes, and hematuria in an older child presenting with Denne's disease. Pointers towards renal Fanconi syndrome include a usually acidic urine pH in presence of metabolic acidemia because the distal nephron hydrogen secretion is intact, hypostenuric urine because of concentrating defect. There may or may not be proteinuria and glucoseuria, a negative urinary anion gap. Usually the metabolic acidemia is mild because the threshold for bicarbonate reabsorption is lowered. It is not completely suppressed, but instead of 24, the renal tubules are able to reabsorb bicarb till 16 to 17, and below that, everything which is filtered is going to be reabsorbed. Usually there is only mild hypokalemia. There may be hypophosphatemia, high alkaline phosphatase, and a low serum uric acid, all related to defect in the proximal renal tubular reabsorption of various solutes. Now, few important features between renal tubular acidosis of the proximal type and that of distal type. Why do we usually not see hypercalciuria and nephrocalcinosis in proximal renal tubular acidosis of the renal Fanconi syndrome, except for Denne's disease? Mainly because the metabolic acidemia is mild. It causes only lowered renal bicarbonate reabsorption threshold, and hence there is lower degree of buffering by the bone calcium carbonate. Because of the defect in reabsorption of multiple solutes, even citrate, which is normally reabsorbed in the proximal tubule, is not reabsorbed, and hence citrate is lost in the urine. And as we know, citrate is a natural chelator of calcium in our urine. And thirdly, because the distal nephron hydrogen ion secretion is intact, the urinary pH is going to be acidic, and that's a simple chemical basis why we do not precipitate calcium phosphate in the acidic urine pH. So definitely children who are treated with phosphate and active form of vitamin D3 for the hypophosphatemic rickets can develop hypercalciuria and nephrocalcinosis over a period of several years, and that needs to be monitored, especially when they are on treatment. Management is first to attempt and identify the treatment etiology of renal tubular acidosis of the proximal type. There are certain principles which guide us in management. First, replace the supplements enterally as much as possible. Go slowly. Give small doses frequently to mimic the losses that occur 24/7. There's no point in giving medicines just twice in a day or thrice in a day, because there is a 24/7 continuous leakage in the urine. And most importantly, please do not try to normalize deficiencies. It is impossible, and it is only going to worsen the urinary losses of the solutes. An important point to be discussed over here is, once we start these children with sodium bicarbonate or sodium acetate to correct the hypokalemia or metabolic acidosis, the hypokalemia is going to worsen, mainly because the increased delivery of sodium bicarbonate and water in children with proximal RTA to the distal nephron, along with hypoaldosteronism because of volume depletion, is now going to stimulate more sodium reabsorption and potassium secretion. So a bicarbonate of 17 to 18 is very much acceptable in patients with proximal renal tubular acidosis. So watch for hypokalemia when we start treatment with alkali. If the alkali treatment is not initiated, these children do absolutely well with potassium of 3 to 3.5. Various molecules which are available, I'm not going to go into the details, but these children need a very high amount of sodium and potassium citrate to replenish the losses. Few of them would require oral phosphate, which is now available as Edphos sachets, oral active form of vitamin D3, dietary measures to reduce hypercalciuria, which would be a complication of phosphate and active form of vitamin D3 management, low dose hydrochlorothiazide to cause some amount of volume depletion and decrease the GFR and decrease the filtered load of solutes can be given, again keeping a watch on hypokalemia. Certainly, there is no role of ACE inhibitors of ARBs to correct the hypokalemia, because these children are always volume depleted, and using this is going to risk hypotension and acute kidney injury. Management of renal Fanconi syndrome is like filling a bucket with multiple holes. As much as you allow the water to fill the bucket, most of it is going to continue leak out. And hence, we need to have a balance between the desired blood levels and the growth versus the side effects of the supplementation, and give the molecules at frequent intervals. Moving on to type 1 or distal RTA. This is either of primary defect or a secondary defect. The primary defect is the most common. It is because of a defect in the distal hydrogen secretion, and hence the urine pH is always more than 5.6. Secondary defects could be because of voltage defect, because of impaired distal sodium reabsorption. We'll come to this in the subsequent slides. The main mechanism of sodium reabsorption in the distal nephron is dependent on aldosterone, where sodium chloride is reabsorbed in exchange for potassium and hydrogen secretion. So if the distal sodium reabsorption is impaired, there is inability to generate lumen negative potential difference. This results in reduced potassium and hydrogen secretion, retention of potassium and hydrogen, causing hyperkalemia and metabolic acidemia. This is very commonly seen in children who present with severe volume depletion. Here, whatever filtered sodium is reabsorbed in the proximal tubule, and hence less sodium is delivered to the distal nephron. Child has got hyperaldosteronism because of volume depletion, and whatever little sodium is there, it is not sufficient for the kidneys to excrete the potassium and hydrogen. And certainly when we use drugs which block the epithelial sodium channel, we can get a similar presentation. And the third is the gradient defect, which is because of membrane permeability defect, classically seen in children who have been treated with amphotericin B because of back leak of secreted hydrogen from the tubular lumen back into the intracellular compartment. Again, please remember the secondary defects have an intact hydrogen secretion in the alpha intercalated cells of the distal nephron. It's only in the primary situation where the distal hydrogen secretion is impaired. There are different types of primary distal renal tubular acidosis. Type 1 is because of defect in the anion exchanger, or also called as a band-3 protein. It is also present in RBC, and this is associated with an hemolytic anemia, the type 1A. Type 1B is because of a defect in the ATP gene present in alpha intercalated cells and cochlea, which results in severe presentation and deafness. Type 1C is because of a different gene defect in ATP present in alpha intercalated cells. This is not associated with deafness. And type 1D, which is because of a defect in hydrogen potassium ATPase. It's an hydrogen potassium antiporter where hydrogen is secreted and potassium is reabsorbed. So this is a very rare situation. The most common is either type 1A or type 1B or type 1C. The etiology can be either primary genetic because of an isolated defect, or it could be with syndromes. Most commonly in infants, it is an autosomal dominant because of anion exchanger or band-3 protein defect. It could be autosomal recessive with or without deafness because of the hydrogen ATPase pump defect, or secondary because of different conditions mentioned over here. Most common are the ones which are highlighted in the text over here. Rickets is usually not a feature of distal RTA, especially in young children. And we were conventionally taught that if rickets is present, we should not think about distal RTA. We should think about proximal renal tubular acidosis as part of renal Fanconi syndrome. However, we have seen a number of children with distal RTA with rickets. So distal RTA can present with rickets. And what are the reasons for that? These are some of the reasons why a child with distal RTA can have rickets. One, the chronic metabolic acidemia has been known to inhibit 1-alpha hydroxylase activity, which is required for generation of active form of vitamin D3. Loss of calcium from bones causes osteopenia, resulting in negative calcium balance. And there is often associated vitamin D deficiency because of decreased oral intake related to chronic acidemia. Polydipsia makes the child always filled with water, and decreased sunlight exposure because of weakness and limited physical activity. Children are always indoors. So there are multiple reasons why children can have rickets in distal renal tubular acidosis. The second important point is, why do they develop nephrocalcinosis? We often use nephrocalcinosis as a differentiating point between distal RTA and proximal RTA. And there are three reasons for this. As we said, there is release of calcium carbonate from the bones to buffer the acid which is generated and not secreted by the distal nephron. The calcium which is left alone is then excreted through the kidneys, causing hypercalciuria. Hypositraturia, because of metabolic acidosis, there is increased proximal renal tubular reabsorption of citrate in response to metabolic acidemia, and hence less citrate is available in the distal nephron luminal area to chelate the calcium. And the high urine pH is a basic so it allows the calcium phosphate to precipitate in alkaline urine pH, and that's a primary defect. So because of these three pathophysiological conditions, you end up having nephrocalcinosis as well as hypercalciuria. I think I will skip this because most of this has been covered. Severe metabolic acidemia, high urinary pH, high or positive urinary anion gap. Nephrocalcinosis may or may not be there, but if it is there, it helps us think about distal RTA, mild to moderate hypokalemia, no features of renal Fanconi syndrome, and there may be features of rickets. So presence of rickets does not mean it is not distal RTA. The treatment is directed to improve the growth, prevent or restrict nephrocalcinosis, prevent and arrest progressive chronic kidney disease, and prevent hypokalemic complications. So these are the objectives of treatment of a child with distal RTA. This treatment is simple, economical, and very effective. Treatment can be with oral sodium bicarbonate tablets, commercially available potassium citrate suspension, or in initial phases of treatment when there is severe hypokalemia, we need to use only serum pot chloro potassium chloride and not correct the acidemia. Some of the principles of treatment. First, please pay attention to treatment of hypokalemia. The patient will not die because of metabolic acidemia, but if there is a sudden correction of acidemia without correction of acidosis, without correction of hypokalemia, there will be a shift of potassium from extracellular to intracellular compartment, causing further hypokalemia and cardiac arrhythmias and arrest as well. Stop potassium chloride when the serum potassium is more than 3.5, which may take 1 to 2 weeks. And at that point, you add therapy with alkali, and third, with sodium bicarbonate. So we have to go in the sequence when we are correcting a metabolic disorder of hypokalemic, hyperchloremic metabolic acidosis of distal RTA. Target potassium of 3.7 to 5.0, and indirectly resolution of polyuria and polydipsia would tell us that the potassium level is acceptable. Target venous pH of 7.35 to 7.42 and a bicarb of 24. Anything less than 24 will allow some amount of chelation of calcium carbonate from the bones, resulting in hypercalciuria and chronic nephrocalcinosis and progressive chronic kidney disease. Dose of bicarbonate may not be just 2 to 3 milliequivalents per kilo per day, but in the initial stages, because of negative bone balance, we may require even a higher amount of bicarbonate, up to 8 to 10 milliequivalents per kilo per day. And please remember, the duration of therapy is lifelong. We should not discuss about the lifelong therapy with the families at the first visit. We need to develop confidence between the family and the physician. Once the bonding is there, gradually we need to inform the family about the long-term therapy. If it's mentioned at the first visit itself, the family is going to keep on going to different hospitals saying that we are not going to be using therapy for lifelong. They will end up having complications of hypokalemia, nephrocalcinosis, and chronic kidney disease. Importantly, the family should be encouraged to be on a low-salt vegetarian diet for obvious reasons which are mentioned over here. And if rickets are present, they usually get corrected within 3 to 6 months of therapy with calcium, phosphorus, and some inactive form of vitamin D3. Complications are growth retardation, rickets, hypokalemic periodic paresis, and CKD due to nephrocalcinosis and chronic hypokalemia. Type 3, I'm not going to spend a lot of time on this. It is just one slide. There is a defect in both the proximal tubular carbonic anhydrase 2 enzyme as well as the distal nephron alpha intercalated cell carbonic anhydrase 2 defect. So this is a enzyme which is present in both proximal and distal nephron. It results in mixed renal tubular acidosis. Because this enzyme is also present in brain and bone, it results in osteopetrosis, mental retardation, and facial dysmorphism, and hence it is called as marble brain disease. And finally, few slides on type 4 or hyperkalemic renal tubular acidosis. The basic defect here is impaired cortical collecting tubular sodium reabsorption. This is the basic defect. Because of this, there is decreased potassium and hydrogen secretion, and hence we end up having hyperkalemia and metabolic acidosis. This could be of two types. Type 1, the voltage-dependent RTA, which we discussed in the earlier slides, which is because of severe volume depletion, and they get better by administration of sodium chloride. Or it could be a primary defect in the aldosterone, either a deficiency, it could be an isolated aldosterone deficiency, or it could be part of congenital adrenal hyperplasia, or it could be because of pseudo-hypoaldosteronism, where the aldosterone level is high, but there is an end organ resistance, either because of mineralocorticoid defect, which results in an autosomal dominant type 1A PHA. It could be a systemic defect in the epithelial sodium channel, which is present not only in the luminal membrane of the collecting tubular cells, but also in lungs, in GI system, as well as in the sweat glands. This results in a much more severe type of hypoaldosterone related defect. And finally, it could be type 3, which is seen in children who have got PUV or lupus or sickle cell disease. There is a type 2 PHA called as Gordon syndrome. This is a misfit over here because this is the only condition which is associated with hyperkalemia, with normal renal function and hypertension. Features are almost similar to the other types of renal tubular acidosis with polyuria, polydipsia, vomiting, failure to thrive, all resulting from aldosterone deficiency related hyponatremia and hyponatremia and volume depletion. Diagnosis, again, children would present with very severe hyponatremia, hypochloremia, and hyperkalemia, much more than children with type 1 distal renal tubular acidosis. Mild metabolic acidemia, we need to obtain specific tests, ultrasound abdomen to rule out PUV. If there is hydrouretronephrosis, we obtain MCUG. Blood 17-hydroxyprogesterone and cortisol if we are suspecting CAH, and blood aldosterone level to look for aldosterone deficiency or pseudo-hypoaldosteronism. Management is giving them salt. If there is aldosterone deficiency, in addition, we may need to give them potassium binders or oral fludrocortisone and hydrocortisone if there is CAH. Children with aldosterone resistance, especially the type 1A, the mineralocorticoid receptor defect, they do quite well. They respond to high salt diet and low potassium diet, and majority of them, they get better by 2 years of age. And finally, a simplified approach to a child with suspected renal tubulopathy, a child who has got failure to thrive, polyuria, and polydipsia. First, please make sure there is no chronic kidney disease because of hypodysplastic kidneys. Check blood urea, creatinine, and aldosterone. If they are ruled out, look at specific gravity, pH, protein, and glucose in a complete urine examination. Get a venous blood gas and serum electrolytes, and then decide, is the blood pH normal? Is the sodium normal or high? Are we dealing with diabetes insipidus? Is there acidosis? Are we dealing with renal tubular acidosis? And then we define it further. Is there alkalosis? And then are we looking at Bartter syndrome or an older child with Gittelman syndrome? Again, please make sure we don't miss CKD before evaluating a child with renal tubular disorder. Most common being RTA. So friends, to summarize, we suspect renal tubular disorder in a child with failure to thrive, polyuria, and polydipsia. A detailed history, including birth weight and amniotic fluid index, are the starting points of an evaluation for a child with renal tubulopathy. Investigation should begin with complete urine examination, looking at specific gravity and pH, which are often not reported in majority of labs. It should include spot urine electrolytes, calcium, protein, and creatinine. looking at urinary anion gap, proteinuria, and hypercalciuria, a venous blood gas with electrolytes, renal function tests, calcium phosphorus alkaline phosphatase, and an ultrasound abdomen. Fortunately, all these tests can be done at most centers in the country. They are not very expensive, but they give us a lot of information. Finally, the diagnosis is usually easily made. We don't need to go in for very fancy investigations. Treatment is not only effective, economical, but more importantly, it decreases the morbidity and prevents progressive chronic kidney disease. Thank you so much.
Thank you, Dr. Mehul Shah. That was a wonderful presentation. And there's one question that is there posted by one of the delegates. How does hypokalemia cause polyuria?
Yes, I think that's a very good question, because potassium is required for the generation of cyclic AMP in the cells. And when there is hypokalemia, there is inhibition of adenyl cyclase. There's decreased production of cyclic AMP, and cyclic AMP is required for mobilization of the aquaporin transporters, aquaporin 2 especially and 4, in the cortical collecting and the medullary collecting ducts from the intracellular compartment to the luminal membrane. So as we know that for water reabsorption, we need channels. We have water channels or water pores, which are called as aquaporins. Normally, they are there inside the endoplasmic reticulum. For them to be shifted from the endoplasmic reticulum to the luminal membrane, we need the second messengers, which is the cyclic AMP. And when there is hypokalemia, it inhibits the adenyl cyclase, and hence there is decreased mobilization of aquaporins to the luminal membrane, and hence there is decreased reabsorption of water, and hence there is extra flow of water in the urine, and that causes polyuria.
Thank you very much, sir, for that wonderful explanation as well. With this, we come to the conclusion of this session, and I would like to thank all the three speakers for their excellent presentation. I'm sure the audience enjoyed all your presentations. I'll now hand over the proceedings to Dr. Sangeeta. Thank you.
Thank you very much, Dr. Sukanya, for the moderation. Thank you, Mehul sir. Really, it was a wonderful session. Always your approach to tubular disorders, starting from the postgraduate period, we love to hear from you. Thank you very much, sir.
Thank you.
Now we will break for lunch, and we'll start the session at 2:20. Thank you all.
Hello.
A very good afternoon, all. So,
Dr. Manikandan.
Yes, sir. Welcome, sir. So we are going to start the afternoon session. I invite Dr. Manikandan to moderate the session. Dr. Manikandan, sir, is the proud alumni of Sri Ramachandra Institute of Higher Education and Research, currently working as professor in SRMC. His field of interest are dialysis, renal transplantation, glomerulonephritis. He has 10 years of experience as nephrologist since 2013 till date. He has published 7 articles in national and international journals. Over to you, sir. I request you to moderate
Yes,
the session and introduce the speaker.
Yes, ma'am. Good afternoon, everyone. The next speaker is Dr. Kalavani Ganesan. She has completed MD Pediatrics Fellowship in Pediatric Nephrology. Currently, she is working as a Senior Consultant in Department of Pediatric Nephrology, Mehta Multi-Speciality Hospital. And also, she also consults in Rela Institute and Medical Center. Her area of expertise are critical care nephrology, glomerular disease, and chronic kidney disease. Some of the awards and honors are, she's an awardee of World Kidney Day Project 2022, a recipient of ISN grant in 2018, 19, and 2022. Current executive committee member of Nephrology Association of TN and Puducherry. Also, she's a reviewer of Clinical Nephrology Journal, reviewer of International Journal of Nephrology, and member of ISN and IPNA. And also has varied publications in multiple journals. And also, I really thank her for coming up for this to deliver this speech. And she's also, I'm happy that she has come, and she's one of my classmates in UG. So I really welcome her for delivering this speech, madam. Over to Dr. Kalavani Ganesan, madam.
Thank you, Dr. Manikandan, for the kind introduction. I'm very happy that we got to meet in this platform after many years.
Same here, madam. Same here.
Good afternoon, everyone. I first like to thank Dr. Sangeeta for this wonderful opportunity and taking the CME away ahead for the World Kidney Days as a part of World Kidney Day celebration. So today I'll be talking on hypertension in children. Slides are visible?
It's visible. Can you please go to the slideshow, Dr. Kalai?
I'm already in slideshow. I've moved to slideshow now. Is it visible now?
It's visible, but not in the slideshow mode.
Okay, I've already changed to slideshow. Is it visible?
Okay, I think you can present, but just check whether it is moving.
Okay,
can you go to the next slide, please?
I think I have moved to the second slide. The specific learning objectives. Is that slide visible?
It's blank. Sorry.
Okay, I'll just see. Is it visible now?
No, Kalai.
No, Kalai. Still not visible. Now it is visible.
Yeah.
I think in slideshow, it's not visible. Now it's not.
You can present in this mode only then.
Fine. So the objective of this presentation is to understand the management of hypertension in children and to know the definition of hypertension through case-based scenarios and to comprehend the etiology of hypertension in children in order to enable optimal management strategies and to choose antihypertensives according to the various case series. So how do you define hypertension? You're able to see my slide? I'm in the definition part of hypertension.
We could see the specific learning objectives slide.
Oh, no, I have moved to the next slide. I think it doesn't work in slideshow. Fine. So the hypertension is, how do we define hypertension? Hypertension is defined as when you have a systolic blood pressure and a diastolic blood pressure, which is greater than or equal to 95th percentile for that specific age, sex, and height on 3 or more occasions. And any child more than 13 years is liable to have hypertension when you have a blood pressure reading of more than 130/80. And elevated blood pressure is when you have a systolic blood pressure or a diastolic pressure which is greater than or equal to 90th centile or less than 95th percentile, but less than 95th centile. And a child of more than 13 years is said to have elevated blood pressure when you have a blood pressure reading of more than 120/80. So whenever you have a child with elevated blood pressure, what is the next step you need to do? So you need to first confirm whether the child has got elevated blood pressure or not. So you need to have a multiple BP readings. It's because blood pressure in childhood is quite liable and can fluctuate widely even in children with secondary hypertension. And so according to the 2017 American Academy of Pediatrics clinical practice guidelines, you should have minimum 3 abnormal readings obtained at 3 different times or needed to before you establish a child as having hypertension. And we should always remember that elevated blood pressure obtained by oscillometry should be confirmed by oscillatory method. And so whenever you use blood pressure machine, you should make sure whether the cuff is adequately fitted and it has been handled in a right way. So the main thing is the child has to be seated with the back supported and the feet has to be on floor. And the child should rest minimum for 5 minutes before making a reading of BP. And the child should not be talking and there should not be any device use or any other activity done during the BP recording. And use a correct sized cuff and repeat at 1 minute's interval. And so how do we choose a correct sized cuff? So you need to know the mid-arm circumference. Ideally, arm circumference should be measured and the proper cuff size has to be chosen. And you should measure between the acromion and the olecranon process and make sure your bladder width is at least 40% of the circumference at midpoint, and the length of the bladder has to be between 80 to 100% of the circumference at the midpoint. And we should know that we should always have variety of cuff sizes at your office practice. And this is a blood pressure reading as per the 2017 AAP clinical practice guidelines. A normal blood pressure is when you have a blood pressure of less than 90th centile for children aged between 1 to 13 years. And you consider them as having elevated blood pressure when the reading is more than 90th percentile to less than 95th centile, or when you have a blood pressure of 120/80 or less than 50th percentile, and consider whichever is lower. And stage 1 hypertension is when you have a blood pressure reading of more than 95th centile to less than 95th percentile plus 12 millimeters of mercury, or when you have a blood pressure reading of 130/80 to 139/89, and consider whichever is lower. And stage 2 hypertension is when you have a blood pressure of more than 95th percentile plus 12 millimeters of mercury, or more than 140/90 millimeters of mercury, and consider whichever is lower. And for children more than 13 years of age, the normal blood pressure is less than 120/80 of systolic and diastolic. Elevated blood pressure is when your systolic blood pressure ranges between 120 to 129, and make sure that your diastolic blood pressure is less than 80. And stage 1 hypertension is 130/80 to 139/89, and stage 2 is when you have a blood pressure reading of more than 140/90. So these guidelines are derived from the 2004 guidelines, and there are new replacements from the 2004 guidelines. The significant changes in these guidelines include the replacement of term pre-hypertension with the term elevated blood pressure, and there is a new normative pediatric blood pressure tables based on the normal weight of the children, and there is a simplified screening table for identifying blood pressure, and simplified BP classification for adolescents more than 13 years of age is in association with the American Heart Association guidelines too, and are more limited recommendations to perform screening blood pressure measurement only in a preventive care visits. And there is always a streamlined recommendations on initial evaluation and as well as in the management of abnormal blood pressures. And there is now an expanded role for ambulatory blood pressure monitoring. And revised guidelines has also come up with when to perform echocardiography in an evaluation of newly diagnosed hypertensive children. Generally, before starting the pharmacological treatment. So this is a simplified table which shows according to the age and the gender based. And so you can classify hypertension as transient and intermittent hypertension, or intermittent hypertension and persistent hypertension. Transient hypertension, the most common cause in children is renal, followed by drugs and poisons. Central causes, and in renal causes you have the most common cause of acute post-infectious glomerulonephritis, and in drugs you have the common drugs which we predominantly use in nephrology, the corticosteroids and cyclosporin. And in central nervous system, the common things we encounter is increased intracranial pressure, which is causing high blood pressure, GBS, transverse myelitis and porphyrias. And what are all the causes of persistent hypertension in children? Persistent hypertension in children, the predominant cause is renal cause, followed by your vascular causes, endocrine causes, and your central nervous system. And in renal causes, which are the things which are highlighted in bold, are the ones which are the common causes of hypertension. So in renal causes, you have the renal scarring, chronic glomerulonephritis, polycystic kidney disease, and in vascular causes, the common causes is coarctation of aorta, renal artery stenosis, vasculitis, and Takayasu. In endocrine, you have the congenital adrenal hyperplasia because of 11-beta hydroxylase and 17-hydroxylase deficiency, and you also have the central nervous system causes. So how do you divide hypertension according to the age? So the common causes of childhood hypertension according to age group is, you can divide them between 1 to 6 years, 6 to 12 years, and between 12 to 18 years. And between 1 to 6 years, the most common cause of childhood hypertension is renal parenchymal disease, followed by renal vascular. Between 6 to 12 years, you have the renal parenchymal disease again and the essential hypertension. Between 12 to 18 years, you have the essential hypertension, the predominant cause. And so according to the literature review, the common cause of hypertension in children is renal parenchymal disease, which accounts for around 68%, followed by the endocrine cause, which is around 11%, followed by your renovascular cause, which is around 10%. So we'll go through few clinical, the case scenarios. My slide is visible. Are you able to visualize case 1 slide?
No, madam, no. We are still in that persistent hypertension in children causes. Now we have moved on to the case 2.
So
yeah, now case 1.
Fine, no?
Yes.
It's a 5-year-old boy who presented to us with a cola-colored urine with periorbital edema and a mild oliguria for last 5 days, and the child had multiple pyodoma lesions 3 weeks ago, and the blood pressure was falling on stage 1 hypertension. Urine analysis showed RBC cast and proteinuria of 1+, and the protein creatinine ratio was 1.1, and urea was 38, creat was 0.7, azo was positive with the low C3 levels, serum albumin was 2.9, and so it is very easy to make this diagnosis. The diagnosis is post-streptococcal glomerulonephritis. And so in the hypertension in this child is basically because of volume overload. So IV furosemide and oral nifedipine helps in management of PSG and hypertension, and amlodipine can be added. And within few weeks, within 4 days, edema subsided. And at 8 weeks follow-up, the child had normal C3 and the eGFR has increased to 104 ml. Blood pressure normalized. There was no proteinuria, but there was minimal RBC cast. So on follow-up, this child is a feature of acute nephritic syndrome with a clinical and serological evidence of post-streptococcal glomerulonephritis. And there was low C3 levels with normalization of C3 at the end of 8 weeks. And so what is the role of, what is the antihypertensive in this scenario is the basic thing as already discussed. It is because of the volume overload which is causing hypertension. So basic thing is you need to restrict salts, and the next thing to be added is the loop diuretics, and is the first line, followed by your treatment with your vasodilators. And you should always remember that ACE inhibitors are not recommended during acute phase due to decreased GFR and hyperkalemia in these children. And in case if the child is landing up with hypertensive emergencies, then you can use antihypertensive infusions like sodium nitroprusside and labetalol. Moving on to case 2. It's a 7-year-old boy who presented to us in the year of 2018 with a fever of a week ago for 2 days, and child had significant pallor with a decreased urine output for 5 days. There was no diarrhea, dysentery or rashes or jaundice. On examination, child was found to have edema and volume overload was there. Blood pressure was falling under stage 2 hypertension. There was no hepatosplenomegaly. Hemoglobin was low, and platelet count was 63,000 with significant cystiocytes and elevated LDH, and retic count was around 8%. Blood urea was 180 and creat of 5.2. And the child who had significant hyperkalemia with a potassium of 7 and sodium was 129. Urine analysis showed significant RBCs and proteinuria was 2+. With these values and abnormal renal function, the child had to be taken for hemodialysis. And for the evaluation, direct sputum test was negative. Coagulation profile and LFT was normal. Repeated evaluation for malaria was negative. Serology was negative. Serum C3 was low, but IANA and anti-DS DNA was negative. So this child required multiple antihypertensives for control like amlodipine, atenolol, prazosin and clonidine. And so what would be the possible diagnosis and what is the cause of hypertension in this child? So the possible diagnosis is hemolytic uremic syndrome, because factor H autoantibodies was elevated. And so the child required plasmapheresis around 15 to 18 sessions over 1 month, and required hemodialysis as well, followed by immunosuppression. And at the end of 3 years follow-up, the child had serum creatinine of 0.79. From 5.2, it had become 0.79. But still the eGFR is 79, which is falling under CKD stage 2. So this child continues to be on antihypertensives with amlodipine, atenolol and prazosin. And this child has got a concentric LVH, but no retinopathy. There is still proteinuria and with a UPCR of 0.8. So enalapril was added to it because the child is still in CKD stage 2. Now post enalapril, there is no proteinuria. HUS activity is in remission. So according to the AAP guidelines, it has been said that children and adolescents with CKD, hypertension and proteinuria should be treated with ACE inhibitors or ARBs. It is a strong recommendation. And so when is echocardiography recommended in these hypertensive children? Echocardiography is to be performed to assess a cardiac target organ damage at the time of consideration of pharmacological treatment. So like whenever you're planning to start the child on pharmacological treatment, you need to have a documented echo. And LVH is defined by these indexes, and repeated echocardiography may be performed to monitor the improvement or progression of target organ damage at the end of 6 to 12 months interval. And the indication for repeat echocardiography can be either persistent hypertension despite treatment, or when you have a concentric LVH or reduced LV ejection fraction. So moving on to case 3. It's a 9-year-old girl who presented to us with periorbital and puffiness for 1 week and passing red-colored urine and oliguria noticed for 4 days. She had been growing well and was asymptomatic. There was absolutely no history of pyodoma, pharyngitis, rashes, or arthritis. Her blood pressure was falling under stage 2 hypertension. Blood urea was 196 and serum creat was 5.2. And urine analysis showed significant RBC cast and 2+ of proteinuria. So on further evaluation, this child was found to have low C3, HPS, AG, HIV, HCV, ANCA, everything was negative. ECG was normal and fundus as well was normal. So what is a probable diagnosis in this child? It is rapidly progressive glomerulonephritis. The cause of RPGN is with low C3 in RPGN. So it is a rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis is defined when you have a glomerular filtration rate of at least a 50% drop in the setting of glomerulonephritis. And when you have a biopsy proven which shows more than 50% of crescents. So this child was further evaluated and ASO was negative. This child continued to have uncontrolled hypertension. So was started on nitroprusside infusion. Child was on oral amlodipine, prazosin, atenolol, clonidine, minoxidil along with your IV infusion of nitroprusside. And the child had to undergo 8 sessions of hemodialysis over 2 weeks. And the child was immunosuppressed with methylprednisolone and cyclophosphamide. And slowly we tapered the prednisolone dose. So this is a child with crescentic glomerulonephritis due to C3GN. So in hypertension in this case required multiple antihypertensive drugs, and a child also required hemodialysis along with treatment of RPGN with immunosuppressive drugs. So serum creatinine decreased to 0.72 at the end of 3 months. UPCR was normal at the end of 3 months, and child was off antihypertensives at the end of 4 months and were on tapering dose of oral steroids and mycophenolate. So moving on to case 4. It's a 2-year-old male child who was referred to us with incidentally detected to have hepatomegaly. And developmentally, it's a normal child, and blood pressure was falling under stage 2 hypertension. Echo and fundus was normal, but on examination, there was bilateral kidneys and spleen was palpable. Ultrasound showed a significant renomegaly with the right kidney of 11.5 and left kidney of 11.8, which is a significant renomegaly for a 2-year-old child with increased echogenicity. So this is a MRI, which was suggestive of Gallery disease with congenital hepatic fibrosis. On further evaluation, child was also had esophageal varices. Creat was normal, which was 0.32. Child was started on enalapril and amlodipine atenolol thiazides was added later because of the blood pressure control. So diagnosis in this child and cause of hypertension this is a clear-cut diagnosis of autosomal recessive polycystic kidney disease with Gallery disease with congenital hepatic fibrosis. And so genetic evaluation was done, which was proven to have PKHD1 mutation. So we should know that ARPKD children, even though they have a normal kidney function, around 80% of children tend to have hypertension. Even in normal renal function, they do have hypertension. And the main mechanism behind hypertension in these children is the renin-angiotensin-aldosterone system. And some have volume overload features as well in case if they have a low GFR. And enalapril is considered as a standard care. And amlodipine is controversy as it is said to have increased the cyst size, but it is more so in animal models. And in these ARPKD children, beta blockers, thiazides, especially if they have a concentrating defect in form of polyuria. So moving on to case 5. It's a 4-year-old girl who was incidentally detected to have hypertension during her health visit. Her blood pressure was falling under stage 2 hypertension, and there was no edema, anemia, headache, or vomiting features suggestive of hypertension. There was a past history of recurrent fever without cause, and the child required antibiotics for resolution of fever, and urine culture was never being performed. Ultrasound was suggestive of left kidney of 8.4 and right kidney was smaller, which was 3.4, but creat was normal. Urine analysis, there was no significant findings. Echocardiogram showed normal, and fundus showed grade 2 hypertensive retinopathy. And the child had undergone a DMSA, which showed a small right kidney, which had a function of only 18%. And the main cause of hypertension in this child is renin-angiotensin system implicated in genesis of hypertension in reflex nephropathy. And the main thing is plasma renin activity was found to be high, and in these children with renal scars, ACE inhibitors is a preferred antihypertensive drug. And because the child has been having reflex, you need to carry out with uroprophylaxis. So the common question which would rise whenever you are seeing any child with hypertension is, how do we approach a child with hypertension? How do we investigate, evaluate hypertension in children? What is the role of ambulatory blood pressure monitoring and the management strategies? So the common histories you need to take is like you need to look for the peripheral pulses. In case if you have a difference in peripheral pulses, you need to think of coarctation of aorta. When your height and weight, in truncal obesity, all those things more in favor of Cushingoid. When you have a skin finding, say capillate spot, it is more in favor of neurofibromatosis. Adenoma sebaceum, which is in favor of tuberous sclerosis. And in abdomen, you find abdominal mass, then it is in favor of neuroblastoma, Wills tumor, or any cystic kidney disease. And genitourinary system, if you have a finding of ambiguous genitalia, then you're more in favor of CAH. So what is the reason to actually investigate in these children? The main reason you need to investigate in these children is to identify the cause. So to identify the cause, to identify the comorbidities of hypertension, to identify the end organ damage because of hypertension, and the additional testing as indicated. The additional testing would be like renal scan, MRI angiogram, duplex Doppler flow studies, or three-dimensional CT angiogram. So who are all that high risk conditions for which ambulatory blood pressure monitoring is required is whenever you have a child with the secondary hypertension or any child with CKD or structural renal abnormalities, when you have a child with type 1 or type 2 diabetes, or a child who has undergone a solid organ transplantation, obesity children, obstructive sleep apnea, and few other genetic disorders. And masked hypertension and white coat hypertension also requires ambulatory blood pressure monitoring. And when you need to adjust the dose of antihypertensives in a CKD child, you require ABPM monitoring. And so according to the clinical practice guidelines, drug for hypertension, children and adolescents with CKD, hypertension and proteinuria should be treated with ACE inhibitors or ARBs. It is a strong recommendation. And in hypertensive children and adolescents who have failed lifestyle modification, particularly those who have LV hypertrophy or echocardiography, positivity, then the clinician should initiate pharmacologic treatment with ACE inhibitors, ARBs, and a long-standing calcium channel blocker or a thiazide diuretic, which is a moderate recommendation. So what is the treatment goal of any child who is diagnosed to have hypertension? So in children and adolescents diagnosed with hypertension, the treatment goal with non-pharmacological and non-pharmacological therapy should be, the aim is to reduce the systolic and diastolic blood pressure to less than 90th percentile and less than 130/80 in adolescents more than 13 years or older. And in children and adolescents with CKD, should be evaluated for hypertension at each medical encounter, and children or adolescent with both CKD and hypertension should be treated to lower 24 hours MAP to less than 50th percentile. So in CKD children's, ABPM is mandatory, and your aim is to bring down the blood pressure to less than 50th percentile by ABPM. And this is the ISPN guidelines, which tells us how do we approach. So any child who's presenting with hypertension, you need to start with CCV or ACEV inhibitors or beta blockers. If the blood pressure is more than 95th percentile, then you need to try combination therapy in form of ACE plus calcium channel blockers, or ACE with thiazide diuretics according to the etiology, beta blockers or plus your calcium channel blockers. And if you still continue to have a blood pressure reading of more than 95th percentile, then a combination therapy of ACE plus CCB plus prazosin or beta blocker or a thiazide need to be added. And additional agents can be with clonidine, labetalol, hydralazine or minoxidil. And if you are handling a child with CKD, then you need to restrict salt as well. So essential hypertension, ACE, CCB, later beta blockers, and thiazides not preferred in obesity. And in case of acute glomerulonephritis, furosemide is the drug. And if required, you can add a calcium channel blocker. And for children between CKD stage 1 to 3, the first drug will be enalapril to control proteinuria. And in case of renal scars, in case of reflex nephropathy, enalapril is a drug of choice. And in case of endocrinal disorders, then you need to add spironolactone according to the indication. So this is a stepwise approach in a child. Begin with recommended initial dose of desired medication. If the BP is if BP control is not achieved, you have to increase the dose until desired BP target is reached, or maximize the doses till it is reached. If BP control is not achieved still, then add a second medication with a complementary mechanism of action, and you need to proceed to the highest recommended dose. And if BP is still not achieved, then you need to add a third antihypertensive with a different group. So the take-home message is hypertension in children is commonly of renal or renovascular origin. You need to look for the target organ damage in children with the hypertension in form of concentric LVH or retinopathy. Serum creatinine, urine analysis, ultrasound, renal Doppler, DMSA, CT angio are useful in evaluation depending upon the underlying history and etiology. And treatment goals is systolic blood pressure and diastolic blood pressure has to be less than 90th centile. And in CKD children's, your aim is 24-hour MAP by ABPM should be less than 50th centile. And enalapril is the drug of choice in case of CKD stage between 1 to 3. And prompt and correct antihypertensive usage is essential for optimal control and good, better outcomes. Thank you.
Thank you, Dr. Kalai. It was a very good presentation. I have a doubt on you have covered from right from the basic, from how to check BP to common causes to the rare causes and the treatment as well. But I would like to know how difficult is the patient on dialysis, a pediatric dialysis patient with resistant hypertension, and what would be the preferred drugs? How do we plan on drugs on those patients in dialysis population?
Okay, on dialysis population, enalapril is a good drug of choice, and definitely all dialysis patients will require multiple antihypertensives. It requires vasodilator, it requires AC inhibitors, if required ARBs as well. And centrally acting clonidine also plays a role. They will require multiple antihypertensives, it is of no doubt.
No, where do you put ACARBs at the first drug of choice, or after trying the central and peripheral acting drugs, and then you start with the pediatrics? In adult population, we try it as a last resort because the threat of hyperkalemia or other causes, other side effects, we tend to keep it as a last resort.
Okay, like usually what has been practiced is till stage 3 CKD, we do give enalapril for control of proteinuria and as well as for a minimal antihypertensive coverage. It acts as a minimal But in case of children who are on dialysis, they are already on dialysis, you try adding enalapril in case if the enalapril is going to cause your hyperkalemia or any acute events, then you need to withdraw. But enalapril is still a good choice. We take it as a first drug as well.
Thank you.
Adding on to other antihypertensives that alone will not work.
Okay. And also a note on post-transplant hypertension, the drug of choice in pediatric population.
The best thing to my knowledge is vasodilators. If anyone can add on to it, you're welcome.
Nice.
Calcium channel blockers.
Okay, madam. Okay.
Calcium channel blockers, we take it up. And when we talk about this AC inhibitors in children with the advanced CKD, as you said, in many institutions, they won't prefer enalapril as a first drug of choice for children who are under dialysis.
Okay, madam.
But as Dr. Kalevani said, for the initial stages, if the renal functions are stable, and especially in a child who is having proteinuria, definitely that is the first drug of choice.
Okay.
But when the child is put on dialysis, definitely the risk of hyperkalemia is there, as you said. So we tend to keep that as the last drug.
Okay. Thank you. Thank you so much.
It can only be an add-on drug with other antihypertensives that alone as working as antihypertensive when a dialysis child is not possible.
Yes. So basically the drugs has to be planned according to the etiology of the CKD and control as well as the response of the drugs which we add.
Yeah.
Thank you, man. Thank you. Thank you so much.
Thank you.
Dr. Kalevani, you have one question for the discussion.
Okay.
What is the suggested interval between 3 BP readings that is required to diagnose hypertension in a pediatric population?
We usually say it is between 1 week, but there are no clear-cut guidelines which says that so many weeks apart you need to do. But minimum 3 readings has to be there. But how many days or weeks apart, there is no such formulated guidelines.
When do we have to start the child on antihypertensives? I mean, if the BP is high, can we start the child on medication, but even with the first visit?
No, like here, that's what you need document to have 3 abnormal readings. And when your non-pharmacological therapy fails, or in case if you have any other underlying cause of hypertension, say obesity, or if it is going to be a transient hypertension or persistent hypertension, all those things we need to consider. In the first visit, documenting high blood pressure and adding antihypertensive is not recommended.
To add on this, whenever... Sorry?
You need to keep the child on surveillance.
Okay. To add on this, whenever the child is having underlying secondary causes like kidney disease, cardiac disease, then we may have to start them on antihypertensives. For the other children, we will be starting lifestyle changes first. I think, hope you will agree with me.
Yeah.
Thank you very much. Let's move on to the next topic. I request Manikandan sir to introduce the next speaker.
Thank you. Thank you, Dr. Kalai. That was a very controlled presentation. Thank you.
Thank you. Thank you, doctor. Thank you.
Next, we'll move on to the next speaker, Dr. Nivedita Kamath. I'm very happy to introduce her, and thanks, madam. Thanks for coming. And madam has completed MD Pediatrics, DNB, and DM Pediatric Nephrology, and currently she's working as an associate professor, Department of Pediatric Nephrology, St. John's Medical College, Bangalore. Her area of special interest are chronic kidney disease, chronic dialysis patient, neonatal AKI, and now she also has a honorary faculty. She's also a honorary faculty, Kasturba Medical College, Bangalore. Member Bulletin Editorial Board, Indian Society of Pediatric Nephrology, member Committee of for Priorities in Low Income Countries, International Pediatric Nephrology Association. We welcome you, madam, for this to deliver the speech.
Thank you. Thank you for the kind words of introduction. Thank you, Dr. Sangeeta and team. It's always a pleasure to be associated with all of you. We have very happy memories of having shared.
Ma'am, your video is very feeble, ma'am.
You cannot hear me?
Sorry, audio.
Yeah, can you hear me now?
Very audible. Audio is very low, ma'am. Volume is so low.
Maybe I'll just disconnect. Is it better now?
Yes, ma'am.
Better, ma'am.
Okay.
Better.
Okay, can you see my screen?
Yes, ma'am. Yes, ma'am. Yes.
Okay, just give me a minute. Yeah, thank you to Dr. Sangeeta and team. We have always had a very good association with all our friends and colleagues in Chennai, and this is yet another opportunity to be associated with them on this at the CME. And thanks to Dr. Sangeeta for giving me a topic which I'm interested in, that is chronic kidney disease in children. As this cartoon shows, every primary physician, pediatrician always likes to have a friendly specialist to whom he can refer difficult cases. And chronic kidney disease is one such condition where timely referral matters. And let's see why. Pediatric CKD in LMIC, what are the challenges for timely referral? When to suspect CKD? This is a very important aspect because only when you suspect CKD will you be able to diagnose, and only when you diagnose will you be able to refer the child to the pediatric nephrologist in a timely manner. Once a timely diagnosis is done, what is the next step? What are the consequences of late referral? This is some of the data that we have seen at our institution and published. We found that 30% of patients were newly diagnosed to have late CKD, that is stage 4 and beyond, at presentation. We had, when we compared our cohort of CKD to what is already reported from high-income countries, they have a higher burden of comorbidities, probably attributable to late referral. The rate of decline of GFR in our cohort was twice that of the Western cohort. That is the mainly the published data from the Nephrotic and the CKID, which are the largest registries and studies of CKD in children. 21% of CKD were incidentally diagnosed while presenting with a life-threatening emergency. So about a fifth of CKD children presented with life-threatening emergency when their diagnosis was established. And in those who presented with a life-threatening emergency and incidentally diagnosed, had a higher need for emergent initiation of dialysis dependency, and because the parents and the family were completely unaware and unprepared for such a huge diagnosis and management, they also had a higher rate of discharge against medical advice. So we know that late referral can have life-threatening consequences. But what are the challenges? Why is timely referral not happening in most of our patients? This is because, firstly, of delayed diagnosis. We know that CKD is a great mimic. It does it especially in children and also in adults. There may not be very specific signs and symptoms that are attributable only to kidney disease. Many a times it needs a high index of suspicion. So the diagnosis itself may be delayed. Once diagnosed, patients and families, especially when given such a grim diagnosis, may opt for alternative systems of medicine after consulting neighbors, friends, Google, etc. Also, financial and logistic issues, the lack of pediatric nephrology services in small towns and villages, the difficulties in coming to larger cities, the financial aspects that are involved because therapy for especially end-stage kidney disease and renal replacement therapy are quite expensive. And we know that most of our population have out-of-pocket expenses. Very few of them have insurance or support from employers, etc. So what are the 10 clues for early diagnosis? We have looked at what the challenges are for referral, but can we diagnose these early, and then could that help us in referring these children in a timely manner? So these are 10 important clues for pediatricians who are seeing children, and you need to have a high index of suspicion. So I'm going to take you through a few case scenarios, most of which are cases that we have actually seen in our outpatient or inpatient departments. A 7-year-old girl presents with persistent vomiting for 4 days. Her height is less than -3 standard deviations. Her parents say that she's shorter than most friends of the same age. And when you investigate, you find that her creatinine is abnormal, and ultrasound shows bilateral small kidneys. So growth failure is an important marker of chronic kidney disease. Of course, not to undermine that growth failure can be caused by a zillion causes in children. But one cause of among all the long list of things that one needs to think of is also chronic kidney disease. So definitely look at nutrition, look at other systems that may be involved, but don't forget the kidney. A 12-year-old girl presents with fatigue, poor growth for 2 years, hemoglobin is 8 gram%. She's treated with iron for 9 months, has received 2 blood transfusions. Evaluation is done suspecting a hematological condition, but a HP electrophoresis is normal. Her creatinine, however, is found to be 2.3. And when we go back and look at the peripheral smear, she had normocytic normochromic anemia, which is very typical of anemia of chronic disease. So it took quite a while for her to be found to have chronic kidney disease, and because the search was for a hematological condition. So refractory anemia, anemia that doesn't respond to iron therapy, anemia that occurs despite blood transfusions or requiring blood transfusion itself without any apparent cause, one must think of a kidney disease. 6-year-old girl presented to the orthopedic surgeon and is referred to the pediatrician for clearance for surgery. And during evaluation is found to have an abnormal creatinine. So needless to say, bony deformities are often land up with the orthopedic surgeon, and many a times we have seen corrective surgeries being done before the metabolic workup is being done. So bony deformities should also give us an important clue to an underlying kidney disease. 13-year-old girl presents with severe headache for 3 months, is treated as migraine, and because she has blurring of vision is referred to an ophthalmologist. On the fundus examination, she has hypertensive retinopathy, and then her creatinine is found to be 1.7 and her blood pressure is 180 by 120 millimeters of mercury. Her DMSA showed a scarred kidney. So hypertension, as was very elaborately discussed in the previous presentation by Dr. Kalaivani, is an important clue to an underlying kidney disease. And most often in children, hypertension is of renal or renovascular origin. So don't forget to check the blood pressure in your patient. A 10-year-old boy presents with microscopic hematuria during an episode of fever. Though it is thought to be just an incidental hematuria that is found during an episode of fever, it is repeated after 4 to 6 weeks, and microscopic hematuria is persistent. However, probably because of the lack of understanding by the patient, there is a loss to follow-up, and he presents 3 years later with hearing loss, persistent microscopic hematuria, and also proteinuria. A biopsy, the electron microscopy, confirms the diagnosis of Alport syndrome, and his eye evaluation shows anterior lenticonus. So a persistent urinary abnormality should not be neglected. Some of the findings in the urine that may give us a clue to underlying CKD could be proteinuria. It's not only a marker of progression, but could be an early manifestation of dense disease, IgA nephropathy, membranous nephropathy, and will be detected only if looked for. Similarly, microscopic hematuria may be a sign of IgA nephropathy or Alport syndrome, as in our patient. Another situation where it's a 9-year-old boy who is the first child of a consanguineous marriage, presents with UTI and stones, is found to have ESRD requiring dialysis, and a genetic evaluation confirms primary hyperoxaluria type 1. Knowing that this is an autosomal recessive disease, the younger sibling is advised to get screened, and the genetics again is positive for PH1, though she is asymptomatic, and on evaluation is found to have CKD stage 2. So the presence of a family history of a genetic disease is definitely calls for screening of other siblings and family members. Familial CKD in the glomerular disease category, we often see it as steroid-resistant nephrotic syndrome of genetic origin, Alport syndrome. Among the tubular disorders, proximal RTA, cystinosis, dense disease, Lowe syndrome, nephrolithiasis, mainly primary hyperoxaluria, and polycystic kidney disease are the most common familial disorders leading to CKD. Sometimes you might detect CKD in the antenatal period itself. A family is referred for counseling because the antenatal scan at 34 weeks shows bilateral enlarged hyperechoic kidneys with oligohydramnios. So this is very characteristic of an autosomal recessive polycystic kidney disease, and one needs to not only counsel the family, but also advise genetic testing and screening of subsequent pregnancies. So as early as in the antenatal period, there may be a clue to an underlying kidney disease. What are the other markers of CKD in the fetus and newborn? The amniotic fluid may show oligohydramnios. There may be severe bilateral hydronephrosis with a keyhole bladder, which is the characteristic feature of obstructive uropathy. Enlarged echogenic kidneys, which may be seen in polycystic kidney disease. Bilateral small cystic kidneys, suggestive of hypodysplasia. The characteristic Potter's facies, spinal and genital abnormalities, which could be seen in the neonate, and a palpable bladder or a renal mass should also alert the pediatrician to an underlying disease that may lead to chronic kidney disease in this child. Coming to the next case, a 3-year-old boy who has been fulgurated for posterior urethral valve at 6 months of age, but the parents presume that a surgical cure has been attained and are lost to follow-up. He has had recurrent episodes of UTI and now presents with a scarred kidney with an abnormal creatinine. So urinary tract abnormalities and recurrent UTIs are definitely a predisposing factor for CKD, and every child with a urinary tract abnormality or a recurrent UTI must be evaluated for CKD. Another case scenario of an older child, a 15-year-old boy who has been hale and hearty, has been diagnosed to have AKI stage 3 after a snake bite, requires 3 weeks of hemodialysis. The creatinine at discharge is 1.5 mg%. Unfortunately, because the dialysis has been stopped and the patient is discharged, they presume that all is well, but come back 3 years later with an abnormal creatinine. Presumable diagnosis of a cortical necrosis. So an underlying AKI is always a risk factor for CKD in the future, and all these children must be kept under close follow-up. AKI to CKD is now considered a continuum and not two separate entities. The common risk factors are the extremes of age, genetic factors, associated problems like hypertension, metabolic syndrome, some disease modifiers like severity of CKD, the stage of chronic kidney disease, the number of episodes of AKI, the duration of AKI and proteinuria may be important risk factors, and the outcomes may involve not only the kidney, but also disability, cardiovascular disease, and diminished quality of life and mortality. A 9-month-old girl, polyuria, rickets, on evaluation has proximal RTA. At 16 months is found to have cystine crystals in the cornea. Her creatinine is 1.1, and it's quite an easy diagnosis of cystinosis. But what is the important point here is that some conditions with or without treatment lead to end-stage kidney disease at the end of the road. There may be modifiable or non-modifiable risk factors. For example, some of the modifiable conditions may be non-genetic steroid-resistant nephrotic syndrome, which may be modified with immunosuppressive therapy, obstructive uropathy with good care of the bladder, and cystinosis with cysteamine therapy. However, there may be some non-modifiable conditions where only supportive therapy may help. For example, steroid-resistant nephrotic syndrome of the genetic variety, congenital anomalies of the kidney and urinary tract, bilateral hypodysplasia, aplasia, familial hypomagnesemia, hypercalciuria, and nephrocalcinosis, nephronophthisis, and autosomal recessive polycystic kidney disease. So once a timely diagnosis has been done, looking at all these clues that we discussed thus far, what is next? Of course, you could refer this child to your friend, a pediatric nephrologist, but what do you think the pediatric nephrologist would do differently? The most important aspect of management of chronic kidney disease in children is comprehensive team management of various complications and looking at supportive therapy as well. So the first step would be to stage and identify complications, early interventions to prevent progression of CKD, frequent monitoring to assess catch-up growth and correction of bony deformities, and counseling of families to prepare them for what is at the end of the road, that is end-stage kidney disease and initiation of renal replacement therapy. Of course, this is the most recent guideline by the KDIGO for staging of CKD, but it seems a bit complicated. It involves both the GFR stages and the proteinuria. The simple ISKDC classification could be used, which is based only on the GFR, and based on a GFR more than 90, which is stage 1, 60 to 89 as stage 2, 30 to 59 as stage 3, 15 to 29 as stage 4, and less than 15 as kidney failure or ESRD, which was previously known as ESRD, is now known as kidney failure, could be made. The most important complications of CKD in children are the abnormalities of growth and nutrition, the problems of anemia, acidosis, mineral bone disease, hypertension, and cardiovascular disease. All these need to be assessed not only at baseline, but at periodic intervals, depending on the therapy, the stage of CKD, the native kidney disease, the age of the child, etc. The timeline of complications: proteinuria, we know, can be present very early and can be missed if one does not look for microalbuminuria. Growth failure occurs around CKD stage 2, but again may be dependent on several factors. Anemia is usually seen at CKD stage 3B, 45 GFR of 45 onwards. Mineral bone disease, overt mineral bone disease becomes more manifest in the later stages of CKD, though very early in CKD, there may be biochemical abnormalities that may not be detected. Hypertension could occur at any of the points during the decline of GFR based on the native kidney disease. So all these factors need to be monitored at regular intervals. How do we prevent progression of CKD? Of course, blood pressure control is an important aspect of prevention of progression. In addition, reduction of proteinuria, healthy diet, and exercise are important components. Regular monitoring is required for all the complications that we have just discussed, because CKD is a continuum that goes from infancy to adulthood, and in adulthood could have a list of long-standing complications, including the bone in the form of bony deformities, fractures, vessel problems like ectopic calcifications, cardiovascular problems like LVH, myocardial infarction, arrhythmias, failure to achieve the adult final height, and of course, CKD progression itself. Supportive care involves immunization, not only the regular national immunization schedule, but also the optional vaccines, especially in preparation to transplantation. Quality of life, and looking at it in terms of appetite, sleep, ability to interact with peers, attend school, and lead a normal life are important aspects that one should give importance to. Care of the bladder and other extrarenal issues. Sometimes CACUTs may be associated with mental retardation, with other cardiac defects or hearing abnormalities. All these need to be addressed as a part of comprehensive care, and emphasizing on compliance and follow-up, because it's a long journey from childhood to adulthood, and CKD is going to be there throughout life, irrespective of whether they are on renal replacement therapy or transplantation. They need to be compliant with medications and have regular follow-ups. So this can never be overemphasized. Counseling plays a very important role in the management of a child with CKD. So involving the family, the supporting members of the family, the extended family, and in older children, the children themselves is very important at various stages of CKD and in preparation for end-stage kidney disease. So to summarize, a high index of clinical suspicion is required and close follow-up and monitoring following an early diagnosis. Once the diagnosis is made and timely referral is done, staging of CKD, identification of complications, preventing progression of CKD, regular monitoring, and preparation for ESKD care is required. So this is our team that takes care of children with chronic kidney disease. These are all transplant patients, and it definitely takes a huge team to care for a child with CKD. Thank you.
Thank you, madam. That was a very nice presentation and a very important presentation. Being an adult nephrologist, we tend to see many patients, suddenly they land up in CKD where they've been managed outside by other physicians. But And very importantly, rightly, you told that preparing them for what next to come, that is very, very, very important. That at least we can, but there is one set of patients without knowing what next, suddenly they come up with a creatinine of 9, being starting on dialysis. There they go for disbelief, or they go for alternative medication. They waste a lot of time, and that happens in adult population. So right time referral prevents, and it stops all these things to happen. So therefore they can go ahead with positively to the next level of treatment. And also in our setup population, we encounter such diabetic patients where they have proteinuria. It has been where when we have to suspect a non-diabetic renal disease in a set of diabetic patients, it has been masked only by the proteinuria. Only when nephrologists look into it, they also look into the associated urinary sediments as well as the course of the proteinuria. Then we come to know that we have to look and go for a biopsy and to diagnose non-diabetic renal disease in a diabetic patient. So all these makes a difference. So it is better we get a nephrology opinion at an early stage to avoid such complications.
Absolutely. Thank you.
Dr. Sangeeta?
Yes, sir. Ma'am, you have few questions.
Sure.
In the antenatal scans, when you see this enlarged echogenic kidneys alone, is it an indication for medical termination of pregnancy?
So enlarged echogenic kidneys are an indicator of, they could be a sign of an underlying kidney disease like autosomal recessive polycystic kidney disease. So it depends on how big the kidneys are, and also what is the status of the amniotic fluid. So if there is an associated oligohydramnios, if there is an underlying consanguinity or a previous pregnancy loss or a previous child with an autosomal recessive polycystic kidney disease, it becomes easier to diagnose. And we may be more confident in giving this diagnosis. If not, it would be better to confirm the diagnosis in the early stages, maybe by amniotic fluid analysis or a chorionic villus sampling, or that may be very early where it's not detected by ultrasound. Usually, if there is no severe oligohydramnios, we would advise them to continue the pregnancy. If there is severe oligohydramnios, sometimes we have even seen antenatal scans with anhydramnios in the late trimester, then we counsel them that this child may have severe pulmonary hypoplasia and may be incompatible with life itself, because there is severe pulmonary hypoplasia, there is need for high pressure ventilation and risk of complications. Also, the kidneys are not functioning because that is reflected with the severe oligo or anhydramnios. So these are the options that can be given to the patients.
Thank you, ma'am. The next question is, you discussed that renal stone disease, especially hyperoxaluria, can go for CKD. While we were evaluating a child with stones, crystalluria evaluation found to have hyperoxaluria. It was more than 1.5 milligram per kg per day in the 24 hours urine protein. Genetic analysis showed type 2 hyperoxaluria. How will you manage this child?
So what is important to see is that in type 2, primary hyperoxaluria also has a risk for progression to CKD. So one thing is to do a baseline evaluation of what is the status of the child in terms of the kidney disease, in terms of looking at all the comorbidities that may be associated with the CKD itself, and managing them. Usually these children may have multiple issues in the form of recurrent UTIs, recurrent obstructive episodes requiring interventions. And depending on how these things happen, if they have multiple recurrent UTIs with AKI obstruction, they may progress to CKD. And when they progress to CKD and ESRD, they will definitely require transplantation. So they have to be managed like any child with CKD, but giving specific emphasis for prevention of UTIs, for regular screening of obstructive symptoms because of calculi.
Thank you very much, ma'am. The next question is, what will be the course of management if the antenatal ultrasound shows bilateral hydroureteronephrosis?
Okay. So if the antenatal scan shows bilateral hydroureteronephrosis, firstly, it is important to see what is the trimester that we are looking at and what is the anteroposterior diameter of the pelvis. So at different trimesters, there are different cutoffs for the anterior-posterior diameters. However, if there is bilateral, it requires evaluation and monitoring. We also need to look at if there is ureteric dilatation, about the status of the bladder, if it is a thick-walled bladder, if it is a persistently dilated or a keyhole bladder, and look at the amniotic fluid status. Also look for other extrarenal abnormalities that may be associated with this. These children require, antenatally also they require frequent monitoring, and after birth, depending on, like if it's a male child and we are suspecting that this is a posterior urethral valve, then ultrasound and MCU must be done as soon as possible.
Next question is, are children with CKD treated with the growth hormone supplements in practice? The role of growth hormone in CKD patients.
Definitely, there is a role for growth hormone therapy in children with CKD. But before we start with growth hormone therapy, we must ensure that all other causes of growth retardation are addressed. That is, we must address the nutritional status of the child, because often they have poor appetite, they may not be taking well. So nutrition must be adequate. We must treat other causes like acidosis, mineral bone disease parameters like hypocalcemia, hyperphosphatemia should be addressed. The PTH should be well within normal limits. Once we have addressed all these, electrolyte issues sometimes may be there in some tubular disorders. After all these issues have been addressed, then growth hormone therapy can definitely be tried. And there is enough evidence to show that growth hormone therapy in early stages of CKD has shown significant improvement, especially in the pre-pubertal age group. There is improvement in the height standard deviation scores even in the pubertal and post-pubertal, but the best effect is seen in the pre-pubertal age group.
Thanks a lot, ma'am. It was a wonderful session. It was nice interacting with you. With this, we will move on to the next session. Thank you very much. Thank you, Manikandan sir, for moderating the session.
Thank you, Dr. Sangeeta. You are single-handedly organizing a very good conference. Thank you so much.
Thanks a lot, sir. Now I invite the moderator, our young, energetic and enthusiastic nephrologist, Dr. Sandhya, to moderate the session.
Thank you, ma'am. At the outset, I would like to thank the organizers for giving me the opportunity to moderate this important session on lupus nephritis and transplantation in children.
Dr. Sandhya is, she has done her MBBS from Madras Medical College and General Medicine from CMC Vellore, DNB Nephrology from Nadir. Currently, she is working in SRMC as a consultant nephrologist. Her field of interest is glomerulonephritis, dialysis, and interventional nephrology. She was the recipient of Young Nephrologist Award for Top Clinical Science Abstract at WCN 2021. Currently part of NSMC internship class of 2022 conducted by NEPHJC. Over to you, Dr. Sandhya.
Thank you very much for that introduction, ma'am. At the outset, I would like to thank the organizers for giving me the opportunity to moderate this important session on lupus nephritis and renal transplantation in children. So without further ado, let's dive into the penultimate topic of this academic feast. So we all know that a significant proportion of SLE patients have their onset in childhood. And talking to us about lupus nephritis in Indian children will be our next speaker, Dr. Aditi Sinha, who probably needs no introduction in the world of pediatric nephrology. She's an additional professor in the Division of Pediatric Nephrology in AIIMS, New Delhi, and has special interests in the fields of nephrotic syndrome and HUS. She has been part of several important publications, including the ISBN guidelines for steroid-sensitive and steroid-resistant nephrotic syndrome and HUS management in developing countries. She will be taking us through the topic of pediatric lupus nephritis in India. Over to you, ma'am.
Thank you. Thank you very much. Thank you, Sangeeta, for inviting me along with other organizers and the respected chairpersons. I hope I'm audible and my screen is visible.
And you're audible, lines are not visible.
Even now? I'll share again.
Yes, ma'am. It's visible now.
And they are full screen now?
Yes.
Okay, so I slightly altered the topic because I thought that what we'd like to understand more about is how childhood lupus nephritis presents, what is the current management, and the Indian perspective to the management guidelines that exist as of date. So for this audience, probably everyone's very well aware about juvenile lupus nephritis, which is overall a very rare disease with very low rates of incidence and prevalence as shown on this slide. But we all know very well that in childhood, when lupus emerges, one must be careful to evaluate very carefully for kidney involvement, because nephritis is present in more than half the cases, actually develops within the first 2 years of presentation with lupus nephritis in the majority of patients, and will be present despite minor abnormalities. You might find very high grades of lupus nephritis when you undergo histopathology. More often so in the Asian perspective, also in the Hispanic and the African communities, that you would find high grades and high rates of involvement of the kidneys in patients with pediatric lupus. The importance of recognizing this are manifold. Obviously, kidney outcomes really adversely affect patient outcomes. So missing out on this diagnosis would be very, very wrong. So it would be important to evaluate these patients for this. So very quickly in a snapshot, looking at the pathophysiology of lupus and lupus nephritis, why lupus occurs is not very, very clearly understood, but we understand that there might be inherited susceptibility genes as well as environmental triggers that are responsible for recognition or kind of mimicry or some alterations such that there's impaired apoptosis of the antigens, such that there's defective clearance of self-antigen. And this leads to inflammation against these antigens, activation of aberrant lymphocytes, leading to increased production of immune globulins, inflammation mediated by both immune complexes of these antigens and antibodies, as well as complement, and lots of abnormalities, which is leading to a multisystem disease. And you can just see various parts of the inflammatory pathways that are involved in lupus nephritis. And suffice it to understand that now we increasingly understand that there are kind of 3 forms of lupus. There is a very early onset lupus, there could be a juvenile lupus, and there could be an adult onset lupus. And the more we know now, the more we understand is that both genetics and environment would interact. And the role of autoinflammation is higher in the elder population, whereas the role of genetics is more in the younger children. There could be monogenic autoinflammatory disease associated with complement deficiencies or primary interferon abnormalities. There could be in the slightly older juvenile group, there could be interaction between genetics and autoinflammatory, environmentally acquired autoinflammatory disease. And in the older patients, it might just
Ma'am, you're not audible.
I'm sorry, was I not audible?
Now audible.
Briefly or all along?
Briefly.
Okay, so okay.
They're also not visible.
Screen is not visible, I'm sorry. Do I share again? I think,
yeah.
Is it visible? Yeah. So were you with me till the prior slide? Yeah. I suppose pathophysiology, I was audible and visible there, the slides? Yeah.
Yes.
So the diagnosis has usually relied on the modified ACR criteria, but these criteria, despite their high specificity and sensitivity, have been criticized for certain reasons. And these reasons have been that these criteria might have low sensitivity in very early lupus. Patients can get classified as lupus even in the absence of neurological criteria, because you just require to meet certain number of criteria in all. You can miss, because all skin criteria were not included, so you could miss out on various cutaneous features. And biopsy proven lupus nephritis may just not be classified as lupus in the absence of certain clinical or immunological criteria. Low C3 was not really accounted for in a major way here, although it is one criteria. So then there was the SLIC criteria that came in 2012, which required 4 criteria, including 1 clinical and 1 lab criteria to be met, or the presence of biopsy-proven lupus nephritis with 1 immunological feature such as ANA or anti-dsDNA. However, herein, while the sensitivity was much higher, the specificity was lower, such that you could wrongly classify someone as lupus. And then have come in tubular criteria of 2019, which combine features of both kinds of ACR and SLIC, and have been found to have much higher sensitivity and specificity than either of the criteria, as listed in the derivation as well as in the validation cohorts in which it was tested and applied. So what this criteria requires in entry criterion is the presence of anti-nuclear antibodies. Now, these anti-nuclear antibodies, definitely it has to be at least at a titer of 1:80, preferably on the HEP2 cell line, or an equivalent titration method that has been established. And if someone does not have this qualification, they do not get qualified as lupus. And this has been criticized in certain fora as being too rigid, because patients might sometimes have ANA positivity later. Additive criteria are listed over here, and they are weighed according to their importance. And a total score of 10 is required to be met between the clinical and immunological criteria to achieve the diagnosis of lupus. One must understand that given if you find a kidney biopsy finding of class 3 or class 4 lupus nephritis alone, and you have no other feature, and you had a positive ANA, you would get classified as lupus nephritis. So these criteria are relatively sturdy, robust, and are being used now. Presentation of lupus nephritis can really vary. Most children would have nephrotic range proteinuria. Very often they would also have edema, but that is not essential. You could just have proteinuria, and that could just be subnephrotic range. Hematuria, microscopic or macroscopic, is usually present. Impaired function at presentation is actually present in quite a substantial proportion of patients presenting with lupus nephritis. Overall, we would definitely have a very low threshold for performing kidney biopsy in these patients because the clinical and lab parameters cannot reliably predict the disease class. And while it has been said that patients with class 2 nephritis should have minor findings such as isolated hematuria, non-nephrotic proteinuria, whereas those with class 3-4 would have definitely significant hematuria and proteinuria, and they may also have impaired function. And class 5 is typically thought to present with nephrotic syndrome, but this is not hard and fast. And actually speaking, the majority of patients that you biopsy in the pediatric age group would tend to have class 3 or class 4 findings on histopathology, regardless of what they presented with, and that could be just subnephrotic range proteinuria and microscopic hematuria. The histopathology, the ISN, Indian Society of Nephrology, the International Society of Nephrology, Renal Pathology Society classification, which was proposed in 2003 and modified in 2018, are used to classify the histopathology into 6 classes, and these vary from minimal mesangial lupus nephritis to focal nephritis, going on to be mesangial proliferative nephritis, going on to focal nephritis and diffuse lupus nephritis. And a type 5 is recognized, which is predominantly membranous, and there could be just a very chronic process such as advanced
You're not audible, ma'am.
Hello.
Yes, ma'am.
Where did I get lost? I was not aware.
Previous slide.
Oh, sorry. This one. So the histopathological classification. So I had just mentioned that we have classes ranging from minimal mesangial lupus nephritis to mesangial proliferation. Then there is focal lupus nephritis, and there could be diffuse lupus nephritis, that is class 4. Membranous nephritis is a slightly different process, which less proliferation and just basically deposition in the subepithelial or location globally or segmentally. And the advanced sclerosis lupus nephritis, that is class 6, is considered to be a chronic lesion which has a very, very adverse outcome. Very often we see combinations, while we most often, when we biopsy, see class 3 or class 4 lupus nephritis in pediatric lupus patients. We can very often see combinations such as class 4 and class 5, and class 3 and class 5. Some lesions are considered really pathognomonic of lupus, such as the presence of wire loop lesions. But there are also other findings that could really be very specific to lupus, and these include the deposition of immune deposits in tubular basement membrane, the presence of mesangial deposits and reticulotubular inclusions, the presence of, as I said, the wire loop lesions, that is the subendothelial immune deposits, as are shown in the H&E stain in panel 3. These would also be considered very, very specific to lupus. So some of these representative lesions are shown in this slide here. The presence of, obviously, the kind of full house positivity, that is presence of IgG, IgM, IgA alongside C3 and C1q, would be definitely considered very, very specific to lupus. I'll kind of move on quickly in the interest of time to how do we manage these patients. Management, there is very insufficient data in pediatric lupus, and what we have is primarily driven by data from adult literature. We do not have good quality evidence, and even in adult literature for certain categories, such as for class 2 lupus nephritis, because you don't perform randomized controlled trials in patients with class 2 lupus nephritis because they constitute a real minority of patients. Immunosuppression is advocated in patients with lupus nephritis of class 2, that is the mesangial proliferative lesion, only in the presence of significant proteinuria. And this has been constant across various guidelines, including the EULAR, the American College of Rheumatology, the previous iteration of the KDIGO guidelines, the Spanish guidelines, the Dutch guidelines, and the kind of Association of Rheumatology. So you can see here that most guidelines are recommending that if you have subnephrotic range proteinuria, you either do not immunosuppress or you just use ACE/ERB inhibition. In presence of nephrotic range proteinuria, these patients are treated with oral glucocorticosteroids in various recommendations. The dosing has varied from 0.25 to 1 mg per kg. And some patients would additionally also be advised to receive AZA or MMF for 6 to 12 months. And in certain cases, CNI, but this was really low quality evidence, and that is made out from the level of recommendation that is listed over here as 2, that is we suggest, and the quality of evidence shown as C or D, which is rather low quality evidence. Now, what is suggested in the recent KDIGO guideline of 2021 is that if you have low level proteinuria, you consider immunosuppressive treatment based on the presence of other features such as arthritis or oral ulcers or other, you could have neurological manifestations or hepatic disease that could guide the choice of immunosuppression or the use of immunosuppression, but not so much the kidney disease because the proteinuria is low level. Herein you only manage with ACE/ERB inhibition. In the presence of nephrotic range proteinuria, you would definitely want to look at the kidney biopsy very carefully. And herein they are also advocating not missing out things like lupus photocytopathy, which would be missed out if you were to rely just on light microscopy, which would essentially be normal, and immune fluorescence, which may or may not show deposits. But electron microscopy would definitely show photocytopathy in the form of photocyte foot process effacement. In presence of just this kind of finding, you would still go ahead and manage them with corticosteroids, but in the absence of any photocytopathy on EM, if there was only class 1 or class 2 lupus nephritis, that is minimal or no lesions or some mesangial proliferation, you would consider corticosteroids, and you may want to add on another immunosuppressive agent later as maintenance immunosuppression. But the dose of steroids used here would be lower. So this is our unit protocol that in patients who have not much proteinuria, non-nephrotic range, that is UPUC of 0.2 to 0.5, we would not use corticosteroids. We would only use it in the sense if they are required for extrarenal manifestations, and use ACE/ERB inhibition. In the presence of nephrotic range proteinuria, if the proteinuria is predominant, then we would use prednisone at 1 mg per kg per day for a few weeks and then taper it. Alongside, we would also use one maintenance immunosuppressive agent such as MMF or azathioprine for 6 to 12 months. What about higher grades of lupus nephritis? Class 3-4 nephritis have been the subject of several trials in lupus nephritis over a period of last 3 decades. And this began with the NIH study of 1986, comparing cyclophosphamide to azathioprine with prednisone versus prednisone alone. And therein they found that use of maintenance immunosuppression non-corticosteroid was beneficial. They went on to look at, people went on to look at other agents such as IV methylprednisolone, which formed the basis of using pulse immunosuppression in patients, especially with impaired renal function, and went on to use combinations of cyclophosphamide and MMF, or comparing head-to-head MMF versus cyclophosphamide for induction, and then later MMF versus azathioprine for maintaining remission, and then bringing in the role of biologicals, particularly rituximab, in the role of induction as well as in the role of maintaining remission. So this is just a timeline of the RCTs, which are increasingly relying on biologicals, including neobiologicals such as belimumab, and then use of certain calcineurin inhibitors such as voclosporin, which will come to some time. So these have been important trials, but we'll begin with just corticosteroids. What has been the recommendation on induction for corticosteroids has varied for various guidelines, but you can make out that most guidelines have advised in patients with class 3 or class 4 lupus to use methylprednisolone pulses at the onset of disease, regardless of impaired renal function. So while it was standard practice for most nephrologists to use IV methylpred if kidney function was impaired, guidelines now recommend, based on available data, that even in the absence of impaired renal function, you should go ahead and give 3 pulses of IV methylpred at diagnosis of class 3 or class 4 lupus nephritis. And certain guidelines are more conservative. They would say that if there is impaired renal function or there is definite extracapillary proliferation, then use IV methylprednisolone. But if you were to look at the guidelines of the KDIGO in 2021, then what they have considered is that you could consider using IV methylpred pulses initially for up to 3 days, usually as initial treatment, and then you use variable dosing of oral prednisone. So in the standard dose scheme, the dose starts from 0.8 to 1 mg per kg and goes down to less than 5 milligrams beyond 6 months. In the moderate dose, it starts with 0.6 to 0.7 milligram per kg and goes down to below 5 mg. And then in the reduced dose scheme, you go from 0.5 to 0.6 and come down to below even 2.5 at 6 months. So you can see that using induction with IV methylpred enables you to start with lower doses of corticosteroids otherwise and then cut down rapidly. What about other data? So in the absence of crescents, that is not very adverse parameters, the renal function is intact, crescents are not present in the biopsy, then people have also used just starting out with other immunosuppressive agents without using IV methylpred. And there have been comparisons of looking at MMF and cyclophosphamide in the context of the additional induction therapy. And you can see that recommendations have varied, but more or less what it seems to suggest is that you could use MMF or cyclophosphamide. Most of these guidelines are beginning to suggest that. The quality of evidence has risen with the increase in number of trials performed in this regard. And the KDIGO 2012 had already recommended that you can use either MMF or IV cyclophosphamide, preferring low-dose IV cyclophosphamide in Caucasians without severe disease, and considering MMF equivalent to high-dose IV cyclophosphamide on the short term. But long-term data had not been present to advise on the long-term outcomes of using MMF as the induction agent. What has guided this is more recent data as well, which is included in the KDIGO 2021 guidelines. And it suggests that you can use IV cyclophosphamide as the initial therapy for active class 3 and class 4 lupus nephritis, particularly in patients where compliance is in question. And some of this data is shown here. You can make out that you have a high dose and low dose cyclophosphamide comparisons, and both seem to have performed sort of similarly in the Eurolupus trial, despite certain differences in free from kidney failure, at least in the Kaplan-Meier. They seem to do comparably well. If you were to look at long-term data comparing the groups that have received prednisone in different dosing and IV cyclophosphamide versus azathioprine, there are small differences, and there are, individual RCTs have shown different differences, such as certain RCTs showing higher rates of relapse with IV cyclophosphamide versus higher rates of remission induction with cyclophosphamide, and so on and so forth. Looking at MMF, so MMF versus cyclophosphamide was tested as initial therapy in this study, the lupus management study, the ARM study, and there have been studies that have been performed for use as induction therapy as well as for maintenance therapy. And while it was designed to show superiority of MMF to IV cyclophosphamide as induction therapy, that superiority was not demonstrated. However, comparability was demonstrated. If you were to look at in the follow-up period, that is in the maintenance phase, which performed better, MMF versus azathioprine, the data seems to suggest that MMF might be superior to azathioprine in maintaining a renal response and in preventing relapses in patients with lupus nephritis. So if we were to look at all these studies meta-analyzed together, comparing between MMF and IV cyclophosphamide, overall, there doesn't seem to be remarkable difference in terms of mortality, in terms of rates of kidney failure. In terms of complete renal response, there seems to be some difference such that favoring cyclophosphamide usage, but in terms of renal relapses, there seems to be not much difference. Another agent that has been examined more recently has been tacrolimus, and tacrolimus in particular forms part of even the induction protocol in certain areas, particularly in, say, institutes such as Singapore, NUH. You would definitely have a triple drug immunosuppression happening at the beginning, and then you take off one drug after the other. If you were to look at the additional use of tacrolimus, there seems to be some suggestion that the rates of complete as well as partial remission are better if you were to add on tacrolimus to the induction regimen. So multi-target group seems to have, however, have good response rates, but they might be at risk of some serious adverse events compared to users of IV cyclophosphamide. However, given that the data is limited, the heterogeneity between studies is high, only 2-3 studies are there in this regard, there is not much evidence to guide the use of tacrolimus. But this is what lupus nephritis multi-targeted therapy has comprised of when used in, say, Dr. Yap's unit at Singapore. You would have pulse methylpred given at the beginning, add on MMF, and then if patients persist to have high-grade proteinuria, but renal function is intact, you add on a calcineurin inhibitor. Having induced remission, you take off the calcineurin inhibitor and continue MMF, and by that time, you would have tapered your prednisone and made it on alternate. So it allows you to cut down prednisone rapidly. It allows you to induce remission in the majority of patients. That has been their experience. So a meta-analysis suggests that complete remission rates, as I said, were higher with the additional use of CNI. Meta-analysis between MMF and cyclophosphamide. Overall, there is some concerns that MMF, while superior or equivalent to cyclophosphamide, particularly in regions such as ours, there's always issues of compliance. Compliance is guided by oral twice-daily dosing for MMF in a high dose for a costly medication versus IV cyclophosphamide administered at certain intervals in the hospital under supervision. So compliance is definitely better for IV cyclophosphamide in our context. The rates of GI intolerance and leukopenia might be higher with the high doses required at induction for MMF. There is not enough literature in children, and there is not enough follow-up data certainly for use of MMF. So overall, and as I said, TAC plus MMF, we don't have enough data, but it might be better in inducing remission. So what does the KDIGO recommend now? That you, in patients with 3 or 4 nephritis, you can use either agent in combination with corticosteroids. This is what their algorithm shows, that in absence of thrombotic microangiopathy, which is dealt with separately, you was to start with corticosteroids, which would be 3 pulses of methylprednisolone, 1 to 3 pulses of low-dose methylprednisolone, add on prednisone afterwards, not to exceed 80 milligram per day, not to exceed 1 milligram per kg per day, and taper over a few months to a small maintenance dose of 2.5 or 5 milligrams. You can either use MMF or cyclophosphamide for up to 6 months, MMF for about 6 months at least, and in certain settings, such as I explained to you in the Singapore context, very often directly patients might be getting tacrolimus. as an add-on. So you can see the choice is kind of you have a boutique choice. You could have any of these agents being used. So it doesn't give you very firm guidance on what policy to follow. They also leave it open that you could try belimumab or other targeting biologicals, and I'll come to that shortly, at the onset as initial therapy, as alongside MMF or IV cyclophosphamide as well, and or consider rituximab in patients with refractory disease. In presence of class 5 lupus nephritis, I'll quickly go over in the interest of time. Patients with any class 5 lupus nephritis, given the proteinuria, you would definitely use ACE inhibition. But in the presence of nephrotic range proteinuria, you would add on immunosuppression. And again, this is kind of very general advice that you would use one other agent. It could be MMF, cyclophosphamide, CNI, rituximab, or azathioprine, and you'd also use hydroxychloroquine. If proteinuria worsens or complications of proteinuria develop, one could move from one immunosuppression to another. So what do we do? What we would do is we would initiate therapy with IV methylprednisolone pulses, and we would use about 30 milligram per kilogram, maximum 1 gram for 3 days. And in presence of impaired function or in presence of high proportion of crescents in the glomeruli, we would go up to 6 days. We would then add oral prednisolone and then taper it down to about 7.5 to 10 mg by 6 months. So we do stay higher in our dosing than the KDIGO regimen, and probably we are treating our patients more aggressively or more immunosuppression is being practiced than is probably at other centers, and probably we should look to kind of coming down this a bit. We would taper it a bit slowly in patients who continue to show disease activity in form of impaired in presence of hypocomplementemia or elevated anti-DSD titers. Induction regimen, we tend to use more IV cyclophosphamide than MMF, because the MMF dosing is about 1.2 grams per meter square per day. And then we would definitely prefer cyclophosphamide in presence of impaired function or in presence of cellular crescents. Maintenance therapy, again, guidelines have differed and have given options of azathioprine and MMF in the past alongside low-dose steroids. And in patients who have not responded to MMF, add-on calcineurin inhibitors, and then later take off one agent. What about overall, what do studies have shown between MMF and azathioprine? Overall studies seem to suggest that MMF might be associated with lower relapse rate and as well as lower rates of leukopenia. There seem to be no differences between the two agents in terms of their efficacy in terms of long-term data of kidney failure and mortality. So what is the recommendation by the KDIGO is that after initial therapy, you start either, you would prefer using MMF because of its better safety profile. You would definitely prefer MMF or its analog. In patients with some individual indications where intolerance to MMF is there or cost is an issue, you might consider azathioprine. And if either is not tolerated, you could consider use of tacrolimus or cyclosporine. So overall, the intent of the KDIGO guidelines suggestion about maintenance immunosuppression is that glucocorticoids should be tapered to the lowest possible dose during maintenance therapy, unless it's useful for other extrarenal manifestations, and try to get them off corticosteroids beyond 12 months of complete clinical response. MMF, definitely you would use in a high dose in the induction period, and later you would come down on the dose. So what do we practice? We would have prednisone and MMF as our preferred regimen, and prednisone and azathioprine as our less preferred regimen, where cost or intolerance to MMF is a concern. Total duration of immunosuppression has been another question which has not been looked at very carefully in long-term data from RCTs, because RCTs are not on the long-term. So these are again choices, but overall it seems that for proliferative lupus nephritis class 3, 4, or 5, you would not want to treat them for any less than 3 years. At least 3 years of immunosuppression is essential. Obviously, you have would have to assess response and continue to monitor. And patients who continue to have renal flares would require longer immunosuppression. What about response determinants? How do you decide on who has responded and when? So complete remission has been defined as reduction in proteinuria to below 0.5 gram per gram in the protein creatinine ratio, or negative trace consistently on dipstick with improved or stabilized kidney function. And this should have occurred within 6 to 12 months of starting therapy. This time point seems to be very, very far off from onset, but this is how it has been defined because lupus nephritis patients continue to show quite a lot of proteinuria well into induction. A partial response is 50% reduction and below nephrotic range, improved kidney function. Am I audible? And inability to achieve either a partial or complete response would be considered no kidney response. So why is this important to recognize? Because patients who do not have either a complete or partial response by say 1 year of therapy, of initiation of induction therapy, tend to have a very poor renal outcome and systemic damage. And this is data on the long term that has been shown on the Kaplan-Meiers. So we would define response similarly, but in children, we would kind of, we go by UPCRs, and definitely the creatinine should have returned to baseline. And refractory disease, we would kind of define at lack of partial remission at 6 months or lack of complete remission at 1 year. Any worsening in kidney function beyond 3 months of treatment or 2 disease flares within 2 years of starting therapy would also be considered refractory. So when would you reassess for improvement? So definitely we know that complete remission will take a long time, but at 3 months, definitely there should be improvement and certainly not decrement in renal function, decrease in renal function. The proteinuria should not have worsened at 3 months. At 6 months, there should be a partial response, and at 1 year, there should be a complete response. So if you don't have a partial response at 6 months, you're worried, and you might consider adding tacrolimus to what MMF or other immunosuppression that you're using. And in presence of patients who are really showing worsening or have impaired renal function, we would definitely want to consider other options such as treating it as a flare with IV methylpred or switching over to IV rituximab or MMF if you were on cyclophosphamide. So what about CNI use? What does KDIGO say? Given the recent literature on voclosporin compared to placebo showing good rates of response, complete renal response, and low rates of similar rates of serious adverse events as standard immunosuppression, voclosporin seems to be a good option in patients who have preserved renal function at baseline, and it can be considered as an additional agent to use alongside the MMF-based induction regimen. Refractory disease, the data is not very consistent on what you would want to do, but basically if you're on IV cyclophosphamide-based regimen, you could move on to MMF or vice versa, or consider rituximab has been the consensus across various guidelines. What about rituximab overall? What has data shown? Data has been very, very mixed bag, but it has been overall encouraging. If you look at initial RCTs where rituximab versus placebo was compared in the Explorer study and the Recurrent Rescue study, there were variations in, there were different outcomes. If you look at the LUNAR, there was not really much difference in the complete or partial remission rates when rituximab was compared to placebo. In the Reduxil Lupus trial also, however, there was Ritux induction and MMF maintenance. There was a very high rate of complete and partial response. Overall, there is emerging role for biologicals, and rituximab seems to be a good agent to use in patients with recurrent renal flares or persistent disease activity. So another agent that has come up is belimumab, which acts on the BLyS, that is another antigen on the surface of the B cells, and it can be considered as an additive agent in the treatment of active lupus based on the recent data on the study on belimumab, wherein belimumab had improved rates of complete and partial response as compared to standard immunosuppression. So how do you treat refractory lupus nephritis? We don't have very great options, but we would probably consider any of these. We would consider use of pulse steroids, particularly if renal function has fallen. We would switch away from the cyclophosphamide to MMF or from MMF to vice versa. If already have gone on to done this switch at 3 months and at 6 months, you're again worried about refractoriness, you could consider adding rituximab or consider adding tacrolimus. So rituximab dosing is, at least in our unit, in lupus patients, we would do fortnightly at double the dose that you would use for nephrotic syndrome patients. Very, very rarely you would consider plasmapheresis in patients with refractory disease or with flares who have particularly a suggestion of thrombotic microangiopathy. So what does the KDIGO recommend about monitoring for remission and further monitoring? If you have a lupus relapse, then you would probably again go back to the same initial therapy, that is induction with IV methylpred or oral prednisone to achieve the original response. or an alternative approach. So you definitely look for compliance, you ensure adequate dosing, you might need to consider a biopsy, and you might need to consider switching away from the first induction agent to the second induction agent. And or, as I said, you could consider addition of rituximab or other biologicals, or extend the course of therapy. Frequency of monitoring in our units, we would definitely want to monitor them very frequently. So definitely at 1 to 3 monthly intervals, we would be looking at these parameters. And as time goes by, you could switch away from 1 monthly to 3 monthly, and then on to 6 monthly visits. How do we treat our renal flares? If there is a very mild flare, we would just kind of treat them with stepping up the dose of steroids. Moderate flare as well. But in severe flares, we would want to consider use of IV methylprednisolone and or increase the dose of maintenance immunosuppression. So this is just minor practice points of the KDIGO about pediatric patients, similar regimens to be used as for adults, but consider pediatric issues. Patients who go on to kidney failure would have to be managed with any advanced chronic kidney disease method, and you might want to consider withdrawal of immunosuppression. I'll just, in the interest of time, kind of skip these slides because I think we have already exceeded our time. And I'd just like to share some Aliza's paper from Jodhpur, wherein she has just summarized the pediatric cohorts from India, indicating similar profile of pediatric lupus nephritis patients in India, as has been published internationally. And these are some large series from India, which show similar data on kind of presentation and outcomes as in the West, and makes for an interesting reading for anyone who's interested in reading more on the topic. So I'll just close with these summary points. Pediatric lupus nephritis is common in patients with pediatric lupus. It is a tough disease to manage. High-grade disease is common, and long-term management is required, comprising of induction and maintenance phases to induce and maintain remission. Remission is an important parameter indicative of good outcome. You might need to treat flares or refractory disease with further immunosuppression, including biologicals, which seem to have an improving and emerging role. Frequent and long-term management is very, very important. Thank you.
Thank you very much, ma'am, for that very lucid presentation. In the interest of time, we'll be moving on to our second speaker, Dr. Roshan George. I will answer the questions at the end of this session. We'll deal with the questions from both the sessions at the end. Is that okay, ma'am?
Yeah, sure.
Yeah, yes.
So after that enlightening first talk, let's move on to our second speaker of this session, who will also be finishing the CME, Dr. Roshan George. So as nephrologists like me, who predominantly deal with SRD patients, we look at children almost like small adults, but we know there are certain problems with pediatric transplant that are unique to children. So Dr. Roshan George will be taking us through this important topic of pediatric renal transplantation. She is an associate professor in the Division of Pediatric Nephrology at Emory University in Atlanta, and has vast expertise in the field of renal transplantation and transplant immunology, as well as interest in medical education. She is currently serving as the director and chair of committees within several prestigious organizations, including the American Society of Pediatric Nephrology and the American Society of Transplantation. I hand over the floor to Dr. Roshan George for the final topic of this CME.
Thank you so much to the organizers for this invitation, and especially to Dr. Sangeeta. I am thrilled to be here. I am trying to share my screen here. Excellent. Are you able to see my screen?
Yes, Dr. Roshan.
Very good. Thank you so much. So I'm going to talk today about renal transplantation in children. I have no relevant disclosures for this talk. My objectives today are to talk about some differences in pediatric and adult kidney transplant, summarize management of unique issues in pediatric transplantation, and review future directions. So from a historic standpoint, we should all realize that even though kidney transplantation is something that we talk about in a very regular manner, it is not a very old technique. It's been just about 7 decades or so that this all started. And the first kidney transplantation in 1935 that was done was met with rejection because at that time, the awareness of even immunologic mechanisms underlying this was not there. It was not till 1945 when P.B. Medawar looked at skin grafts in animal models and found that there was an immunologic mechanism underlying acceptance of self-skin graft. This led to further identification of MHC complexes such as HLA antigen. And then finally in 1954, the first successful kidney transplantation occurred, but this was also in identical twins. So the immunologic barrier was not broken here. The main advances were with medications, immunosuppression. As you can see, in the last several decades, we have gone from the initial Imuran, which was one of the first drugs after corticosteroids, and then into more advanced CNI medications. And now we are coming up to co-stimulation blockade. And so we'll jump on to the unique aspects of pediatric kidney transplantation because even as the history is not that far away from the first kidney transplant, the pediatric kidney transplantation world is seeing advances in the last few decades. So as we all say in the pediatric world, children are not small adults. There is immunologic immaturity and differences in the primary cause for end-stage kidney disease. We also have to keep in mind the growth and neurocognitive concerns in younger kids, as well as thinking about urologic causes and different comorbidities as compared to adults. Preparation for transplantation is also slightly different because there is a whole set of caregivers and safety net involved in these patients. We have to think about immunization, and their psychosocial factors also play a key role as they are also dealing with school and other growth related issues. Surgical factors obviously are different because the smaller kids are size differences in the allograft with the kidney, with the patient size, and then absolutely, given the immunologic difference, there's more susceptibility to viral infections. Drug metabolism and post-transplant complications are also different. So going into a very brief understanding of the immunology related to transplant, we know that the HLA class 1 and class 2 plays an important role. HLA class 1 is there in all nucleated cells, A, B, and C, and class 2 in certain cells such as antigen-presenting cell that you have HLA DP, DQ, DR, and these are present on short arm of chromosome 6. As I mentioned before, with cross-matching, we have come a long way with initially preventing acute rejection. And there are several methods of cross-matching that have moved forward through the decades. Initial method, which was cytotoxicity based, was cross-matching where you took T and B cells and incubated that with the patient's serum. And if this T and B cell had a HLA antigen, and if the patient's serum had antibody in it that would bind to this antigen, a complement would be added and this would be incubated. And if there is antigen antibody binding, the complement will cause perforation in the cell membrane, which will cause the dye to enter in, and you'll see the reaction in this form. Now, this is a non-specific form of cross-matching, as antibodies that are present for other antigens can also cause this reaction. So we moved on now to flow cytometric cross-match, where again, a T or B cell, which has the HLA antigen, is then incubated with the patient's serum. And then a secondary antibody, which is fluorescent bound, is incubated with that. And if there is antigen antibody reaction or aggregation, then there will be a channel shift in this fluorescent intensity based upon the secondary antibody. We have become even more specific by using solid phase HLA antibody detection assay, which are microspheres which have single beads which have the specific HLA antigen on it, like HLA-A2 or HLA-B2D7, etc. And here the same mechanism happens, and if there are antibodies in the serum of the patient, there will be the response that happens, which identifies with the shift of fluorescence intensity, which specific antigen it is. And this has been really helpful in matching up patients correctly, and that reduces acute rejection. Now, the panel reactive antibodies are what are present in the population, where we are trying to estimate the likelihood of a positive cross-match to a panel of potential donors in that area or the community. And here again, different assays can be used to determine PRA, complement cytotoxicity assay, ELISA, or flow cytometry. What is interesting to note is that we have become even more detail oriented with this now, with more and more studies talking about epitope or iplet matching. These epitopes are basically configuration of amino acids which are either in a linear sequential pattern or clustered together, which also have antigenic potential. And there are studies showing now that if there is iplet mismatching, that can also result in donor-specific antibodies. So coming a long way from the initial cytotoxic cross-matching, coming to more minute and more specific ways of matching our patients who are recipients to potential donors. Now, in the pediatric population, what is really important to note is that pre-operative planning is essential. The preparation and making sure that they are ready for surgery, especially with fluid management, electrolyte management, is key. Perioperative fluid management is also different from adult population, because here we are really looking to avoid tissue hypoxia and keep them on the side of being a little bit volume overloaded. And you are trying to make sure that there is not a vast decrease in blood pressure as they get perfusion of the allograft. And there are various methods of monitoring during surgery. None of these are very specific or accurate. So it's important to use multiple measures in these pediatric population and keep them at a little bit of a volume overloaded side during surgery. Now, early complications in the post-immediate period after the surgical procedure include hypotension, as I mentioned, because of the mismatch of the donor kidney size and the pediatric patient size, electrolyte abnormalities, delayed graft function, renovascular complications such as thrombosis, which could be devastating, ureteric and surgical complications, and obviously rejection. Importantly, with the immunologic changes with age, it's important to realize that we have this dynamic process happening in this age group. As the thymic immigrants reduce as the baby is born, as well as increased infection that is seen by these cells, you see that initial naive T cells, which have a vast repertoire of diverse responses, shrinks as the patient ages, and there is increase in memory T and B cell. Now, we looked at this within our group and saw that in our patients who were on dialysis or even with CKD, not on dialysis, had a higher in number of memory T cells, which were CD28 negative, meaning that the response rates were different from what you would assume in an older middle-aged adult. So it's really important to keep that in mind, that our patients have a larger spectrum of their immune T and B cell phenotypes. Now, the T and B cell phenotypes are important to think about because that is where our primary immune modulation or immune suppression works. As we know, the T cell interacts with the antigen presenting cell, and here the antigen is presented by the APC, and this binding with the T cell receptor causes signal 1. Signal 1 needs to be potentiated with signal 2, which is after there is interaction of CD28, which is on the C cell, with the antigen presenting cell CD80. And this potentiation causes downstream response in the calcineurin pathway, MAP kinase pathway, causing expression of CD154 and CD25. Now, these ones that we have with this interaction causes signal 3 to come when there is binding of interleukin 2, which leads to further downstream cell maturation and division, leading on to T cell proliferation. Now, as you recognize probably, these are all the pathways that are immunosuppression targets. So going into that, we see that We have induction and maintenance immunosuppression. Induction immunosuppression is given perioperatively, and we are looking to suppress the T cells and then sequentially bridged on to maintenance therapy. Maintenance is usually by combination therapy, and we try to dose taper over time, specified to the patient's condition. Now, when we are talking about induction therapy, there are polyclonal agents such as thymoglobulin or AdCam, or monoclonal agents, and now we are more and more using specific anti-IL-2 receptor blocker, which are chimeric monoclonal, Simulect or basiliximab. Maintenance immunosuppression has a lot of different classes. The most commonly used are calcineurin inhibitors, cyclosporin or tacrolimus, antimetabolite agent, mostly MMF or mycophenolate mofetil now. mTOR inhibitors can also be used, and steroids are the mainstay of many of the regimens. Now, as I mentioned before, these are always used in combination, but it is important in smaller kids to make sure that we try to customize it and try to minimize or avoid steroids as much as possible to help in growth. And streamlining of medications is important to increase adherence. As you can see, this is actually a picture of one of our patients. This is my research mentor's hands. He's holding all the pills that the patient has to take. And as you can see, for a small child who is 7-8 years old, this is a vast number of pills. And so it's important to make sure that we are streamlining medications, customizing it, and monitoring really closely for side effects. Now, another area where there is a huge difference between pediatric and adult population is primary cause of end-stage kidney disease. And as you can see, the congenital causes are commoner in younger kids, and as the children increase in age, more glomerular and acquired causes such as lupus nephritis and FSGS becomes prominent. Post-transplant, we have to deal with a lot of complications. In the short term, I had mentioned initially right after the surgical procedure, but long-term complications are also something that relates to all of the differences in the immune system related to rejection, infection, malignancy. Cardiovascular causes are really important to consider because this is one of the most common causes of mortality even in this young age group, and effects of growth and psychosocial changes after transplant. Infection, really, as we know, I've listed some here, but UTIs are really important in these patients. And so preparing the bladder, even pre-transplant, to make sure that they have the best milieu to put the allograft in is important. But even post-transplant, making sure that these patients, if they have recurrent UTIs, are placed on prophylaxis is key. BK virus is something that was identified in 1971 and really something that affects a lot of these transplant patients once they're immune suppressed, and treatment for this as well as other infections starts with reduction of immunosuppression. We have also used leflunomide and other agents, and the classic finding is intranuclear infusion bodies that you can see in these patients. CMV, universal prophylaxis, is really important. The first 6 months post-transplant, we do prophylax our patients. EBV, something that is also key to monitor. We monitor it very closely after the first year of transplant, and then later on to make sure there is no risk for PTLD, which can be driven by EBV. Malignancy overall, thankfully, compared to adults, is a little bit less, but it's quite devastating in these younger kids. So thinking about even some common things such as skin cancer and PTLD, of course, incidence of 1 to 2% linked to EBV infection and is increased with higher levels of immunosuppression. Obviously, reducing immunosuppression is the first step, but many of these patients will require chemotherapy. Growth, as Dr. Nivedita very nicely mentioned with CKD, there is significant growth failure that can happen prior to transplant, and these kids can be less than even 2.5 standard deviation of height. As she also mentioned in the Q&A session, that it's really important to correct a lot of the other underlying causes, such as electrolyte abnormality, acid-base status, but providing and consideration about good nutrition and recombinant human growth hormone supplementation is something to think about. Many of these kids actually recover height once they are transplanted. This was a nice retrospective study looking at the height, velocity, and comparison of growth with normal population kids. And this is renal transplant kids who were transplanted right before puberty. And as you can see, they do achieve some increased height and catch-up growth after transplantation. However, as as you can see, some of them do end up having less height than their peers after several years down the line, even with transplantation. So it's really important to make sure that the growth is monitored, supplementation given as appropriate, and also thinking about the psychosocial aspect of the loss of height these children experience, because that can lead to lower self-esteem. Neurocognitive development is also key to note. Also, as mentioned before, these children do have CKD-induced effects on their brain development. This was a study that was published in 2018 looking at cerebrovascular blood flow and all the areas of the brain in a patient, in a pediatric patient with CKD, showed higher blood flow, signifying a mismatch of cerebrovascular perfusion and abnormalities there. Several studies, including those done in large population of CKD patients, which is a multi-center database, shows that there are lower scores in certain cognitive metrics for these patients. So it's important when we are thinking about transplant that these neurocognitive dysfunction may continue, especially if transplantation happened late. So important to identify these CKD patients early. And so to summarize management of these unique challenges, it's important to note that we have come a long way. This is data from a European center looking at basic survival of kidney transplantation compared to between pediatrics and adults. And the adults are in a green line. And as you can see, the cumulative survival and the graft survival overall is better in pediatric population. However, as you can see, it also comes down as compared to their normal age peers, and their overall survival is not good as the normal population. So we still have some ways to go. The biggest issue happens when patients are transitioning from pediatric to adulthood. And there are several studies that show that that age group, especially the ones 12 to 17 years, as shown here, actually do much worse than patients who are transplanted earlier in life. And if you look at this graph, the 12 to 17 years in this yellow light area, are the second worst when compared to outcomes after 10 years post-transplant, when you compare to over 65 years old who have a lot of comorbidities. So this age group, 12 to 17, should not be doing theoretically as bad as the much older age group, but they do just because of that changes that happen during this emerging adulthood. So really what is key is providing a lot of support to that age group, especially as they are transitioning from pediatric to adult side, and close communication with your adult colleague. Early identification of CKD is really critical. Catching up on immunization prior to transplant reduces risk of infections later on. Collaboration with other specialists, including fetal-maternal specialists early on, even from the prenatal times when you know that a child may be born with abnormal kidneys. Other specialists such as urology, transplant surgery, and your adult colleague. Close monitoring for immunosuppression, attention to growth, nutrition and development, and careful transition to adults. What's really important, again, as has been touched upon, is to make sure the patient and their families are part of this shared decision-making, because at the end of the day, we can write the best medications and it'll look great on paper, but as long as the patient is not on the same team and the parents are not supporting this care, the real world impact of all of our innovations are useless. So we need to make sure that we are all working as one team. So future directions, it's really exciting to know that although we have come a long way, there is still ways to go. There are, like I mentioned, during the adolescent years, a lot of loss to follow up that can happen. So that is a gap that we can fill, and hope that when this transition between institutions happen, when we looked at SRTR data, up to 50% of our patients who transitioned were lost to follow up when that change happened between institutions. So close collaboration with the transitioning recipient institution is really important to make sure that these patients continue to get seamless care. Newer agents are now coming up, belatacept, something which is a co-stimulation blockade, like we talked about earlier, where the signal 2, where CD28 and CD80 in the APC is attached, that signaling is blocked by belatacept, which is very similar to abatacept, but we are now using belatacept in select pediatric population in our center. And this long term is, we are hopeful that will reduce our transplant glomerulonephropathy. There are several other newer agents that are helpful in treatment of rejection, as you can see here, eculizumab, bortezomib, which have also been coming up. And this is something which is a talk in itself. So I'll just leave that here. As you probably have all seen, newer gene editing and xenotransplant procedures have been coming up, where edited pig kidney was transplanted to an adult person in Maryland, Baltimore earlier this year. Unfortunately, the patient just passed away in March. However, it is a key step. And we know that even if we are not thinking about transplanting a whole kidney, even thinking of gene edited cells to think of some specific aspect of challenges such as treatment of viral diseases could be something to think about in the future. So towards the end, I'll just say that we have come a long ways, but still everything has been in the last 6-7 decades. So there is still a long way to go, especially for our pediatric patients. It's really important to have immune monitoring, risk stratification, and some ability to individualize medications. These medications are all expensive, and I understand that the access is difficult also in certain areas. So it's important if we can customize medications, minimize them. Not only does it reduce side effects, but it's also important to minimize cost, which is sometimes exorbitant. So with that, I will stop here. I welcome questions. I have my email there as well as my Twitter handle. If anybody wants to reach out to me, you are welcome. And again, thank you so much for this opportunity.
Thank you very much, ma'am. That was a very clear presentation. I have a couple of questions, ma'am. How do you deal with the psychosocial aspects of kidney transplant in children, especially as they grow? And as a corollary, how do you deal with compliance to medications in them?
Yes, that's a very important question. And, you know, we have been fortunate to include psychologists as part of our CKD and transplant team. And I think they play a key role from the very beginning. I think even pre-transplant, it's really important to make sure that there is expectations that are set for the patient and the family, especially if it's an older patient. Also, we want to make sure that we are providing other support, because a lot of the times these pediatric patients are not just looking at that kidney health, they are actually looking at their life. So school support, making sure that their peers understand what is happening, and also making sure they have pathways to succeed outside of this medical arena, because if they are succeeding in life, they feel motivated to do better with their kidney medications. And obviously really working with them with side effects of medications, because it's obviously there are some medications they have to take, but as much as possible, minimizing medications that can cause side effects is really important. So we really partner with families.
Thank you, ma'am. There's one more question on your experience with mTOR inhibitors in children with cystic kidney diseases.
Yes, so we use mTOR inhibitors for even post-transplant in some of our selected patients who do not have glomerulonephritis or proteinuria causing conditions. After 6-month biopsy, we do protocol biopsies at our center, and if the 6-month biopsy does not show rejection in that particular patient population, we do place them on mTOR inhibitors just for long-term outcomes, because to avoid CNI toxicity. Specifically with cystic kidney disease, I know the data is not that clear, but there is some benefits to mTOR inhibitors. So depending on how those patients fall after transplant, that is one other group that we would consider it on. Immediately after transplant, obviously you don't want to do mTOR inhibitor because it inhibits healing and can cause really significant surgical wound related complications. So you do want to wait for several months before you start it after surgical procedure.
Dr. Sangeeta has a question about transition from pediatrics to adulthood, which is really difficult for CKD patients, especially for the parents. So she asks about the prospective steps for that to avoid losing them to follow-up.
Yes, that's a really key point and a big gap. I think everywhere we do take care of our patients up to 21 years of age. So it's like almost into the adult age that are considered pediatric here. But we have a pediatric transition program where we take them early on. So after 14 years, and you can kind of extrapolate it into whatever age group works best, because it is recommended that 12 years onwards, kids be very much involved in their own care. What we have found is that giving them small skills to conquer as they grow older, remembering to take their own medications, but having the support of their family members to make sure they are just not being completely left independent and then, finding out 2 weeks later that they've not taken any of their medications. So, it's a collaboration between them and the family members. But I have also found personally that close collaboration with our adult colleagues who would be taking care of these kids later on is very helpful, and letting the patient and their parents know that the communication between you and the adult team is happening actually helps a lot, because I think that is where loss to follow up is the biggest issue, because the adult and the pediatric teams are not talking and then they just kind of get lost. So that is also key on our side that we could do.
100% agree with you, Dr. Roshan. That's more important. Yeah.
Yes.
I have one question, ma'am. Do you routinely practice steroid-free transplants in children or early steroid withdrawal? No.
So at our center, we had tried it almost a decade ago, and had seen a lot more rejection in our patients. And when we tried thymoglobulin for this, that is the patient who have this steroid withdrawal, many of those patients ended up having PTLD. So for our personal experience has been, we do minimize steroids, but we are not completely withdrawing. However, I'll say the caveat is that several centers do complete steroid withdrawal protocol and complete or no steroids from the beginning after they select and give thymoglobulin to these patients, and they have been very successful and show great results with improved height velocity, improved blood pressure metrics. So I am open to saying that this is a very good strategy to consider in centers that have good experience with it.
We have one more question from Dr. Subhashri. She's asking about the TAC and cyclosporin levels in pediatric transplant. Are the levels similar to that in adults, or is there any difference in the levels?
That's a great question. So the metabolism can be very different. We do target higher levels early on after transplant, and the level targets kind of reduce as they go on. So from 7 months onwards, we target lower levels, which are similar to the adult targets for tacrolimus, which we do like 5 to 7 nanograms per ml. So we have a little bit higher targets early on after transplant. And cyclosporin is also similar to that. However, we are not using much cyclosporin now in pediatric patients here anymore.
I think we don't have any further questions for you, ma'am. Thank you very much for that presentation.
Thank you.
And logging in from a different time zone.
No worries. Take care. Have a good evening, you all. Bye.
Thank you, Dr. Roshan. It was a great pleasure to have you here. In spite of your busy schedule, you could able to make it. Thank you very much.
No, I appreciate the invitation. It was wonderful to be part of this. Thank you. Bye-bye.
Bye-bye.
Dr. Aditi, I think, ma'am, you have answered almost all the questions in the chat box that had been asked regarding the indications for rituximab and the indications for plasmapheresis. Ma'am, I had one doubt about flares in childhood lupus nephritis. Are flares more common in the childhood population, especially in the Indian children compared to adult population?
I think so, although I don't think there is enough firm data on this. But yes, pediatric lupus is overall considered more difficult, particularly with lupus nephritis. I suppose infections, non-compliance, these would be reasons for more flares happening in developing versus developed countries, because infections could be triggers for the same. So yeah, we do see, but I mean, fortunately with frequent monitoring and with compliance adherence, it's not such a big problem for our population. I mean, like, it's obviously, I can't put a number to it, but I think that it's still considered to be like not so common. Yeah.
Given the potential for cumulative immunosuppression exposure in children, how long do you give the maintenance immunosuppression in the childhood population? Is there any data, or do we just follow the within 36 months?
Yeah, depends on the kind of disease. So at least 3 years, as we have written in our protocol also and shared on the slide, and very often 5 years it would go on. We do know that they will carry on with having lupus in adulthood also, because they'll require monitoring. So yeah, you'll have to continue to monitor them even after we stop immunosuppression.
Okay. I think there were no further questions, and you had already answered all the questions. Thank you so much.
One more doubt I have, ma'am, to Dr. Aditi. The dosage here is 750 milligram you have mentioned. Are you seeing any adverse effects because following rituximab, they are at risk of getting infections?
No, actually no. But you could have a variety of protocols. People will also do 375 per meter square weekly for 4 weeks. Sometimes people would do 2 weeks, but I mean, somehow there is an impression that maybe there is less good outcome with this 375 than with 750. So most lupus protocols worldwide would be 750 and fortnightly. So 2 weeks apart, 2 doses, like 2 big doses. Yeah.
Okay. Thanks a lot, Aditi ma'am. In spite of your transplant today, you could make it.
That's fine. Yeah. Thank you.
It's a pleasure to have you here.
Thank you to allow me to participate. Thank you.
Thank you, Dr. Sandhya, for the wonderful moderation and interactive session.
Thank you very much, ma'am, and for pulling off this really commendable CME with so many dignified speakers. It was an honor being part of this session, ma'am.
Thank you very much. Having come to the end of the very interesting and interactive academic session, I'm here to say my vote of thanks. It was a wonderful program. I thank our HOD, faculty's Department of Pediatrics for the cooperation in organizing this webinar. I express my gratitude to IAP team for providing the online platform, and special thanks to Dr. Tirumurugan. I thank all the moderators and speakers for their enlightening talks and discussions on various topics in pediatric nephrology. I thank all the delegates for their active participation. Thank you, one and all.